And then...
I'm going to hang up with you on the phone, okay?
Okay. Can you hear me? Hello?
Can you hear me, Dr. Woodard? Can you hear me okay?
Can you hear me?
Yep. Can you hear us?
Yeah, sounds great. Let
Hi.
me do this so I look more professional. Okay. I don't like this too. Okay. All right. So will it appear right there behind you or no?
Yes. Yes. So right now you don't see it on the big screen because we're just testing it through Chris's laptop. But as soon as we'll get the same view that you have there on Dr. Chang's laptop once he sets that up. He's in process.
Hold on. Now, what if I do this? What do you see? The presenter view or the
we see a normal view then, and it looks good.
So it looks like, okay. All right, so you can't see the presenter view, right? You just see one slide.
Right.
Disclosure.
Correct.
Okay. All right, cool.
Are you happy with that?
Yeah, because that way I can see on the other slide. I mean, I have another screen that allows me to see the what's coming next. So I can plan my transition statements and stuff.
I can understand why you'd want to see that. And Chris, can we still see Dr. Woodard's face? Will you hold on 1 second, Dr. Woodard? I want to run over to Chris's laptop.
What's up, Eugene?
Hey, good morning, man. How are you?
Good.
Good. Oh, yeah, I do, actually.
I think that looks good. We see exactly what we need to see.
You see me and the screen?
We do see you.
Oh, okay, that's good.
You're not used to hearing this, but you look very, very small, so we're going to fix that.
Oh. So I'm kind of rusty, so I like to usually throw a few jokes in there, so they may I don't know how they're going to land.
I've witnessed this before, and I think it goes over very well.
All right.
I like it. Joke away, sir.
All right. Well, and I think probably because it's usually in the evening when everybody's had a few martinis.
They'll be all ramped up on caffeine for you this morning.
All right. Well, cool. So, all right. Yeah, I just wanted to test that. And I guess say if during the presentation, if it's something, you can just let me know if you're seeing the presenter view or the regular view. How about that?
Yeah.
Oh,
that sounds great.
There you go. So let me try it again. I like that. So you're probably seeing the presenter view right now, right?
Well, that depends on Zoom.
I think. Oh, I gotta mute yourself.
There we go. Perfect. All right. And then can you make those little side boxes any bigger? The people are talking. Nice. Yeah.
But you guys disappeared. I wonder how I can do that.
Yeah, once he shares his screen again, as he talks, his face will show up in there.
I love it.
Yeah.
That looks nice. What do you think, Dr. Chang?
No, I think it looks great.
Okay, we've made you almost life size, Dr. Woodard.
What'd you say?
I said we've made you almost life size. It's like you're.
Oh, geez. Should I share my screen again and see what it looks like?
That'd be great.
All right. Hold on a minute. I accidentally closed the presentation, so.
So, Chris, if somebody has questions, I use this mic over here then? Okay. Got it. But I don't unmute here. I just go to okay. Awesome. Awesome. I'm going to grab a drink or something. I'll be right back.
Yeah, that looks nice. Just a stretch of the screen, right? Right. Yes, I understand. It's got like a double broadcast going on.
All right, here we go. And
And then can you I still don't see. I want to see him.
I think once he starts talking, his face will pop up.
Okay.
hello? Can you hear me?
Yeah.
See, there's a pin on this.
Oh,
so if
I
we
see what you
remove
mean.
that pin.
There we go.
Okay.
Can you hear me?
Yes.
Yeah, we can hear you.
Oh,
Give us
okay.
1 second. We're gonna work on. Do you see that?
Yeah. How do I get?
Okay, so go back. Can you go back to the other view? Not his screen, but the view of ours. And we want to. Oh, you know what? He might have to do it on his side.
What's that?
Pin himself.
That's it. Sorry, not.
Yeah, because
It was a better. So that's his screen, and this is Eugene's. Yeah.
Oh, okay.
Let's see. Do we want gallery?
Okay, so now
Yeah.
see how this one
Pin.
There
Yeah.
you go.
Okay. And then how did we get it? So he was
here. I think if you just go to the corner, we can drag him larger.
Like
That's
that?
actually great.
Like that?
That looks fantastic.
That's okay?
Can we go a little bit?
Yeah, absolutely.
On
Yeah,
him?
of course. And then I'm going to turn the room lights down so it's not
Yeah.
quite as washed out.
I love it. I think that's great.
That's okay?
Yeah, I think that's good.
Okay.
Dr. Woodard, I'm going to step to the back just to look at the size of the screen. I'll be right back.
Yeah, I'm looking at this video now. Looks good.
It looks great. I like the size. Do you like the size, Chris? It looks fantastic. I like the whole view.
Okay.
Yeah. Are you happy?
Yes, I am.
I like I love this AI in the hand and the whole presentation. I love it. It's awesome. That's new.
It is new.
Yeah, I love it.
You know, Johnson & Johnson will take it out, though. So I had to sneak it in there before they get it. Don't tell anybody.
Hey, listen, we don't need a big Johnson & Johnson banner. we want real deal, Dr. Woodard. It looks good. I love it. Okay, I think we're set on our side. I should have sent you breakfast this morning.
That's okay. You can make up for it later.
Okay, I will. In martinis.
You're right.
Okay, that
Dr.
sounds
Woodard,
good. So we're set on our side. I have a feeling.
I just want to see if you can hear me through this microphone. Can you hear me speaking in this other mic? Great.
Yes.
All right, fantastic. Thank you.
That's the question microphone. So great.
Oh, okay, perfect.
So I
Um,
have a feeling you have a few minutes.
yeah, I was gonna say, yes, cool.
Do you
I
want me?
kind of wanted to. Can I stop sharing my screen? I wanted to add a picture.
Yeah,
I gotta find it. So
you got lots of time.
cool.
Yeah,
Yeah, I can.
so I think people will probably get here at 6:30. They're going to get breakfast in the other room. They're going to settle in. So I would guess, if I was to guess, probably more of a 6:45 start time.
Yeah, that's cool.
So you have lots of time. So if you want to, if you want to go off your camera and work away, we can either hang up and we can call back. I would hate.
How about I just leave it like this, and I'm just gonna mute and stop my video, and then you can just call me on the cell phone.
I'll do it. When people are getting settled down, I'll call you on the cell phone. I'll give you about a 3 to 4
Yeah,
minute warning.
perfect. Thanks.
Okay, thanks, Dr. Woodard. Take your time.
morning, everyone. Hope everybody had a great night last night. Thank you again for attending this morning session. We're actually going to start out with a non-CME event. So Dr. Woodard is going to give us a brief presentation on his experiences with the most recent navigation devices, and also give us a nice synopsis of how this has helped evolve his training as well. Hey, good morning, Troy. Can you hear me?
Can you hear me? Excuse me.
We can hear you fantastic. Thank you so much for taking time out of your day. We truly appreciate it. Just as an introduction, Dr. Woodard is one of the rhinologists and skull-based surgeons at Cleveland Clinic. Really has a passion for education as well as implementing new innovations and technologies within his practice. And Troy, again, thank you for speaking with us. I wish you were here in person, but thank you again for speaking with us virtually regarding some of the advances that you've had and your personal experiences with surgery and navigation. Troy, we are ready whenever you are. I don't know if you can hear us here. Hi, Troy, can you hear us okay? Hello? I can't put it on, I can't unmute it, otherwise we're going to...
Can you hear me? Hello?
Yep, we can hear you. Can you hear us? Oh, okay.
Hey, Troy.
Turn off the mic? Oh, no, I did, but there's just too much feedback. Yeah. We can, yeah.
Hi, Dr. Woodard. Hold on.
Can you hear me? Yeah. Okay. Well, I'll just talk, but I can't hear anything. Yeah, we just did that. Okay, so all right, anyway, I'll just start. Okay, thanks. Bye. Well, good morning, everybody. I swear we practiced this beforehand, and I don't know what happened, but I'm Troy Woodard, rhinology, sinus, skull base surgery surgeon at the Cleveland Clinic. I have an idea. We'll just blame COVID. It seems like everybody blames COVID for everything, and so that's what we'll do for the AV malfunctions. All right. And so let's see here. Okay. So today I'm going to just briefly discuss an update on endoscopic sinus surgery and navigation, really as it pertains to the Clarent Trudy system. And these are my disclosures. All right. And so the goals of this morning's presentation is really to focus on the next generation surgical navigation and the Trudy system, which you'll see later today, and how it utilizes artificial intelligence, augmented reality, and virtual reality to make our surgeries not only more accurate, but safe. It allows you to do preoperative planning to help you prevent complications. It allows you to be more efficient where you can target certain anatomy and make sure you have complete surgery. It also, for those of you who are interested in teaching or have residents, it can make you or enhance that experience. Ultimately, it leads to improved outcomes, helps you grow as a trainee or a teacher, and improves your experience as a surgeon as well as the patient's experience. So before I begin, I like to go back in time, right? Because I believe it's important to be honest and sort of give you a story of like how I got up here on the stage, right? So I want to go back to a time where I was balloon sinuplasty and a Clarent naysayer, all right? And so I haven't always been up here. I've kind of evolved over the years. I've been at the Cleveland Clinic for almost 13 years now, all right? And so when I was first approached by Amanda, she was our rep at the time, and she was like, hey, we have this new tool. You should use it on all your sinus patients. My initial impression was like, hell no, right? At that time, balloon sinuplasty was really not in. It actually was really out of favor. A lot of the academicians didn't want to use it because it was thought to be used only by people who didn't know how to operate or by people who were just out to get money, right? And thinking about the reimbursements. And so I really did not at that time want to be a part of that. I was about a couple years out of my fellowship. And so I was like, nah, I'm good, right? And so went on about my business until one day I had a train wreck, literally a train wreck walk into my office. So I had this guy right here, patient zero. Let's call him patient zero. So I walk into my office. He's sitting there. He has this big Goomba on his forehead, okay? And he's just kind of moaning. And I'm like, well, what happened? He says, well, sir, 20 years ago, I got hit by a train and they put my face back together. And over the past few weeks, my forehead started growing and now it hurts really bad. So I get this scan and this is what you can see, right? So he has this huge mucocele / almost Potts puffy tumor right in the forehead, right? In front of his face. You can also notice all of these plates that were used during the reconstructive portions of, when they put his face back together, right? So I knew right then that this was going to be a pretty serious case. Now you're probably thinking, okay, this is not a balloon case. And I totally agree with you. This is not a balloon case. And so I took him to surgery, did probably like a 6-hour case, did a bicoronal, flap, pulled it down, went externally and drained it. I also did endoscopically and really connected that mucocele into the frontal sinus, all right? And so my goal was I call it like above and below approach, or you can do like an inside out approach. And, really wanted to connect that collection to the native frontal sinus. It went really well. I'm a big guy, so I like big holes. So we drilled out the frontal sinus very well. Everything went well. So I saw him back about 10 days later, maybe about 2 weeks later for post-op. Walk in the room, and literally he was a hot mess. Okay. So he was moaning, his face was swollen, and he looked horrible. And so I'm kind of sort of like freaking out on the inside, as a physician. You have to sort of keep it together for your patients, but you can still be kind of on the inside like, oh crap, what happened, right? And so I asked him, I says, well, what's going on? And it's kind of interesting because he says to me, well, I started rinsing like you told me. I got the Neomed bottle rinse, and when I irrigate, the fluid goes in, but it doesn't come back out. And I'm like, what? So I take a look, and this is what I see. All right. So where the arrow is pointing, you can see that was my huge endoscopic frontal sinusotomy. And in a matter of 10 days to 2 weeks, it has completely stenosed and become infected. So what I realized, it was a one-way valve. He was putting in saline irrigation. It was going through that opening and coming out the plate that was on his forehead into the soft tissues of his face. All right. So I immediately was like, okay, you got to stop irrigating. And then I was thinking, what could I do? What could I do? All right. So remember, my whole mentality, I'm at the Cleveland Clinic, and it's kind of like I'm a small fish and like surrounded by sharks. All right. So I didn't want to get a bad reputation. I wanted to basically prove myself as a good surgeon. Right. So I'm a few years out of my fellowship, and I thought, man, I hate to take him back. I just had him in this long surgery. Is it possible that I could do balloon sinuplasty? So I call Amanda up and I say, hey, I got my first balloon sinuplasty case for you. And she says, okay, great. And I was like, but there's a catch. So I told her about the patient. And then I says, and I want to do it in office. Right. And so she was like, what? And then, this is not your typical balloon sinuplasty patient. And I was like, I know, but none of my patients are kind of typical. Right. And so she comes. And so before we move to the next slide, take a look here. You will see that his anatomy, remember, it's not normal. His face has been put back together again because of, he was hit by a train. So you can see all the screws coming into the nose here. So it's very tortuous, and, it's not straight cut anatomy, right? It's kind of twisty and turny. All right. So this is my first balloon sinuplasty case. All right. So I got the balloon, tried to insert it. It was pretty tough. Realized immediately that I had to do something called serial dilations to dilate the frontal os. I was able to do that. It was tortuous and narrow, but I was able to successfully dilate it. It was fine. All right. Immediately post dilation, I was like, okay, this looks pretty good, but like, I don't know. Remember, I'm a skeptic. All right. So I have to see proof. And so I was like, okay, well, let's see you back in, 2 weeks, and let's see what's happening. So the 2 week time frame comes, and I'm like, okay, well, let me open up the door and see how it goes. Open up the door. His face has completely resolved. He looks fine. So I says, okay, patient 0, how are you doing? He was like, not good. I was like, not good. He was like, no. It's closed, doc. And I was like, what do you mean it's closed? How do you know it's closed? He says, well, on Sunday, I caught a cold and everything is closed. And I think you're going to have to go back and do surgery. And I was like, oh, gosh. So I go in there and I look, and this is what I see. All right. And so, if you think about it, everything is kind of swollen except the area where I did the balloon sinuplasty. And I'm smart enough to realize that balloons are not magic, and they do not cure upper respiratory infections and viruses. I don't really know why this worked, but it did work. And so I didn't have to take him back to surgery. This is how he looks after his virus resolves 2 years later. All right. So I was like, okay, this balloon, maybe there's something to it. Let me try it on another patient. So I call Amanda back, and I'm like, okay, I got another case for you. So she's like, oh, great. And so she comes, I was like, okay, we're going to do this one in the OR, and this is another frontal case, right? And I was like, you tell me all the time how this balloon is so fantastic and how it can like fracture the bones. So I says, well, this patient has polyps and this type 3 frontal cell. I want to see if it's strong enough to fracture this type 3 cell. And so in the OR, I removed the polyps, right? Did a total ethmoidectomy. And then right at the frontal recess, I slid the guide wire in there. At this time, we didn't have navigation. So it was just, I confirmed the location by the light and then slid the balloon in place, cranked it up, and you could feel and hear crunch, 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 okay? And afterwards I looked and I was like, it looks pretty good. And, I withdrew it. I normally don't do this, but just to confirm that it worked, I actually asked the patient afterwards in the post-op. I says, do you mind if I get another CT scan? And this had to be several years ago because now it's not so easy just to get repeat CT scans, right? Insurances won't do it. But this was when the balloon sort of, I guess, let's see, this was probably about 8 years ago. So they allowed me to get the scan. So I got a repeat scan, and this is what I was able to demonstrate. So you can see where I removed the polyps surgically in the ethmoid cavity. And then you can also see the crushed type 3 frontal cell, all right? Look at the sagittal view at the top right. It looks pretty good. And see the frontal pathway is wide open. I was a little concerned that it was going to cause a mucocele because it compressed that cell and all the mucus that it produced would be trapped, but it never happened. Patient did well. All right, so right around the same time, my go-to navigation system was the Medtronic Stealth, okay? And so I was having serious problems, right? We had the old Fusion system, that worked fine. I had no problems with it at all. But they were starting to not support it as much because they were starting to promote the new S8 or the new Stealth machine. And so we bought that. And so let me just start out by saying at the Cleveland Clinic, we pretty much have every system, okay? So we have Brain Lab, the old Medtronic, the new Medtronic, a Clarence, actually we have 5 a Clarence, and we have a Scopus. So we have pretty much every navigation system. All right. So, but before all of that, we were primarily Medtronic. And so we bought the Stealth machine and we were having problems because it wouldn't register. And then when it would register, it would start out accurate. And by the time you would get posteriorly to the sphenoids, it would become very inaccurate, right? And so I'm like, okay, well, this is where I need it along the skull base and the sphenoids. This is where I really need it. So I was kind of frustrated. All right. So anyway, around that time, I was approached by a Clarent, and they were like, hey, we have this tool that'll help you be more successful. It's called Trudy, and we want you to try it. And honestly, I was like, I don't know. You guys know about balloons. I don't think you know much about navigation, right? But I was actually pretty pissed off at Medtronic because our service was pretty bad. And the technician had told me that it was the surgeon's fault and not the navigation system's fault. So I was willing to give a Clarent a try. So they just happened to come in at the right time. And so, I didn't really expect much because, at that time, navigation is pretty passive, right? It's kind of like point and shoot, right? So, you know where you want to go, you kind of aim at it, and it kind of guides you and helps you, right? And over time, besides localization, there's been very little innovation. I mean, we have MRI fusion. You can use multiple instruments that are plug and play. You can even use them in the office, but really it's not interactive, right? And so, I didn't really expect much. And so I tried Trudy, and immediately I realized, okay, maybe there is something to this, just like there is something to the balloon, right? So it's accurate, it's simple, and then it has these true 3D features, right? And I'll briefly start talking about these. But the things that I'll focus on first is the accuracy and simplicity, right? Like, man, if you haven't tried this system, I'm sure Dr. Chang and Stacy will, let you get your hands on it. It's accurate down to the millimeter, which is very important, especially when you're doing sinus surgery around the orbit and the brain. All right. And it's very simple, right? And so one thing that frustrated me about some of the other systems was that you had to constantly try to register each instrument. And, at our institution, the SPD would bend the instruments. And then if they're bent, they wouldn't register correctly. It was a pain, right? And so sometimes, you may have only half the set working. But with this system, the sensor is in the tip of the instrument. So it doesn't matter if the instrument is bent or not. It's going to be accurate just because of the location of the sensor. And so they'll explain that a little bit more. Because of time and everything, I'm not going to explain that now. And it's easier for you to understand once you're there, okay? But what I really liked was that they were starting to kind of move the needle. All right. And so when I first started using this system, probably about 4 years ago, I think our institution was probably the first to get Trudy. They started having these things called planning points. And it allowed you to actually view the scan and try to figure out a path to, dissect the frontal or to your sphenoid. And you can put these little dots down, and these dots would actually show up on your screen, like your virtual reality screen. And as you're dissecting, you could follow along these paths up to your frontal. This video demonstrated how I used those path points to map out a path to the frontal sinuses. In addition, they had these beacons, which you could put in areas of no-fly zones, right? And so I oftentimes use them, especially when I have residents, when they're going through and reviewing the scans, I'll have them put them in areas where there are dehiscences. So along the orbit, along the skull base. This is just an example of a case I'm going to show you a little later of a patient that had a posterior table dehiscence. And so what we did was put the beacons there. So that way, when we got close to that area, it would alert us and let us know, hey, you're in a danger zone, be careful. All right. You could also use those beacons to let you know that, to actually confirm that you hit a certain spot. Like, for example, if you wanted to know that you got far lateral in the, frontal sinus, you could put that over in the frontal sinus. So when you actually get to that point, you'll hear a little ding, 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 ding to let you know that you were able to reach that spot and confirm that you dissected that area. So one thing that, you've heard me talk about is my evolution, how I went from a non-balloon user to one who actually uses it regularly as a tool, which you'll see in some of the cases. And so I also noticed, and this is one thing that I appreciate about Acclarent, is that they also evolve, right? And so what do I mean? Well, all right, Trudy has evolved over the past 3 or 4 years. It evolves really regularly within every year. And they'll explain this a little bit more. But what I've noticed is that unlike the other systems where what you buy is what you get, with Trudy, the software, it's all in the software. So even, now if you get it, you'll get this nice looking cart, etc. But even like we still have the old cart, but it has all the new technology. So it doesn't matter if you have the old cart, new cart, it's all in the software. And that's upgraded regularly. And so they'll explain that. And so it all comes, like when you buy the system, the upgrades come regularly. And so it has evolved tremendously. And so they began to make it smart, right? And so they use artificial intelligence, the virtual reality and augmented reality to make it a more interactive and immersive experience. And so remember how I talked about the mapping out your path to the different sinuses with those points? Well, now they actually made it even smarter. So they're using artificial intelligence. So the computer itself is using all these different algorithms so where you can put a point in whatever sinus you want to go, so the frontal sinus, and then a point in the nose where you want to start. And then it will calculate the path of least resistance. So the shortest path without going through any bone to, whatever sinus you want it to, you designated it, okay? Very smart. All right. Remember how I talked about the beacons and I use those to help alert me when I get to dangerous spots? Well, they still have those, but they also expanded it to include auto segmentation. So it allows you to like label anatomic structures such as the brain or the eyes. And what that does, it has embedded beacons. So when you get within certain millimeters, you can set the distance. And so usually we'll say within 2 millimeters of the eye or 2 millimeters with the brain, the system will alert you to let you know, hey, you're getting close to these structures. All right. And oftentimes that's very helpful to help prevent any future complications. Now, they also have this intrasinus TrueView camera. How is this helpful? So this is a patient who had unilateral sinusitis, it's hard to see on this scan, but osteoneogenesis right in the ethmoid area. I needed to cannulate the frontal sinus. And, one way that I thought we could do is put a camera in the frontal sinus and look down in the frontal recess. So if you see at the bottom of the screen, this is a view of the camera looking down into the frontal recess. I am now going to come from below with my navigable probe or curved suction, and you'll be able to see it in that area. And with confidence, I know I'm in the right area. I can now push through that hard bone into the frontal sinus. So this camera gives you confidence that you are in the right location, and it allows you to have a more complete surgery. Another feature is the fast anatomical mapping. Now, this was initially used in the cardiac space where they would map out the heart. They took this technology and now apply it to the sinonasal cavity, in which we use it to map out space created during surgery, also use it to ensure completeness of surgery. There's also potential for tumor mapping, especially with margins. So this is an example. So I'm at a teaching institution, and so oftentimes I'm trying to explain to the residents how to operate in the ethmoid cavity, right? And so I have a junior resident doing an ethmoidectomy, and they said, okay, I'm done. I said, okay, well, let's map it out. So you get your instrument and you just kind of move it over the space after they finished operating, and it paints a picture. So you can see the red space is the space that the PGY2 created after they operated. He says, okay, well, let me show you. You missed a lot of the upper ethmoids. So I go back and I do a more complete surgery. I take that same instrument, and all you do is just kind of move it over the space that you created. And I'm able to then show them, hey, look, you missed some spots. And this is, it gives them a better picture or a better understanding of what more they need to do in order to have a more complete surgery. So I kind of talked over briefly some of the newer features and explained how Trudy has evolved over time. I just wanted to give you a few case studies, kind of a mixture of complexity, to kind of illustrate how we routinely use Trudy. So before I go, I just want to kind of tell you about my practice, right? So I do tertiary care rhinology, probably about 80% revision surgery. It's 50-50 skull base, 50-50, rhinology. All right. And so one common problem that I see is recirculation. I know we all see this, right? Oftentimes, some physicians will leave an uncinate or don't necessarily connect the natural os to the intraostomy site, right? And so what I do is I will oftentimes try to teach my residents, okay, it's important to make sure you have that connection. Otherwise, this can lead to persistent infections, postnasal drip, etc. So this illustrates how we use the path to target, which created a path, as you can see, around the uncinate. We have the TrueView camera showing that it comes around the uncinate. Use a navigable instrument, making sure we're going through the natural os. The resident went up towards the eye, and I was like, oh, be careful. You're going up towards the eye. See how it's blinking? There's also a sound notifying us that, hey, you're in a danger spot. You're going to hit the eye now, right? And so this allows us to be able to do complete safe surgery and avoid the orbit, right? And the same thing could be used in other areas like the frontal or the sphenoid. But this is just a clear example to show you how you can use these
Might be back.
So I use the beacons to demonstrate, to alert me when I was close to the posterior table defect. And I know this, again, this is not a total balloon case. Most of the time when I use the balloon, it is a combination, right? I use the balloon as a tool. So I did a total ethmoidectomy, remove the ethmoids, and then use the balloon to go into the frontal sinus area, open that up to drain out the pus in the frontal sinus. From that point, I then take my Hosman punch, widen that. Again, I do a lot of hybrid procedures, so it's not balloon only cases. I just use the balloon as a tool to make sure, to me, it just makes it easier, okay? So I open it up. So now I get my curved instrument in there and I go and take a look. You can see the pulsations coming through the posterior table defect, all right? Now I get my wire up there. I advance it up towards the beacons. Again, it lets me know. So when I hear their alert, I know I'm getting close to the posterior table defect. So I withdraw it. Right below that, I inflate my balloon some more to atraumatically dilate that. Then I'm able to clear that out and take out the intersinus partition. this is how it looked 3 months later. All right, this is my last case. 70-year-old man who was at a different hospital, had mental status changes, severe pneumocephalus. He had sinus surgery 4 days prior to this by an outside surgeon. Came to our ED, confused, noted to have a 1 centimeter defect in the ethmoid fovea. Broad spectrum antibiotics, CT scan revealed this. It's a lot of pneumocephalus, huh? And all right, so this is what we found, okay? So if you take a look, it's kind of interesting because the recess is really narrow, right? Very, very narrow. And it's about the size of the opening, right? And so let's go back here. Look at the sagittal view. And I think what happened is as the surgeon was trying to dilate the frontal sinus, he went up through the ethmoid fovea. And so it's important when you're doing sinus surgery to look at all 3 views because of this. If it's so narrow like this, oftentimes I try not to touch the frontal sinus because it's extremely narrow. So you have to be very, very careful. All right. So I repaired the defect with a free graft, and evidently I repaired it too well because it scarred over my frontal outflow tract. So if you look at the right picture, this is 10 weeks later. Not only is the defect healed over, but the frontal sinus is completely healed. So I see the patient in clinic. He says, yeah, doc, I have no leak, but my right eye is killing me. It hurts really bad, and it's starting to swell. So I'm like, okay, well, let's get a scan and look. And this is what I see. So I fixed one problem, but I caused another, right? So he has right forehead opacification, and now he's starting to develop a mucocele that's causing dehiscence of the lamina. So I'm like, crap. Now I have to go in and drain this, right? And avoid causing another CSF leak. So what I ended up doing was a hybrid. Again, remember, I used the balloon as a tool, not usually as a standalone procedure. So I'm pushing on his orbit. You can see there is no bone there. It's all scar tissue. So I used the balloon to atraumatically dilate a frontal recess pathway, and then I convert to rigid instruments to expand the opening, all right? I use Trudy to accurately define a path, make sure that I'm in the right spot. And in this case, every millimeter counts. If you're off by 3 millimeters, then you're in the brain or you're in the orbit. And that's why I really, use this system. That's why we have 5 of these at our, in our main hospital and at our different locations, because it's so accurate. So it's extremely narrow. So I convert to a Hoseman punch, continue to take out the floor. It's a very small sinus. You can see the patch that I put, it's kind of white. You'll see it right there. Yes, so I tried to avoid that. There's the opening into the frontal recess. I put in a propel, hoping that that would kind of stay open. And so basically, this is how it looked at 6 weeks and at 3 months. It was starting to stenose. So I ended up ballooning it again. And this is how it was 6 months post dilation, and it's remained stable ever since. So in conclusion, Acclaren has developed novel navigation systems that are adaptable, accurate, and simple. But they have also evolved to utilize AI and simulation, which has translated into increased functionality. It has expanded the dimensions of ENT sinus surgery, which has allowed for complete sinus surgery and has improved patient outcomes and surgeon and training experience. Hopefully you were able to get something out of this presentation. Hopefully you were able to hear me. And because I can't hear any of you. But I think that's it. Thank you.
Thanks so much. I will
You're
say
on
that-
mute, Eugene, at
Oh.
your where you are. I don't know if they can unmute that.
No, we'll have horrible feedback. Thanks again, Troy. We have several navigation companies that are our sponsors here, and feel free to use them. We'll also talk about some emerging technologies, both in the navigation area as well as in our preoperative planning area. So good morning again to everybody. Welcome to the second day of ENT in the desert. Thank you all for making it. We've got an exciting program today. A couple of housekeeping notes. Please visit the sponsors as well as fill out your bingo card. Sonia and our team are going to draw the winners at lunch today, and I think the grand prize is a 2-night stay here at the Lowe's, also free registration for our next meetings, and some cool Arizona swag. So please visit the sponsors, and we would love to award your prize. Everybody have a good time last night, and everybody have a good time yesterday in terms of learning about pediatric airway, COVID, and rhinology? Awesome, thank you. Oh, and the last housekeeping thing, today is Chris Adams' birthday, and so Chris is one of our phenomenal PAs, and he has been working our AV system. So a round of applause for Chris. Thank you so much for all your hard work. So we are going to start out today. Today's our surgical day, so today's a lot of fun. You're going to start learning about techniques of how to operate within the sinuses. You're going to get to ask experts questions that you may have, either with our techniques, with our equipment, with our styles, and how we evaluate these patients. And then you're going to meet some new people on our faculty. And it's my great pleasure to, again, reintroduce Zara. Zara, thank you so much. We're really looking forward to your frontal sinus talk, as well as some input for our patients with nasal obstruction. And I also want to invite and introduce our newest faculty member, Dr. David Chen. David is the nicest guy that you will meet. He trained at Hopkins, did a facial plastic fellowship at OHSU, was on staff at MUSC. These are all fantastic institutions, obviously not as great as ours, but we were able to lure him over here, and really in the span of about 6 months, he's really built up an amazing practice. Why I loved him is when I asked him, I said, what's your favorite thing to do? And he said, I love the nose. And I said, we talk the same language. So what David is going to do is, for about the next 10 minutes, he's going to lead us through how we evaluate patients that come into our office that can't breathe through their nose. Give us a detailed step-by-step analysis of that. And then Zara and I are going to talk a little bit about our endoscopic approaches to how we do this, what we can do, but also, honestly, probably what we can't do. And then David is going to bring us home with some of his really cool open techniques. So thank you again, David, and welcome on. This
This is a green 1 or 2 if you need. So, yeah.
All right. Well, thank you so much, Eugene, for those perhaps too kind words. Morning, everyone. My name is David Chen. I'm one of the new faculty here at the University of Arizona. I specialize in facial plastic and reconstructive surgery. Super thrilled to be joining the team and also joining the community here. So as a facial plastic surgeon, one of the small joys of my life is getting up early in the morning and talking about the nose to people who will listen. So thanks for joining me. In my practice, most of the patients who come in for nasal obstruction will have already been seen by another ENT, and they're seeing me specifically to be evaluated for an open septal rhinoplasty. So I get kind of a biased subset of patients for whom an open approach is oftentimes appropriate. That said, I do offer an endonasal approach for a lot of other patients as well. And the focus of these next few talks is to talk about how to decide between those two approaches. To start, I want to go over how I evaluate patients with nasal obstruction. This is something that no doubt most of us in this room have done time and time again, but I kind of want to highlight some of the points that are important in my decision making. And to start with the history, one of the most important points is really figuring out whether someone has obstruction, can't breathe through their nose because of inflammatory congestion, or if it's a true anatomic obstruction. So I always tell patients that there's two categories of reasons why you might not be able to breathe through your nose. One category has to do with swelling, which is a dynamic process, and it's oftentimes treated first line with medications. And on the other hand, we have a true physical blockage of the structural blockage of the nose, and that's usually treated by surgery. So if patients come in, they're saying, oh, you know, my obstruction kind of switches from side to side, it really fluctuates throughout the day. These are clues that there's an underlying inflammatory problem that needs to be addressed with or without surgery. And to that end, yesterday we kind of touched upon, you know, whether we should decongest patients before we examine them. So when I see patients with nasal obstruction, every patient that comes in gets decongested at the beginning of the visit. And so I think it's useful for a couple reasons. Number one, I do evaluate every patient with a rigid nasal endoscopy. But number two, I think it also helps to really unmask any underlying structural blockage. So there are patients, you come in, you look in their nose, and you're like, oh man, your septum looks terrible, and you have no room in your nose at all. But then you decongest them, and you realize that anatomically they're actually okay. It was really just a swelling issue. So about halfway through the visit, I always ask patients, you know, that spray that you got a few minutes ago, how much did it help you breathe? How much better are you breathing now? And if the answer is a lot, then, you know, that clues me in that, again, this could be a swelling issue. And it also kind of speaks to their potential candidacy for an inferior turbinate reduction. I always ask about history of nasal trauma and prior surgeries, and the key thing here is if I'm operating on this nose and opening up this nose, how much scarring am I going to encounter? And is there any cartilage in the septum for me to use, potentially for grafting purposes? Smoking is a huge issue, especially with rhinoplasty. The healing with rhinoplasty is unpredictable enough as it is. Smoking adds a whole slew of additional potential risk and complications. But a lot of that risk can actually be mitigated even with temporary reduction or cessation of smoking around the time of surgery. So this is something I counsel the smokers on. I also ask about history of MRSA exposure. And so these are people who have had MRSA infections, or they work in a healthcare setting, or have had prolonged exposure to a healthcare setting. So as we all know, MRSA kind of lives in our nasal vestibules. It colonizes the front of our nose. And post-op MRSA infections with rhinoplasty can be especially devastating. So there's mixed evidence as to whether prophylactic measures before and after surgery can reduce that risk of MRSA infection, but nonetheless, any patient who's had a MRSA infection or might be exposed, I do put them on a protocol before and after surgery to reduce that risk. And then this kind of goes without say, but really document the functional impact. This is why the patient's coming in to see you in the first place. And as you know, surgeries like rhinoplasty can be really difficult sometimes from the insurance end to get pre-authorization. So it's really helpful to just kind of spell out exactly what the patient's struggling with, whether it's work or exercise or sleep. Right, moving on to the physical exam. So the crux of the physical exam is identifying the exact site of the obstruction, because not everyone's obstructed the same way, and it really changes the surgical plan. Now the key to this is really the internal and external valve, which are the narrowest parts of the nose and the places where the patient's most likely going to be obstructed. Just a really quick review of that anatomy. You have your internal valve, which is right here, the junction of the upper and lower lateral cartilages at the scroll area. And oh, sorry, the mouse is not showing up. So that's going to be right here. And the boundaries of that internal valve are the upper lateral cartilage, the nasal septum, the nasal floor, and the head of the inferior turbinate. So an aberration of any of these structures can cause narrowing of that internal valve. And the external valve is a little bit more straightforward, actually. It's just what you can see on the outside. It's the nostril. So external valve obstruction, it's easy to pick up. You kind of look, underneath the patient's nose, and it's jumping out right at you. So in this case, it's important to distinguish between what's called static versus a dynamic collapse. So this is a lady who has a very deviated caudal septum. And so this cartilage is kind of just sitting off to the side here. It's there statically all the time. And contrast that to this patient who has pretty narrow external valve to begin with, but then every time she takes a breath, her nose just totally collapses. So it's helpful to have the patient take a breath, sniff in through their nose, and see what happens. For the internal valve, it's a little bit harder to assess because it's deeper in the nose. The gold standard kind of physical exam maneuver is the modified caudal maneuver, and this involves taking a small instrument like a ring tip curette or the narrow end of a Q-tip, putting it into the nasal valve area and very gently applying lateral support to that area. I want to emphasize really gently, because if you kind of really crank out on this area off to the side, anyone in this room is going to be able to breathe better. But the point is to really try to emulate what you can create with surgery. So just a small amount of support in this area to simulate what can be created with a cartilage graft. And then once you've done your entire exam, you want to kind of break down in your mind where that obstruction is taking place. So this is a handout that I actually use to counsel patients in the clinic. So is that obstruction mainly because of a deviated septum? Is it inferior turbinate hypertrophy? Or is there collapse or narrowing of the lateral nasal wall, either at the internal valve or the external valve? And oftentimes, it's a combination of all of these things. So some other things that are useful to pay attention to, the length of the nasal bones and the thickness of the skin soft tissue envelope. So we know that patients with shorter nasal bones and also thinner, lighter skin are going to be more predisposed to nasal obstruction. And also these are patients that are going to be harder to fix because they inherently have less structural support for their nose, so they may need more robust grafting. Lastly, the endoscopic exam. And so sometimes there are things that are a little tougher to see on anterior rhinoscopy. So this is a septal spur, obviously that's a little bit more posterior. It's completely abutting the inferior turbinate. And keep in mind, there are also those rare nasal masses and malignancies that can sometimes present as nasal obstruction. So it helps to do your due diligence and make sure those aren't missed. Every now and then, you're going to get a patient who comes in to your office for nasal obstruction, and you're going to say, sir, I think I have an idea as to why you may have difficulty breathing through your nose. But a lot of times, the problems that are the most obvious can also be the most challenging and complex to fix. So I think having a systematic way to evaluate for obstruction and a systematic exam really helps you hone on the appropriate plan for these patients. And with that, I'm going to turn it back over to Dr. Chang here to talk about some closed techniques for addressing nasal obstruction. Thank you.
David, thanks so much. You're going to come back and tell us how to do open approaches too, right?
Love to.
Good, good. So in just a couple of minutes, he'll go ahead and do that. I'm going to talk to you a little bit about our endoscopic approaches. So when I trained, we did what was called the traditional endonasal approach. And I see one of my old attendings here in the audience, Dr. Mashka. Thanks so much for coming. So I learned how to do septoplasties with his partner, Dr. Phil Lee. So we would go up to Mason City, and this is where we got a lot of our cases done. So it was really, really exciting. This is where we were allowed to operate. They took us under our wing. And I still remember the day, Phil Lee, just a gregarious, friendly, just loving individual doing a septoplasty. We did the traditional endonasal approach. He'd make the incision, he'd dissect, and he'd go, Eugene, come over here. Let me show you what I'm doing. And so he's a big guy, and so I'd kind of come around and say, do you see the septum? Do you see the spur that I'm about to take out? And I couldn't see anything, like at all. Like, first of all, he had the headlight. Second of all, there was a lot of blood. So it was really challenging to see what was going on. And so how you ended up doing septoplasties, it was a see one, do one, and pray that it worked one. Because a lot of times you were operating in a kind of a bloody field. And part of that was my lack of skill in doing these. Oftentimes I wasn't finding that right layer. I wasn't dissecting properly. But a lot of this was the visualization, right? So this view is actually optimized. This is with an endoscope, and this is what I took on our patient just to show you the potential narrowness of the field that you're looking at using a traditional endonasal approach, as well as the lack of depth that you see, I think. And so I think one of the advantages that we now have with endoscopic endonasal approaches are that we are able to see things at a much higher magnification, and we're able to go the length back and forth between the tip of the nose all the way back to the nasopharynx. And from my personal experience, what that has allowed me to do is it has actually allowed me to be more aggressive. We always talk about the 1 centimeter struts that we leave, the L struts, in order to preserve the support. But I think when we're doing the traditional approach, we actually don't get to that border. But with an endoscopic endonasal approach, we can. And so this is a view that you get with an endonasal septoplasty. I'm going to be honest, this was one of my more challenging cases. So, you can take a look in the nose, and as you can see, just a really bad septal. Would you call this a septal fracture, David? Or yeah, it looked like. Yeah, to me it looked like somebody had just clocked this guy on the left side of his nose, and I couldn't even get in to see the right side. And so I remember distinctly counseling this patient before surgery, and I said, I know a fantastic person that I would love for you to meet, Dr. Chen. And this is my favorite part of counseling, is being able to hand off really challenging patients to people who have much more skill than me. And he said, no, I really want you to do it. And I said, no, Dr. Chen looks exactly like me, but he's just taller and he's more handsome, and he'll do a great job. And he said, well, I just want to get it done. And so I explained to him the limits of our endoscopic approach. I said, look, we can maybe do some of your septum, but I don't think I can get a lot of your tip done at all. The recovery time might be slightly less with an endoscopic approach, but at the same time, you're not going to get the full benefit. Zara, I'd love to hear, you have these challenging patients as well. How do you distinguish between endoscopic versus open?
Yeah, good morning, everybody. So I think just that very first picture that you showed is a perfect one where you can't even look into the nose. That's someone I send to my facial plastic surgeon. Because, what we can do really well, I think, with endoscopic approaches is remove deflected pieces of bone and cartilage, but reconstructing the support after you've removed something which you need at that very anterior caudal aspect at least in my hands, we're not able to do very well endoscopically completely. And so that's my distinguishing characteristic. Is this something that is going to need to be reconstructed after I remove it? If so, then I'm just going to send that person to my facial plastics colleague.
I would agree. I think that was really well said. And I think all of us have probably trained in open approaches during residency. But if you don't do it every day, if you don't love it like David does, it's hard. And then the stakes are high, right? I mean, these are cosmetic incisions that people are seeing that you can really deconstruct the nose and destabilize them. So I think that the mechanisms are challenging. So I saw this septal fracture and I was just curious. I said, what happened? You know, how did you get this? And so just curious, what is the funniest story that you got for a mechanism of injury for a nasal fracture?
Oh, gosh. That's a really tough one.
We could write books, I think, right?
Yeah,
all of you could write books, I imagine, as well, too.
Yeah, I'll have to get back to you on that.
How about you, Zara? What's your most entertaining story that you've heard?
Yeah, I mean, there are so many different crazy things. A few of them is an MMA fighter that fights in the UFC that just like keeps getting hit over and over and keeps coming back to like ask us to fix their nose. And then, you know, there have been some like younger, more adolescent, like kids fighting other kids or playing with other kids, and then all sorts of crazy injuries from like the things that they're playing with, like a hanger fight.
Wow.
That can cause a lot of damage. But yeah, there's so many.
So I've heard so many of these. So this is my impetus. So this is my second boy here, and so here I'm teaching him how to box. So he's a great boxer now. He's got all of his combinations down because I told him that, look, I heard so many stories of just minding your own business, and all of a sudden, you need to rush in to help a distressed person in need, and you need to get those punches out. So he's now learning how to box for that. So in terms of incision and dissection, a couple tips that I like to do. I like to make my incision actually pretty anteriorly because it gives me a little bit of space. I am a right-handed surgeon, as most of us are, and so I typically like to make, my incisions on the left side. But I do think that you have to be comfortable in making them on both sides. And so the reason why I made this one on the right side, the patient's right side, I apologize, is because I did want to try and see if I could do some tip work. So the important thing here, and this is where you should really spend some time, getting in this mucoperichondrial plane. If you don't feel confident about it, I often use a 15 blade to kind of score that to get that gritty surface. And once you're in that plane, so this is that huge septal fracture here, you see this blueness within the septal cartilage. And that's where I know that I've done a good job there. Making your incision in the septum, making sure that you just make it through the cartilage and not through the mucosa on the other side. And here, once we make our incision through the septum, then you'll be able to see that with an endoscopic approach, you can see these tiny fibrils that lift up. And this is how I know that I'm in the right plane. So you can see these fibrils here that are lifting up. And once you see those, and once it's a bloodless dissection, you can understand why this is so much of an easier procedure endoscopically, in my hands at least. So I don't do any more traditional endonasal approaches. So I got really nervous before this case, and I read a lot on endoscopic tip work, and we were able to actually do a really nice repair. So this is his right side here, so we were able to get it pretty nice and open, as well as on the left side. And so for the tip work, I actually scored the cartilage on the other side. I tried to do it with some mattress sutures that I had read about in textbooks as well as in chapters. This was his kind of before result here, where you could see the crus kind of going into that right nasal area, and this was his result immediately after surgery. And I came out and I was like high-fiving everybody in the room. I was like, I'm going to be a facial plastic surgeon. This is awesome. And then he came back to see me. This is the sad part of the story. So he came back to see me like 2 weeks later, and he said, oh, doc, I'm feeling so good. I'm breathing so nicely, but there was this thing that was like bothering me on my nose, so I started picking at it, and then I heard like a spring, and it went back to kind of like, not completely like this picture on the left, but he still had some crease that I could see. So again, really pushing the limits of what you can do endoscopically. Now I know that I am going to force them to see you for these types of cases. But hopefully you've learned and picked up some tips on endoscopic approaches. And now David's going to take us home for the open approaches.
Thanks, Eugene. I think probably the funniest and best stories about nasal fractures are probably untold. Usually the story is I was minding my own business on the way to church, and I think those are probably some of the best stories if we know the truth. So, as a quick disclaimer, a big focus of my fellowship training was for rhinoplasty. It's a big part of my practice here and happens to be my favorite surgery. So I want to start off by kind of offsetting some of my inherent bias by acknowledging some of the important drawbacks of an open approach to nasal obstruction, namely septorhinoplasty. And so those main drawbacks are, again, it's going to be increased operative time. It is going to be more pain and recovery for the patient. I think significantly more pain and recovery with the external swelling that they have compared to an endoscopic approach. And then there's increased cost of care, whether that's on the patient's end or healthcare dollars, the system as a whole. And then there's the issue of scar, right? So there's obviously the external scar on the skin, which usually heals up pretty well and it's minimally visible. But I think the more concerning scar is the scar underneath the skin that you can't see, the emotional scars. Totally joking. But every time you open the nose, you create a scar plane underneath the SMAS layer that over time can cause irregularities and deformities. So this is the humbling part about rhinoplasty is you close up a nose on the table, it looks wonderful, and then 6 months later or a year, you notice some changes that are suboptimal. And it's because of that scar contracture underneath the skin. And lastly, anytime you open the nose, you're taking things apart and you have to put them back together with enough stability that hopefully lasts the patient's entire life. And if that doesn't work out well or things don't heal well, then you've potentially destabilized important nasal support structures that you could have otherwise left alone. So I think the open approach, is definitely appropriate in a lot of situations, but if you have the option to do things endonasally or endoscopically, it's an approach that should be measured and used judiciously. So in my mind, there's kind of two main indications for the open approach. And Zara, I completely agree with what you said earlier. I think you put it very eloquently. So the first indication is if there's inherent deformity or insufficiency of the septal L strut. And we'll get into that in just a little bit. And number two is if you need to do more stuff to the nose, if you need additional grafting, nasal valve repair, certainly if the patient wants cosmetic changes. There are very talented surgeons out there who will argue you could achieve these goals also with an endonasal approach to rhinoplasty. And I think that is true in a lot of cases, but the caveat is you have to be, the learning curve for effective endonasal rhinoplasty is pretty steep, and you have to have a lot of experience and know exactly what you're doing, because you're essentially doing the same surgery, but just completely without any visualization by feel. So I think for most of the surgeons out there who don't do a high volume of endonasal rhinoplasty, an open approach is probably the safer bet that's going to give you more predictable results. So this is a diagram of a traditional septoplasty where you maintain about 1 to 1.5 centimeters of that dorsal and caudal strut. And this works beautifully if the deviated part of the septum is included in this cartilage that you're removing or in the bone behind it. And so the question is, what do you do if there's an inherent deviation or deformity of this L strut, which is going to be crucial to creating support for the nose? So what surgeries can you do? And the answer is there's actually a ton of surgeries that you can do. So, so this is from a systematic review of all the techniques for extracorporeal septoplasty aimed at correcting L strut deviation. And obviously I don't want you to read the whole slide, but just to give you a little bit of context that there have been a lot of different techniques reported, many of which are very similar to correct deviation of that L strut. The particular technique that I like to use is called the anterior septal transplant. And it's a modified extracorporeal technique. And so what I do is I remove most of the septum, including the entire caudal septal strut. I leave a portion of the dorsal strut in place. And the nice thing about this technique is you get a very long piece of cartilage that you can carve into relatively smaller grafts that are cartilage conserving. And so oftentimes you don't need to harvest additional rib cartilage in order to do this reconstruction. And so to reconstruct, I put an extended spreader graft on either side of that dorsal strut. And what this can do is if there's a bend in this part of the dorsal strut that you're leaving behind, these extended spreaders can splint that deviation and correct for that dorsal deviation as well. And then in the midline, you also have a columellar strut that you're sandwiching in between these extended spreaders that's fixated to the nasal spine. And the lower lateral cartilages are then resuspended in the midline back to this construct. And so how well does this hold up over time? So they have looked at some of the outcomes for this technique. So this is a series of 71 patients with a mean follow-up time of 14 months, so when things are starting to really stabilize. And there's significant improvement in nasal obstruction subjectively as measured by the nose score. And then they also looked at pre and post-op photography with a mean follow-up of 17 months. And so there was visible significant improvement in deviation of the tip and the dorsum from the frontal and base views without any changes in nasal projection and nasal rotation. And so once you've dealt with the septum, you can also use additional grafting techniques to complete your nasal valve repair. If there is bony deviation, of course, that can be addressed with osteotomies. And then if there's additional internal valve collapse, you can use some other grafts to fix that. Remember that the extended spreaders from the septal reconstruction are going to help widen your internal valve angle as it is. But if there's additional collapse that you want to address, you can use any number of grafts that are out there in the literature. You can use alar batten grafts, lateral crural strut grafts. A graft that I actually like to use is what's called a modified butterfly graft, which is essentially an implantable breathe right strip. And so it's modified because it's narrower, much narrower, and also longer than a traditional butterfly graft. This is harvested usually from the ear. And so because it's narrower, it sits right over this internal valve area at the scroll, and it's camouflaged by the cephalic border of the lower lateral cartilages. And so you reduce the risk of contour deformity that is one of the big problems with traditional butterfly grafts. If there's external valve collapse, you can consider alar rim grafts here as well. And so just jumping back, finishing up with the patients we saw earlier. So this is a very nice young lady. She was a volleyball player and suffered nasal trauma as a result of her sport. So she has this really deviated caudal septum. And so I did an anterior septal transplant for her. And this is pretty early on in her recovery. So the scar is still more erythematous than it ultimately will be. But you can see that the caudal septum is in a nice position afterwards. This lady with the external valve collapse, she also had actually a pretty significant caudal septal deviation, which is harder to see from the outside. but we did the septal transplant for her as well as some alar rim grafts, and so really opened up the external valves for her. And then this gentleman took a little bit more work. He's a former Marine with a lot of nasal trauma over the years. So I had to do some osteotomies on him. So usually to straighten a crooked, bony dorsum, I'll do bilateral lateral osteotomies with an intermediate osteotomy to offset the length difference in the bones. And I do that intermediate osteotomy on the side away from the deviation. Clocking sutures to straighten his midfolds, and then also that anterior septal transplant. And you can tell it's not perfect, it's still a little crooked, but definitely more room for him to breathe afterwards, and he was pretty happy after surgery. And that is all I have for you, so thanks for your attention.
Any questions? Any questions from the audience at all? Yes, sir. Very, very great question. So for those of you who may not have heard, for my endoscopic approach, did I bank the cartilage to potentially assist Dr. Chen in the future? I did not. That I should have. I probably should have. So typically banking cartilage, you can bank it behind the ear. It stays viable. David, what have you found? Should I have done something like that?
Yeah, that's a really great question. I'm glad you brought it up. And so there's potential utility in banking cartilage behind the ear, but I think and a lot of times that cartilage does remain viable. I think the quality of the cartilage can really vary from case to case. So sometimes, you'll open up some bank cartilage, and it's super friable. It's difficult to carve, and it's really kind of not usable for grafting purposes, especially if you need stronger structural grafts. The other point I want to make is I know some surgeons, and I saw this during residency, will do the septoplasty, and they may macerate the cartilage that they remove to kind of straighten it out, crush it, and then put it back into the nose. And I've found that actually, if the patient needs a revision surgery, that cartilage is usually not usable, and it's actually sometimes really difficult to get around because it causes additional scarring. And I've also noticed that sometimes that cartilage, if it's put back in, can migrate and cause a recurrent deviation. So that's something that I would actually recommend against is trying to put in cartilage back into the septum after septoplasty.
Great question. So the question again was, how do you close an endoscopic septoplasty? And you had mentioned a couple different options, as well as some adjuvant splints as well. So normally what I used to do is I used to do a quilting suture, making sure going all the way from front to back, and then using a separate incision to close my incision. And so that was two sutures. What I found was that if I could extend my quilting suture all the way anteriorly and incorporate that initially, I found that to be much easier, and it was also really easy to tie. So one of the challenges that I have is if I'm tying a knot that's a little bit further into the nose, I always get an air knot. And so if I can start my incision, my mattress suture right at that incision line, pull that mucosa forward, because it always tends to retract back, pull it forward, go all the way back and forth, and then come out, I found that septal incision heals really, really well. And also, I don't use splints. I just don't like them. I find that they bother people a lot. But I know a lot of people do, and I know from hearing a lot of anecdotal stories that the most satisfying thing for patients is when you take those splints out. So I think that that's also really important too. Zara, I'd love to get your input there.
Yeah, I do exactly the same thing, Eugene. I use a mattress suture. I start out all the way at the very front, pull that mucosa forward so you have a really nice closure of your incision that's at the very front. So I do the exact same thing, and just make sure if you're using that technique that you not only go all the way from front to back, but you go all the way up high also to really prevent any sort of hematoma formation. And I also always leave a little bit of a drainage port at the back. If there's no perforation during the actual septoplasty, then I make a small hole at the very posterior inferior aspect of the septum so that any blood that's collecting inside has a way to drain out. And that, heals really nicely without any problem later. So that's what I do at the end. And I wanted to just also respond to your first question. Some facial plastic surgeons, like the one that is at Stanford that I work with most, Dr. Sam Most, he routinely uses rib cartilage, regardless of, what's in the nose, I think, because he just finds it to be the most stable, predictable cartilage to use in his reconstruction. And so I definitely make sure when I have patients that, like your first patient that you talked about, I tell them, I really think you should speak with our facial plastic surgeon. I really think that would give you the, 100% definitive relief of your nasal obstruction. And they say the same thing. No, I want you to do it. I just want the endoscopic approach. I understand that you're only going to be able to give me 80, 90%, and that you'll still have asymmetry at the end of the procedure. They're okay with all that. I make sure they understand if you do still feel obstructed and you do want to move forward with another procedure, they will likely use rib cartilage. I always say that, just put that out there so they understand exactly what they're signing up for.
Great points. David, if I can ask you for your MRSA approach, or for your MRSA algorithm, we would love to know about that, because I don't know about you all, but many of the people that we take care of are nurses, people that we work with, people with documented MRSA infections, and that's always been challenging for me. So what I would task you with, maybe if you can send that to me via email, and then I'll send it out to the group through either the Socio app, or we'll just send out a mass email of important kind of algorithms and treatment methods and whatnot, because I think that would be really pertinent and exciting for us.
Yeah, absolutely. And I guess a quick spoiler, it's pretty straightforward. It's nothing fancy. I just have the patient actually trim their own nose hairs a week before surgery, and then do TID Bactroban for a week before surgery, and then a month after surgery, and then I make sure they're on prophylactic antibiotics with MRSA coverage after surgery. So if you look at our Academy guidelines, post-op prophylactic antibiotics are not indicated for routine rhinoplasty, but for these patients, I put them on something like doxycycline or clindamycin.
Very good. Well, David, thank you again for being part of our panel this morning. We really appreciate it, and we're so excited to see your practice growing. Zara, if you don't mind just telling us a little bit about frontal sinus surgery and keying us in on how we can do this easily and effectively. Thank you.
All right, let me get all set up here. Awesome. Thank you. Yeah. One other thing I was just going to mention before I start talking about frontal sinus surgery, one technique that I actually learned from Ben Blyer at Mass Eye and Ear, when you're doing an endoscopic approach and yet you want to shift the caudal septum back to the midline, if you use an open Jansen Middleton and take the posterior bone of your vomer, that rectangle that is created with that open Jansen Middleton is the exact right size in most noses to use as a caudal septal strut. And so you can take that little piece of bone, sort of insert it into your mucosal pocket all the way at the very tip, and if you use a Skeeter drill, place 2 holes within that, and then suture it as a strut. I've done that in a case where we were doing a skull-based tumor. The patient had a really caudal deviation of the septum. We didn't want to put them through a rhinoplasty approach as well as a skull-based surgery at the same time, too much recovery and all that. And so that's what I used, and that actually worked really, really nicely. So that's just one other tip. All right, let's go on to sinus surgery, frontal sinus surgery specifically. So those are my disclosures, none are really relevant. There's a lot of different reasons why we operate in the frontal sinus. And, there's big tumors that can grow in that area. I'm not really going to focus on that for this talk. I'm going to really focus more on sinonasal inflammatory disease and how you can really approach the frontal sinus best for that. So, the key to thinking about any sinus surgery, I think, and frontal sinus surgery in particular, is that, of course, before you move to that surgical step, you want to have tried appropriate medical therapy. And that definition has definitely changed over the years. what I would sort of suggest that you do, there's a UCLA appropriateness criteria paper that came out about 7 years ago, and that sort of was a consensus of all expert opinions on different case scenarios. Since we don't have very high-level randomized control trial evidence as to exactly what appropriate medical therapy means, this sort of appropriateness criteria is the next best thing that we have to using, some sort of evidence to guide that approach. When that came out, what I wanted to look at was, once we have this sort of established appropriateness criteria, then is surgical therapy or continued medical therapy most appropriate for what you'd consider medically refractory chronic rhinosinusitis, right? This is the key question that all of our insurance companies are asking us and making sure that we're doing. And so if you ever need any help with getting sort of approval for something that you consider you've already used appropriate medical therapy and they need to continue, this is a good resource, because really what I showed by looking at all these papers that had been done on surgery versus continued medical therapy is really that people definitely have improved quality of life and endoscopic scores when you pool all of that data together, and unpooled olfaction, health utility scores, cost effectiveness, all of that is better in the surgical category. So that would be just one thing to consider when you're thinking about moving forward with surgery anywhere, also in the frontals. And so once people have surgery, so surgical success rate is actually really good, 85 to 90%, at least in the short term. But some patients, right, they're refractory. They relapse, they recur. So why is that? Well, the number one reason I would say is that chronic rhinosinusitis is not just one disease, right? We sort of have lots of different types of sinusitis that we're trying to treat with this kind of broad swath of medical and surgical therapy. There's broad phenotypic categories, like you guys know, the nasal polyps versus not, but that's really sort of much too broad to distinguish exactly who needs what type of therapy, like we talked about yesterday in our panel with our allergy and pulmonology guests. So endotypes are really what is the better way to think about different types of sinusitis. That's much more complex, and we're actually still discovering these categories as we do more research in which are Th1 versus Th2. That doesn't necessarily completely go along with whether it's polypoid or non-polypoid, eosinophilic or non-eosinophilic, all these types of categories. But those will help us determine exactly why some people seem to be more refractory to management in the long run. And then, of course, after surgery, there is a need for long-term postoperative maintenance and care because, as I said yesterday, surgery is great at changing anatomy, but it doesn't do anything to change someone's underlying physiology or reactivity to the environment. And so those are all reasons why someone might be refractory to management. And the frontal sinus is the most likely sinus to fail, likely because of its very narrow hourglass-shaped anatomy and the fact that if you instrument and cause trauma to the mucosa in that area, you're just much more likely to scar off. So just starting with the basics, things that we should all think about and things that I teach my residents about when they first start operating the frontal sinus, really understanding this three-dimensional spatial orientation of the frontal and supraorbital ethmoid cells is key to really understanding what your pathway forward into the frontal sinus will be. Troy, who gave us that talk earlier today, he sort of delineated nicely that you can use navigation, you can use sort of blocking and understand, what you shouldn't be next to, what you should, but really understanding your anatomy, looking at that CT scan preoperatively and building that three-dimensional image in your mind as to what you're going to see endoscopically, which cells you're going to have to go around and take down in order to get to that sinus eventually, that is really what's going to help you the most. Meticulous dissection, and then managing blood in the field, because of course, as soon as you can't see, you're not gonna be able to operate well. And just as a reminder, there's these different attachments of your unsnet process, and that's really the first step, the primary guide in thinking about how you're gonna reach your frontal, right? So if your unsnet is attaching to the lamina, which is the most common, then your frontal sinus drainage pathway is going to be medial to that. Of course, if it's attaching to your middle turbinate or your skull base, then it's going to be lateral to that. So that's the very first step in establishing preoperatively where you're going to go. And then, of course, we have these frontal cells. And the naming of the cells has changed over time, and I think we might talk about that a little bit later, but basically, regardless of whether you call these a type 1 through type 4 cell or a supraagar or a suprabular cell, the key is to really understand what is the delineation of cells as you move up into your frontal sinus. Because if you don't focus on this before you get in there, you won't be thinking about, okay, here's this first cell, I've taken it down, I have one more, or I have two more before I actually get to my frontal sinus. And that's when people leave cells. They leave residual septations. They never get to that frontal sinus. And that's one of the most common things that we see in a practice like mine, a tertiary care academic practice, is that people just haven't completed the dissection. And that's why there's persistent disease remaining behind. Supraorbital ethmoid cells, I think, are really key also to sort of delineate and identify preoperatively on your CT scan, because they're also very easy to get into, think that you're in the appropriate space, because it obviously looks like the frontal sinus. So if you got into this cell, you would see that posterior table, you would think that you're right there at the frontal sinus, you'd be all the way up superior but lateral. And you would not maybe realize, unless you had really distinguished in your preoperative scan, that, oh, I really actually need to move more anterior to that. So this is just an example of just a primary frontal sinus dissection, CRS without nasal polyps. And I'm just kind of going to talk through the different instruments I'm using. This is a frontal kerrison. This is one of my favorite instruments to use in the frontal sinus to take down more anteriorly as you're starting to move up into your frontal sinus area. And now using a probe, whether it's navigation or not, to just slide behind that auger cell into the frontal sinus. And now you can see I'm very carefully not leaving that little bony chip and shard behind, but with a non-through cutting grasper, removing it. Really clearing your field as you move forward is one of the most important steps of doing meticulous surgery. When my residents are operating, they leave all sorts of bone chips around, and there's mucosal trauma, and that's when they lose it. They lose the path. They don't understand anymore where they are. And all I have to do is step in, clear away these little bits and pieces of bone and mucosa, and then suddenly they're able to visualize again. So clearing all these steps as you move forward is the best way of seeing where you're going and getting there. And I don't know how well this is projecting, but I want to show you guys, and I'll emphasize this a little bit more in another picture, but in order to make sure that you've actually really gotten to the frontal sinus, there's a sign. I call it the horizon sign. People might call it different things, but it's basically that very acute meeting of the posterior table sloping away from you as you're looking up into the frontal sinus, meeting that anterior table sloping back. So that little, what I call the horizon sign, like you're looking at the edge of the earth, that is how you know for sure that you're in your frontal sinus. If you have opened into an area and there's a domed, curved top to that area, that is not your frontal sinus. That's the key fact. So what about if there's a bunch of polyps in your way? What do you do then? Well, you do exactly the same thing. You just skeletonize all of your normal anatomy by first removing those polyps. You can see I'm just debriding away all this polypoid tissue and showing myself where are these septations as I move forward up into the frontal sinus. Remove that thick mucin, and then you're able to take down these septations the way that you normally would with your normal through-cutting instrumentation. You can see, again, as you go all the way up, after you've removed everything, at the end there, you're going to be left with your horizon sign right there at the very end. So, there's lots of different tools that you can use. I, just as a sort of disclaimer, my patient population is not such that they are very amenable to balloons. So I would say I almost never use balloons. I use it maybe 3 or 4 times a year at most. So the tools that I use are much more these through-cutting, delicate type of instruments that you can remove different types of septations. So the frontal curette is there, but also that kerrison runger I showed you, the frontal Hosman punch is one of my favorite instruments, and then these non-through-cutting forceps to just remove these little pieces of bone as you move forward. And again, this is that final view. This is a little bit, I think, projecting a little bit better, just showing that horizon sign at that meeting of the posterior and anterior table above. And so now I want to talk a little bit about why many people leave cells within the frontal recess, it's because they're trying to avoid that anterior ethmoidal artery, right? People are worried that if they go all the way up to the skull base in that frontal recess, they're going to damage that artery or get into the artery. I think everyone here probably knows how to identify an anterior ethmoid artery on a CT scan. Just that nipple sign, you see it coming off of your lamina, there it is. But it's a little different to identify it on your CT versus knowing where it's going to come as you're approaching the skull base endoscopically. And so I'm just going to show you a little bit here. This is a relatively complex frontal recess. You have your ethmoid bulla, you have a suprabular cell, you have an auger and a supraauger cell, and then finally, above all of that is your frontal sinus. So you have to get through all of these cellular structures before you actually open into your true sinus. And how do you get through all of that without getting into your anterior ethmoid artery? You can see this is the artery, and you can see it's a little bit hanging off of skull base. So if you're just dissecting in that area and you're not sure where it is, certainly you could get right into it, right? I want you to notice that here's our posterior table of our frontal sinus. It starts all the way back here. Even though there's a little cell coming up, the posterior table where it actually starts to slope is right here. Then there's the cell behind it, and then there's the artery. That is, and this is submitted for publication at this point, but that is almost always, 99% of the time, going to be the anatomic relationship. Posterior table, one step or cell back, there's your anterior ethmoid artery. So I'll just show you here, if this plays, there you go. So I'll just show you here, this is what I'm talking about. Here's your posterior table, here's your frontal sinus going up, there's that cell that you see there, and there's that one step back. Sometimes it will actually be in a septation, and sometimes it'll only just be a little ridge hanging off of the skull base. But posterior table of the frontal sinus, one step back, there's your anterior ethmoid artery. If you just open into the frontal sinus and then dissect back, you will be free and clear every time. You will never damage your anterior ethmoid artery. That's how you do a sinus surgery without getting into there and also being complete. So now that we've established all that, why would we extend the sinusotomy? What would make me do a draft 2B or a draft 3 type of procedure? Well, like I mentioned, overall, the success rate is really good. 10 to 15%, though, will require a revision surgery. And again, the frontal sinus is most likely to fail. If you see over here, it's pretty clear why. There's an association between disease stage of that initial surgery and surgical failure. And that has to do with both the level of inflammation people are dealing with, the underlying medical, physiologic disease process, as well as how much surgery can be done in that type of patient in the first round. So short-term follow-up, recurrence may be 2 to 11%, but if you do long-term follow-up, that goes up to about 20 to 30%. So certainly the longer out you go, the more likely someone's going to need a revision surgery. And so, as I've mentioned, undissected frontal cells, probably the most common thing that we see, retained auger, retained uncinate, mistaking frontal cells for being in the frontal sinus, and those supraorbital ethmoid cells or intersinus septal cells, just mistaking those for being actually in the frontal sinus. That's probably the most easy thing to fix, right? You just go ahead, you go in, you remove all the septations, and you're golden. There's other more challenging things that can happen though, and those are things like scarring. I see this all the time. Someone's had a surgery, and that middle turbinate just swings over and sticks to the lamina. And then you have this highly adherent, bony structure, no room next to this very delicate sheet of bone, and you have to get through that into the frontal sinus. Also, just recurrent polypoid disease. That's really bad, not been medically managed. And then, of course, you can get neoosteogenesis, where you just get this block of bone where it's basically scarring and inflammation that's caused this bone to sort of grow and block off the sinus. So there's this stepwise approach. There's the obvious, draft 2A, which is your frontal sinusotomy, and then draft 2B, which is removing the floor of the sinus and the superior portion of your middle turbinate and extending that frontal sinus all the way to the septum. Just giving yourself that extra little bit of space sometimes is all a patient needs. We did a paper looking at whether there was a significant difference between draft 2B versus draft 3, and there was not actually a significant difference in outcomes in our patient population at Stanford. So you don't always need a draft 3, but sometimes you do. Sometimes there's particular patients that really need that wide, bilateral, open horseshoe shape approach. And that's when you really take that superior septum, you remove the intersinus septum, and you create this common drainage pathway for both frontal sinuses. So the stepwise approach really is just creating a superior septectomy, drilling down that frontal beak, and then connecting between the two sides. That's kind of the step-by-step approach, and I'll show you a little video. But there are indications for doing extended procedures, like I mentioned, recalcitrant disease. And then if you have extensive frontal mucoceles that you can only approach from a certain angle and you have to go from one side to the other, if you have a failed osteoclastic flap, this is a very common reason why I do draft 3s, if you have to get out a tumor, and also to help, sort of fix frontoethmoidal fractures, I'd say 10 years ago or so, you would almost never do an endoscopic sort of approach for repair of a frontoethmoidal fracture. It would always be open. Now, I would say it's very rare, maybe less than 10%, that we need any sort of open approach to correct a frontoethmoidal fracture. So here's just an example of a draft 2B. And you can see just taking a little 45 through cut and taking down this scarred area. Here's that kerosene rongeur again, and just making a very clear delineation between the lamina and that middle turbinate. Now you can see up into this space, and you might think that we're done, but you can see there's actually a blocked off portion of the frontal sinus medially. And so here's what I showed you yesterday, just taking that very top part of the middle turbinate. You do not have to sacrifice that bottom, medial, posterior portion, all the portions of your turbinate that may have olfactory epithelium on them. And then when you drill, you can just drill this part of that medial portion of the bone. You open up into this other cell, and then you've finally created a true draft 2B all the way over to your septum, and that person's gonna heal up nice and easy there. So then, there's another type of procedure that's called a sinus rescue procedure, and this is actually just taking your middle turbinate, removing the mucosa from that one side of it, and then flipping up the middle turbinate mucosa so that it sort of sticks to the skull base. So really kind of taking that middle turbinate structure all the way up, but then keeping that mucosal surface in place. This is something that you can do if, again, you're not worried about any sort of olfaction because it's so degenerated and polypoid, or if you just have normal mucosa on that one medial surface or lateral surface and not on the medial surface. This is another way of approaching extending a sinusotomy. So here's just a case. This is a 50-year-old guy. He's already had 6 sinus surgeries before. And you can see they actually did a really good job down low. This is all super nice and clear. But you can see just right at that frontal recess, and then of course up in that frontal sinus, he remains blocked. So I decide that this guy actually should get a complete endoscopic modified Lothrop because he's just so scarred off. This is all you can see. It's smaller than just this tiny little section, but this is the other side, really nice and open in there. And so you're gonna see, again, just taking that very top superior portion of the middle turbinate. First, we're gonna start on that scarred off side, remove it all the way up to the top, and then we're gonna go over the other side and do the same exact thing. Just remove that very superior portion of the turbinate so that you get really wide access to the septum, to the superior septum. And then you can see here, I'm making that septectomy. I'm going through the superior septum. You can make this in different areas, and as long as you don't go posterior towards your cribriform, you can really bring it as anterior as you want. And then you can see me coming cross court from one side to the other and starting to drill down that intersinus septum. And again, remember, I'm keeping that cribriform, that sort of little hump of olfactory tissue, making sure I don't get a leak in that area, but also making sure that I preserve all the olfactory epithelium there. And the amount of time that this procedure takes has drastically changed just in the last 5 years with the introduction of the 30K burrs. Before, when you're just drilling using 12K, this type of surgery took a really long time and it was really kind of painful. But now you can do this really, really quickly. This is something I used to use, just a little TISA elastic. I don't do that anymore. I'll show you what I do now. You can see that in this particular case, even though that healed up really nicely and remained open, there was still that little scar right in the middle of the frontal sinus that occurred. And I'll show you another example of what I do now to make sure that everything heals nice and open without any little scar there. So the question I'm going to come back to now is, what about balloons? You know, a lot of people say, well, if you just have that one little sinus that's blocked, why not just balloon it open? And there's been lots of papers looking at balloons, but when you specifically look at revision surgery, when you're doing surgery to really try to help someone that's already had surgery before, these are just a few examples of studies. You know, one in-office balloon type of dilation with frontal disease, but no data about which were revisions, and they only excluded patients with prior surgery within the last 3 months. And then this one was balloon frontal anathmoid versus draft 2A, but again, no revision patients. And then this one actually was a little bit more helpful, but just only 5 patients, and showed that revision frontal after a prior 2A or 2B was a good option if you could actually see that stenosed ostia. So I'm going to actually show you an example of a patient I thought was perfect for a balloon attempt after they had had surgery. They came in, this is when I was back at Emory, they came in, they had had surgery from an outside community surgeon. The rest of their sinuses looked great, really nice and open, but again, it was just this one sinus. And you can see, I'll just show you here. They came to see me, and I could actually see a tiny, small stenosed ostia. So I scheduled them to come back the next week because I didn't have time on my schedule that day. By the time they came back, there was no ostia left. There was just this really polypoid, sort of narrow area where I had seen this stenosing ostia just the week before. So I thought, well, this is definitely where it was. I'll go ahead and just try to feel around and make sure that there's no other area that I should be probing or putting this balloon into. And, you know, we were using the nav along with the balloon, so I could just make sure that we're going to go in the right place. I'm just delineating all the anatomy, making sure, oh, there's my anterior ethmoid artery. I want to make sure I avoid that. And so I go ahead and I start to project the balloon up into the frontal sinus, or try to. And you can see what happens. That tip just comes right back down at me. And this is a case where neoosteogenesis had been happening so rapidly that just within a week of me seeing an open ostia and the next week, it had completely scarred down with bone. So this is an example of, again, what someone needed an endoscopic modified Lothrop, a draft 3 procedure. You can see this other side that was really nice and open up here, which is a perfect scenario if you're going to do a draft 3 to have a really nice wide open sinus on one side and then be able to sort of just connect that over to the really scarred off side on the other side. So again, just taking that superior aspect. There's my septectomy that we're starting there, and then you can see all that pus coming out once we actually open into the space. And again, just starting really anterior, taking that frontal beak all the way forward, really trying to avoid this mound of cribiform and olfactory mucosa, doing everything you can. And the key to doing a draft 3 well and appropriately and completely is making sure that you continue going all the way superiorly and all the way laterally, because as you can see, as I continue to operate here, there are all these little loculated areas that if you just stop once you get into the main pocket, you might miss. So you have to just continue going, drilling all this really thick osteoneogenic bone, and really bringing that anterior table as far forward as you can. Some people will go until they just feel a sort of thin skin left. I don't feel the need to go to skin, but certainly in most cases just opening it to this thin layer of bone that you can kind of move a little bit is enough. This is what I do now. I use a steroid-eluting stent, just place one on either side of this draft 3 cavity. And since I've been doing that, I've noticed that everything heals really nicely. I don't have the need or use for mucosal rotational flaps and things like that. It just heals really nicely into a really nice open draft 3 cavity. So, what about, is endoscopic extension definitely the next appropriate step? What about the osteoplastic flap? Historically, this is what was used if you had a failed frontal sinus, right? So, is there any relevance for that? Well, back in the 70s, there was a 93% success rate with this type of procedure, so that sounds really good. But what they noticed in the 2000s was that there was also a pretty high major complication rate. And you can, think about all the different types of complications, but notable were things like frontal bossing, supraorbital neuralgia, difficulty interpreting scans. You can see over here all the different proposed substrates that could correspond to MR findings, and that makes it really difficult to follow over time. If someone is having pain in that cavity after an osteoplastic flap and obliteration, it's still really difficult to know exactly what's going on. Is this dissolved necrotic fat? Is this infection? Is this a mucocele? It's really difficult to know. But then, in the early 2000s, really the endoscopic modified Lothrop came into its own. It showed this major complication rate of less than 1%, which is much, much better than that osteoplastic flap, minor rate of 4%, and again, frontal patency of 96% at a mean of 2-year follow-up. So really this, I think, has mostly replaced an osteoplastic flap for most procedures. You can see, again, a 10-year review with still a 97% patency rate, so even very long-term follow-up. This is a really good type of procedure. Now, reasons not to do this procedure, absolute contraindications would be if you don't have training to do it, then certainly you can get into a lot of trouble. You can, get into the eye, you can get into the posterior table, you can get a leak, you can damage the frontal lobes, all sorts of things like that. And also, if you don't have proper instrumentation, then that's also difficult and you can't really do what you need to do. Relative or historic contraindications would be the anterior-posterior dimension. Again, now that we have these high-speed burrs that have all these different angulations, I think our technology has caught up with us, and now this isn't really a contraindication. You're still able to do this using the appropriately angled burr. Again, frontal beak of less than a centimeter can be overcome with newer instrumentation. And then the need to instrument a highly pneumatized sinus really laterally or along the orbital roof, maybe this isn't going to be the way to get yourself there. Avoiding complications is really just knowing your anatomy, like I mentioned before, studying your preoperative CT in 3 planes. And then, of course, you should continue to be familiar with external approaches, because when you know how to get to that external approach, then you can accept what your endoscopic limitation is. It's really when you're starting to push at the boundary of what you're capable of doing endoscopically, and you don't have any other way of helping that patient, that's when you're going to get into trouble. So keep those external approach skills sharp. Here's an example of a guy who came in with this big goose egg on his head, and he had this motor vehicle accident many years ago and then multiple surgeries over his lifetime before he came to see me. And you can see that he's got something, like a plate or something kind of floating right in front. This is maybe bone, and then maybe something else with it is what it looks like. And you can see it's just completely pushed off. He has no posterior table left in certain areas. And so this is not something that you're going to be able to really deal with endoscopically. So this is something that we opened. I did a bicoronal approach. You can see all this weird methyl methacrylate or something like that, and then this necrotic mesh, titanium mesh with necrotic fat underneath. And once you clear all that out, then you can really nicely see down into the frontal recess on either side. And this is what he looked like after, much better silhouette, and he was really happy. So post-operative care, of course, after any type of surgery you do, you should continue that post-operative care. It's really key in making sure that people remain well, dealing with that underlying pathophysiology. As we talked about yesterday, biologics are probably going to be majorly helpful in this area. And of course, partnership, like the people that we were speaking with yesterday. If your patient's allergic, they can benefit from testing and desensitization. If they're asthmatic, they'll benefit from tight control. If they're aspirin sensitive, do that desens. If they're immunodeficient, treat the underlying deficiency. And of course, if they're smokers, tell them to quit. And that's it, guys. I'm happy to take any questions.
Question over there.
Yeah, after I did that, the final repair, I actually used a MedPore implant, which is really nice inert substance that covered that entire area. Now there's all sorts of newer implants. That case was maybe 5-6 years ago. Now there's something called PEEK implants, where it's a different type of plastic, and that's even more inert and doesn't seem to migrate and shift. And you can actually 3D print different types of implants to fit a defect if you know what the defect size is going to be beforehand. So there's all sorts of new types of reconstructive options, which are great. Completely asymptomatic but bad sinus disease, is that the question? Yeah, so I think that really depends on the individual patient. It depends on whether or not I think that sinus disease is actually going to cause any sort of impending problem with the surrounding structures. So I'll look at things like, is there already bony erosion around the frontal sinus? Is it already, like eroding into sort of intracranial cavity or down on the roof of the orbit? If things like that are going on, then even if they're asymptomatic, I probably will encourage them to have surgery just to relieve that pressure, because that's probably going to worsen over time and eventually cause some sort of symptom. Now, if they're, have that frontal sinusitis and they have, instead of the erosion, they have bony thickening, and it's really kind of walled off and protected, then maybe you don't need to do anything, especially in an older patient. You don't think it's going to really advance that much. So I think it really depends on the individual patient and whether you think that it's going to continue to progress to cause some sort of problem down the line. Yeah.
You leave the propels in and take them out, and is there other things that you do at the end of the case to prevent scarring?
Yeah, so the draft 3 procedure is the only procedure that I actually put steroid-eluting stents in. In my usual sinus surgeries, I actually don't use anything or leave anything at the end of the case. For the draft 3, I do think that after a little while, that stent starts to disintegrate. It becomes these little fishbone type pieces, and then that can cause scarring and crusting and things like that. So not at the first visit, which is for me 1 week after surgery, but at the second visit, which is 2 weeks later, so 3 weeks after surgery, I remove any last residual remnant of the stent if it's still in there and hasn't dissolved on its own.
What irrigation technique do you use to deliver destinite or
Yeah, so I actually demonstrate to patients, and I have a video on YouTube that I tell them to go look at too. And I just show them that, if you have your head down and to the side, like this, and you have a really wide open frontal sinus, it's going to be able to get in there really easily. If someone has a very narrow frontal sinus, then I tell them to get their head maybe a little bit more upside down to try to get in there. And if they're still having difficulty, I'll teach them about the technique of laying on the bed, head hanging backwards off the bed with like a bucket. But that's very complicated, and most patients are not going to be able to do that or stick to that very, very frequently. And so really the head down and to the side position is what I instruct people to do. All right, guys, I'm happy to talk later too.
Thank you so much, Sarah. So over probably about the next 40 minutes, we're going to go over some complications in sinus surgery and what to do when they occur, as well as future therapies and techniques to hopefully help avoid those complications. So for full disclosure, many of these videos are ones that we've used at the AAO talk. So we give an AAO talk on complications in sinus surgery. But also for full disclosure, all of these complications I have been involved in as well. But fortunately, all those videos got lost, and the machine broke down, so I don't have evidence of my own complications, but I can show you other people's complications and tell you how to get through them. So we'll go through these pretty quickly, but you'll be pretty impressed by the videos. So sphenoid surgery, so exciting as a resident. When I was a resident, I loved these surgeries. Usually the attending is doing the other sinus case in the other room. You were working with the neurosurgeons, you're getting excited. Oh my goodness, like now there's a lot of bleeding, right? So you're like, you wanted to be a neurosurgeon for 1 second and take down the sella, and as you did, you just get massive amounts of bleeding in the sphenoid sinus. And when this occurs, it can be very dramatic, and it can be kind of life-threatening to both the patient as well as to yourself. And so this is an example of an internal carotid artery injury. Something that we always talk about, something that we always discuss, we go over in preoperative films, but sometimes we lose sight of things, right? We're in such a rush to kind of get that sella open, get the pituitary adenoma out, and we can often drift off midline. And typically these are lateral structures, and things that you can look at, which we'll talk about shortly, are the optical carotid recess and their localization. But when this happens, what do you do? And this has happened to me. So actually, I didn't end up doing it. Our neurosurgeon ended up doing it. And so I got called into the room, and he said, what do we do? And so first thing is you got to take control of the situation. You got to inform everybody involved. You're like, hey, this is going to be a big vessel injury. Be prepared. If you don't have big bore IVs, get IVs now. Check the patient's vitals. Check your own vitals, and call for help. And then ask for packing material as well. I've also read about compressing the ipsilateral carotid, and I think this is actually a really nice idea. So the whole goal is to decrease the pressure flow, because this is a high pressure bleed. So can you imagine being in this situation where you're packing the nose, so you're packing the throat with strip gauze, you're packing the nose with strip gauze, and it's coming out so quickly that you're having even difficulty packing this area. And the reason to pack this is not to stop the bleeding. It's going to continue to bleed, but you want to at least slow it down, give yourself a chance, and give yourself some time. Also, you don't want a ton of blood going into the airway, and you don't want a ton of blood coming out the nose as well, too. So Aaron O'Brien, who was one of my attendings who taught me a lot, always had a bottle of strip gauze taped to the endoscope microdebrider. And it was great because she said, look, if this ever happens or if you ever have massive bleeding, you want it there and you want it available. It's not sterile. You just open it up and you can pack the nose and you can pack it very, very quickly. So that's something that I've started doing as well, too. So when this does happen, or hopefully it won't happen, but if it does happen, you want to call the interventional IR suite. These are the people that are going to help you out of this. And what they can do is they can actually, typically they go through the groin, and they can occlude the distal bleeding artery. Now, if it's a small branch off the ICA, fantastic. That's easy. Usually it's not. Usually it's a luminal injury. And so this buys you time where you can actually, they can compress it, give you a little bit of time to kind of pack that area, put in a muscle patch, and then they let it go, and then they see how you're doing. Obviously, this comes with risks, right? So whenever you occlude a carotid artery, this is a classic balloon occlusion test that we always read about. You're decreasing blood flow to half of the brain. And so hopefully you're hoping that there are collaterals that come in from the other side. But in the patient that that I'm talking about from personal experience, this person did have some aphasia afterwards, even from just a slight occlusion. So I took a muscle patch. I've never taken a muscle patch before. I'm so glad that I read about it. It's really easy. You take a blade and you make a big incision down the anterolateral thigh. And then you take that fascia, you crush it, and then you put it within the sphenoid sinus. The reason, the muscle patch is not magical, but what it does do is it gives you a little bit of space. So this is actually with the carotid artery slightly occluded, and then you can see when it's not occluded, right? So this is a timing game. So you put the muscle patch in there. It actually secretes some chemokines that help with clotting, and then it gives you a little bit of time to be able to then pack that area, put some glue. We ended up actually using the septal flap that we were going to take for a pituitary surgery anyway to help occlude this area, and then you can get them under control. Interestingly, when I saw this patient in the recovery room as well as after she left the hospital, her biggest complaint other than her mild aphasia was her thigh pain. She said, I can't wear a bikini, and I have a big scar. And I told her, look, I'm sorry, but I've only done this once before, and I just made the biggest incision that I could as quick as I can. And I think that's okay. You can also take SCM. Some people take temporalis fascia, but it's out of your field. Typically, you've got like 4 people attacking the patient at once, and so the thigh is usually an area where you can get access to. So how about ethmoid surgery? So, this is the first time with the microdebrider. You're playing your music. You got old school 80s hip hop. You got the lights down. You're like in a rhythm. We're going to comment on a couple things of what we shouldn't be doing necessarily, but this is fun. This is polyp surgery. You get to kind of take out mucosa, and as you're going, you got your foot on the pedal, and you got a timeline that you want to go through, and so what happens here, Zara? So what's going on here, and what are some things that we could have done, or some things that you might cringe at when you're watching this patient operate?
So we all see that yellow glob of orbital fat come into view. And, I think that the key, if you ever get through the lamina, is just identifying that you've done so immediately so that you don't continue to debride, right? I think all of us have seen these nightmare cases of where the entire medial rectus has been taken, and that's when people don't recognize that they have gone into the orbit and continue to go into the orbit. And so I think the things that you could do to prevent that from happening are when you're using your microdebrider, whether it's right next to your orbit or really anywhere in the sinuses, not to just have your pedal to the metal.
Exactly, yeah.
And keep going. It's really a little tap, tap, and look, tap, tap, and look. Take it slow. Keep your visualization good. Make sure that maybe as you're right along the lamina, you're not directing your debrider right into the lamina, but instead using it up and down to sort of clear the inflamed mucosa along that area. So all of those things, I think, could help prevent that sort of injury. But I will say, once you have it, if it's just fat and not muscle, it's not the end of the world. You don't have to stop your surgery. You just continue to operate around it. You make sure you never are using powered instrumentation or suction right on the fat, and then you can continue your surgery.
So great points that you described there. One thing that I do is I always look at where the maxillary os is. So here we see where the maxillary os is here, and this plane is contiguous with your lamina. So there are times when you can be aggressive, and you can motor through cases as long as you know where you're going. But then once you see this maxillary os and you're like, hey, I'm maybe about 1 millimeter or 2 millimeters away from where that would go up, that's when, for me at least, I start taking it slow. I do often have the mouth of the port kind of towards the lamina. That was always a big no-no, right? But for me, in order to get some of that disease mucosa out, sometimes I'll do that. But you just have to be very cautious and always keep that maxillary sinus in view. In addition, in this case, I do want to highlight that this person was using like a curette for the skull base. I don't really like doing that. I feel like it tends to scrape the skull base. It's an easy way to get a CSF leak. So what I do is I always find ledges, and I always go behind the ledge because I know that the skull base is going to slope towards or higher as I go towards myself. So if I can find a ledge, I know that it's safe, and then I'll often take like a rongeur. Sometimes I will use a curette if it's really, really thick, but I wouldn't just go willy-nilly with the curette or with the angled true cuts. I found some big issues and complications with angled true cuts. And Zara is correct. If this happens, and it will happen, that's okay. So no need to reconstruct the lamina. Some people have described, taking a mucosal flap, taking some bone, putting it back up in there. I find that actually makes the situation worse. The fat prolapses. This fat is inflammatory, and it will scar down, very similar to when we do our Graves' orbitopathy. So I wouldn't be too concerned about that. But recognizing it, palpating the eye is important. So what about this case? So we're at the skull base. Zara has showed me how to do an endoscopic Lothrop. I got my 12K drill. Drill, baby, drill. This is awesome. I see the horizon, and shoot, maybe that wasn't the horizon, right? So what happened here? You see the frontal sinus over here, and then you see that cell behind it. Zara, what vessel do you think we might have gotten into over there?
Seems like the anterior ethmoid arteries.
The anterior ethmoid, the good old AEA, yeah, absolutely. And so anterior ethmoid artery, a troublesome artery. I think you did a great job identifying potential landmarks. Why it's troublesome is if it bleeds, it tends to retract, and then it can retract into the eye. And when that happens, a bleeding vessel that retracts into a fixed space can cause a lot of pressure. So here you see a lateral canthotomy and cantholysis being performed. The main goal of this procedure is relieve the pressure as quickly as possible. You want to do this very, very quickly because people have looked at kind of time, and I think it's anywhere from, I want to say like 5 to 30 minutes where you start getting some retinal loss, and people can go blind, so you don't want that to happen. And so there is a nice algorithm here. Again, communication, communication, communication. Cancel your golf tee time. This is going to take a little longer than you think. Check the eye, and then call ophthalmology. We will send this algorithm out to you folks through email or through the Socio app. It's a little bit, it's hard to remember, but again, you want to check the intraocular pressure. Some of us are skilled with the Tonopen. I couldn't tell you what a Tonopen looked like, to tell you the truth. I've never used one before, but I do have my hands, and I can feel one eye, and I can feel the other eye. And if I feel asymmetry, then that's when I get really concerned. The other thing that I want to talk to you about is that there is nothing wrong with doing a canthotomy and cantholysis. Nobody has ever been sued about doing an unnecessary canthotomy and cantholysis if you said, look, I was worried that there was an orbital hematoma. And these things can be easily fixed as well too. So classically what I was taught was you make a canthotomy, and then there's the inferior canthal tendon, so it's like strumming or strumming a guitar string. It's quite thick. And so I use a needle tip bovie when I do it, and I just cut down right to the bone. And it's successful when that lower lid just kind of droops down. And that's how you relieve the pressure. Any comments on that, Zara?
Yeah, I was just going to add that, it's so rare, thankfully, it's so rare that anyone has to do this, that if you're ever in a sinus dissection course, along with doing all your endoscopic techniques, just practicing this on a cadaver head is really helpful to just have that muscle memory of exactly, have the feel of what that guitar string feels like as you're strumming it before you cut. And I agree, it heals really nicely if you ever have to do this. Just one simple cut laterally. You don't actually even have to place any sutures to have that heal well. It just heals in a really beautiful line. Oculoplastics does it all the time and follow the patients and never have to do any sort of revision. And then one other thing I was just going to mention is you could certainly use the feel of the eye, but a Tonopen is super cheap. And it's really easy to use. It's really just like a little thing, a wire that sticks out of this instrument. You just place it to the eye, and then it tells you the pressure. So it's like the easiest thing to use, and so I would encourage everyone to just have that in their ORs while they're waiting for ophthalmology to come. Then you can really give them more information about how much the pressure is, and how much time you really have. And so I think that's actually a really useful thing to have.
Yeah, Tonopen. For me, I'd probably cause a corneal abrasion, but yeah, absolutely. Easy thing to use. So complete polypectomy. So Zara talked to us about removing the polyps. Be thorough, right? Be aggressive. Remove as much as you can. And this is somebody that's doing that and more. So again, the use of the curette towards the skull base is usually a no-no for me. Taking things out. Whenever you feel a lot of pressure, maybe taking a step back. And thinking what you're doing. And then, these angled true cuts can be helpful for bone, not so great for for other things. And so this is the biggest polyp ever that's going to come out of the nose. And it's obviously a bad polyp because it's leaking a lot, right? So this has a lot of fluid around it. So yeah, this is a big error. So what could have been avoided here, Zara, when we look at this?
So much. So I think number one, visualization is key always, right? So if there's blood in the field and you're feeling some resistance, like the first step would be stop, put your pledgets up there, topical epi. Suddenly everything is going to be much more clear to you. If this person had done that, you would have hoped that maybe they would have realized that they were already at skull base and not pulled anymore on that quote-unquote polyp. They would realize that that's not something they need to keep going at. But I do agree with you. I don't use a curette at the skull base. I think that very easily can cause fractures, especially at that very thin lateral lamella of your cribriform. And so just through cutting instruments and making sure that you're using the right angled scopes so that really, visualization is key in avoiding complications like this.
Absolutely. And this will happen to all of us. You'll get a small CSF leak, you might get a larger CSF leak, but knowing how to manage it is important. So the biggest thing for me is identifying exactly where it is. So hemostasis is important, using those topical epipledgets, knowing where your landmarks are, and then knowing how big it is. Because if it's a small one, I think a patch is actually really nice. And you don't even need to do an underlay patch. You can do an overlay patch. What you do is you just remove kind of the bone around there so it can get it to stick. One thing I will say is that surgical glues have changed so much. So I remember using like Tasil and Durasil, and you'd spray it and it would just go all over the place except for where you wanted it to go. But now they've got pneumatized sprays where you can actually bend the ports and you can get it to act directly where you want it to act. So again, small leaks, just a graft will be fine. Bigger ones, you might need to do an underlay and an overlay. And at that point, you also might want to call your neurosurgeon as well too, because they may need to end up doing a dural repair. So this is just a sped up video of how to put a mucosal patch in place. So this is what I used to do actually. I used to put a suture into the mucosal patch, put it up in there so I could localize it and I could put it exactly where I wanted to. Usually if I was doing an underlay, because then I'd be able to pull it down. But what I found when I did this was inadvertently I'd always pull it out. So I don't use a suture anymore, but what I do is I mark with a marking pen, or I mark it with a little suture which side is the mucosal side and which side is the luminal side. And again, if you do it correctly, obviously tell the patient, let them know, that's incredibly important, but these things heal up very, very nicely. CSF is actually quite inflammatory, and so it can act as a very, very nice seal.
I do think that's a really important point, Eugene, that, we actually had a whole discussion about this in our hospital where some physicians and surgeons feel that if they have a complication like this, but they are able to fix it and repair it during the procedure, there's no need to tell the patient. But that's not best practice. Best practice is really to be completely open, transparent, honest with your patient. Even if you fixed it, then they'll be even that much more happy, right? That there was something, but you repaired it, you've dealt with it. There have been numerous examples of litigation where a patient somehow found out after the fact, went through the medical record, things like that, and was not informed by the surgeon. And so that's a really bad place to put yourself. So really just being open, being completely honest and transparent. If you have a good relationship with your patient preoperatively, they will certainly just be grateful that you helped them.
Yeah, and imagine if that CSF leak patient then goes home, puts on her CPAP mask, and we've seen this, blows a bunch of air into her intracranial cavity and becomes obtunded and then has to come into the hospital. That's not the time to say, oh, by the way, I actually fixed your leak, but now it's, now it's a conduit for air. So absolutely agree. So we will have some questions at the very end. We're running a little bit late, so I do want to fly through this part because this is exciting and this is kind of future technology, and this will hopefully help us to avoid complications going on in the future. So I'm really interested in surgical education, and I want to find out better ways of how we can do that. And I think a lot of us are in academics because of that. And what I found, and this is kind of like Jacob's ladder's curse, right, is that when you are in a position, so let's say you're a cashier, or you're a supervisor, or you're a CEO, or you're the president, you get really good at what those expectations of that job is. And you get so good that you get promoted. And what happens? Then you get yelled at the next day because you're not doing a great job of what you got promoted to. And so we typically don't do a great job of kind of preparing people for that next step. You know, for us, medical student, hey, you're in the classroom. Resident, you're on the ward. Senior resident, you're doing cases. And I think it's challenging in part because of the exposure and the challenging tertiary level cases that we're getting to prepare students for that next step. So ideally, we want to do something that's more self-directed, where we can prepare future residents, trainees, fellows, attendings. I learn each and every day when I go into the operating room and when I attend courses like this. And so how can we do this? Two people really tackled this subject that were working with me. Jordan Grauer, who is a medical student who's applying for ENT from Florida, as well as Eric Bailey, who was our former fellow. And we thought, what can we do in this day and age to help people about anatomy, particularly medical students that might be interested in ENT? And so what we learned was that attention spans are getting lower and lower and lower. So it has to be 10 minutes or less. TikTok has probably shown us that it's got to be like 1:30 and less. But what we've created are videos that not only help patients and students understand anatomy, but more importantly, they also have overlays of what things look like in surgery. So that when you're looking at, you know, sinus TV or ear TV for the first time, you have a reference that you can then access on your phone. And so we've made this publicly available so people can use it on your phone. You all can use it on your phone to train NPs, PAs, or maybe even get a refresher yourselves. And there's actually a post quiz afterwards, and you can grade yourself and see how you did. So that's really important for preoperative planning. Now, Dr. Woodard had mentioned some advances that are going on in navigation systems, and there are really cool advances. And so I'll give you a little bit of a broader overview of what's going on. Just like Zara had mentioned, knowing the frontal sinus anatomy, really key in understanding how to approach these. So the Stryker group has actually partnered with PJ Wormold, where they'll take you through the building blocks of frontal sinus disease, and you can do this on your own patients through the interface, which is actually quite cool. While you're doing that, you can actually label certain structures. So this is an augmented reality overlay of a person doing surgery. And in this case, they actually reference both the internal carotid artery, because they didn't want to get into the internal carotid artery, as well as the tumor site. And these appear as AR rings that are an overlay over your endoscopic view. So again, not a thing that you should rely on, but a tool that might be able to guide you. Similarly, with the Acclarent device, they have sinus segmentation, so knowing where certain areas are within the skull. I remember doing sinus segmentation, and it took me like 5 days to segment a sinus because you had to do it all manually, because they're all threshold analyses, they're all certain gray codes, and it's all binary. But now computer algorithms can do this on our own. But more importantly, not only can they do that for the sinus, but they can also do that for critical structures like the orbit. So Exhibit B, where we were doing ethmoid surgery and we got into the lamina, if there was some type of an auditory or visual cue, that might help us avoid that. In addition, they also have what's called path to target, where they can simulate where that target is. And Dr. Woodard had mentioned that this is called fast anatomical mapping, where it can show you the extent of the surgical disease that you have. So some of my work that I get to work on in the lab is to work with really, really talented people, like Sam Barber, who's our fifth-year resident, who's got a really strong interest in VR as well as AR. John Richards, who has an awesome voice for voiceovers, as well as a really good interest in sinus surgery and education. Young Jun San, who's the head of systems and industrial engineering, and then two of his PhD students, Sirtha and then Tariq. And so what we've developed that's been homegrown and that's been really exciting is that we then manually segment these structures. We don't have an AI computer yet, But then we can take students, patients, as well as residents virtually through the nose, and you can highlight structures. So why is this important? You might think, well, this is silly. It's an inferior turbinate. This is a middle turbinate. But how many of us have actually gotten consults from our patients, from our providers, for patients who have a nasal polyp, right? And then you look in their nose, and it's just a really big inferior turbinate. And so I think there is an area where we can do a lot of education. We've combined this with 3D printing. I think David Lott did a great job of describing how 3D printing can change how we both do patient planning as well as education. And then we can put this in an immersive environment. So this is one of our users using our simulator. And then you get to hear John's lovely voice in just a moment.
Welcome to the first VR neurorhinology simulator. In this interactive teaching module, you will learn the basics of nasal endoscopy. This includes how to hold and operate an endoscope with different angled views. By practicing with a virtual endoscope, you will learn what critical structures are involved in a basic VES case. Lastly, using the virtual instruments, you will practice the steps involved in a maxillary enterostomy.
So this allows residents to get their hands on things, how to hold an endoscope. I mean, how tricky was that for all of us, right? And then being able to identify these areas, these structures, and these landmarks that you had mentioned as well. And this is all done through a head-mounted display. Relative cost is usually about $600 to $700, so very portable and very useful. So what about intraoperative tasks? So as a junior attending, one of the hardest things for me was I was torn. So I remembered my resident cap where I said, man, all these attendings are not letting me operate. I really want to operate. And then being a junior attending and being like, oh my gosh, I really don't want these residents to operate. I'm going to get in trouble. And so how do we bridge this gap? And so what I have started doing, the frustrating thing for me was like right when I started getting into operating as a resident, like my faculty would come over my shoulder and be like, okay, that's enough. It's my turn. And so you could never get in the groove. And part of that, I think, is that you were never able to see those steps forward. So this is actually what I started doing for myself. So I would take those cards that you get on your gowns. I'd flip it over, and I learned this from one of my colleagues, Grant Hamilton. And so he said every surgery can be divided into 12 steps or less, and that's absolutely true, whether it be a sinus surgery, a free flap, a thyroidectomy. I mean, everything can be broken down quite simply. And then what I did was I would then write down the approximate time that I thought it would take me, and I have my residents do this as well too. What's amazing is that when you do this, you've got this internal clock. And you're always on time. My wife is an anesthesiologist, so she says our clocks are a little bit slower than most, but to our clocks and to our head, it's always on time. And so what this has been great for is for teaching. So if any of you do have students that come in or teach residents, this is awesome because let's say Claire is in with an endoscopic sinus surgery with me or Austin. And so they've written these down and they can get through maybe step 3. And if it's taken more than the 30 minutes of allotted time and I come in, then it's mutual, right? They're excited and they're happy that they got their steps in. And I'm excited because I can keep my surgery schedule going. So I think that this has been very helpful in my practice. But also what we need to do as a specialty is divide each of these tasks into specific areas that we can then grade and that we can then caution for. So for instance, this is a maxillary enterostomy. We think, hey, it's a maxillary enterostomy, right? But this can be divided into 4 different steps, probably even more than that, but we wanted to keep it simple. These can be kept divided into surgemes or movements of how we do these. And then, what do we want to target? And then what do you not want to hit? And so if you do this systematically, I think it can actually change how we educate people. And why that's the case is that this is our AI machine learning algorithm for our simulator. This can adapt to your skill. So based on those tasks and based on how well you've done them, the simulator is going to get easier or it's going to get harder. And this is what's called adaptive learning. And this is critical because everybody knows the quote, if you take 10,000 hours to do something, you're going to be really good at it. That is absolutely false. If you take 10,000 hours to do something, you're going to waste a lot of time and you're going to still be really bad at it. But what you need is you need 10,000 hours, and you need somebody to say, hey, you're doing this right, you're doing this wrong, you should spend some more time on this, and you're okay with this. And then finally, in terms of the complications, we want to be able to simulate these complications so that this is not the first time for you doing this. So in our simulator, we can now simulate anterior ethmoid artery bleeding, and then it comes up with a coach where it quizzes you, and it says, hey, which vessel's bleeding, and then it takes you through that algorithm. Because I'll send you that paper algorithm, but unless you're doing it, and unless you've done it, or hopefully, maybe not, but this may have happened in the operating room, but hopefully more in our simulator, then it starts getting ingrained, and then it becomes natural and second nature. So finally, post-procedure feedback. This is the hardest part of my job. How do I tell somebody what they're good at? How do I tell somebody what they need some work at? And then how do I still stay friends with them? And in this day and age, I think it's harder too. People are very sensitive. And the way that we trained is different than the way that our residents are training. And I think it's better. But sometimes, like, I'm speaking Korean and they're speaking English, and we don't understand each other from that standpoint. So I think that, we all have good intentions, but if we can make this feedback a little bit more objective, then I think it can be helpful. So I'm going to leave you with this. This is a thanks to some of the people that have worked on our project. It's just a 3-minute quick snippet, but I think it'll give you the idea of what we're trying to do here in the next couple of years. Endoscopic sinus and skull-based surgery is hard, and training residents and trainees on these procedures is exceedingly difficult, as the number of hours that residents get for training decreases, the complexity of our cases increases, and the rarity of these cases also increases as well. Moreover, when patients do get complications, they can be severe and catastrophic, as we operate near the brain, near the eye, as well as the fluid surrounding the brain, and major vessels in the head and neck. This creates a clinical paradox. How, as a surgeon, can I be comfortable training residents and trainees in cases that they may not have been encountered or exposed before, without bringing them for the first time to the operating room? We've now developed a virtual and mixed reality simulator where patients, trainees, residents, and faculty members can start seeing what their pathology looks like in real life. It's immersive, and trainees are able to go into the simulator and practice these surgical procedures. More importantly, they get immediate feedback as well too, so they can learn how to operate. They can see videos of the surgical procedures taking place within our virtual coach, and then they can continue to do this for deliberate simulation.
One of the key features of our system is a virtual coach that has been developed using artificial intelligence and machine learning technologies. What it does is to automatically classify the proficiency level of each trainee, such as novice, intermediate, and expert, and then to provide a corresponding training material. In addition, the virtual coach provides real-time personalized feedback to the user, as well as immediate scoring based on various performance metrics, such as time to complete a task, avoidance of critical structures, and surgical fluency.
Utilizing 3D printed skulls, as well as surgical instruments, we are able to track these in real time, and thereby give trainees a score and performance on how they've done, and more importantly, what they can do to improve and to get better.
Virtual reality is designed to replace our surroundings with something created in software. There are gyroscopic sensors, accelerators in headset and trackers to determine how we move and track our interaction with the virtual space. 3D visualization brings tremendous advantage for analyzing the scanned image compared to any viewing 2D slices. We used CT data from a real patient to create an immersive 3D model in a virtual reality environment. The X-ray detector in a CT scanner can detect hundreds of different levels of density. It has the ability to see through tissues within a solid organ. This data is transmitted to a computer, which builds up a 3D cross-sectional picture of the part of the body and displays it on the screen.
Our overall goal is to ensure that residents and trainees and faculty members are adequately trained in these complex procedures, and to make sure that they practice on these patients prior to bringing them into the operating room.
Our device is portable, utilizes commercial hardware, and more importantly, is a multi-collaborative effort between surgeons as well as engineers designed to give you the best experience so that we can provide safe surgical care and reduce patient complications.
Well, I will end on that. I wanted to save some time for questions for Zara on her wonderful frontal sinus talk. I'm happy to take some questions on some of the ways that you can avoid complications and prepare for complications as well. I think we have about 5 minutes around, so please, any questions, feel free. Thank you again, by the way. This concludes the rhinology session, and thank you for all of your attention. Very good. So Steve had recommended taking a break, visiting our sponsors, getting some blood flow to your legs. Zara and I will be here during the break to answer any questions that you might have. Thanks again.
how's it going? Good. Good. Did you come down just this morning?
No, I came down last night.
Oh, okay, good, good, good.
Got in maybe 2 in the morning.
Oh, jeez.
Okay. So it was a long day.
Okay.
We worked all day, and then months ago, Britton Howard actually bought us a birthday present for my wife, brown kittens.
Oh, okay, okay.
So I couldn't break that pace.
Yeah, sure.
Even for you, when you came along with us.
Yeah, that's good.
And how it went really late, so.
Okay.
I have talk here.
Oh,
Can
yeah.
I use my laptop?
You can use your laptop. Yeah.
Okay.
A lot of people are doing that. So
I'll have it teed up and plug it in.
Right up there. Yeah.
All right. Good.
Yeah. I'll connect you with.
That's fine.
Yeah. Just close. It's easy. Well, I want to get to the panel because then we can see it. Yeah. So that's it. We don't have that. That will turn down. Good. Great to see you. You gonna be here there tonight for dinner?
Yeah.
Okay. Good. Oh yes. Yes. Yeah. Okay, awesome. Yeah, great to see you.
I don't want you to fall. Don't forget you're up there.
Hi. Hi.
Mike, this is Julie Brown. I don't know if you've met Mike Finney from Mayo. Oh, yeah. Yeah.
We haven't met in person, but I think we've both spoken on the phone. Nice to meet you. Julie Brown, I met him on the phone.
Wonderful. Awesome, wonderful, yeah. I know Savitas is our guy.
Oh, yeah. He was with, in our Phoenix site, University of Arizona.
You're just doing your team.
We have a great partnership. Yeah, I worked with him.
He was at Ohio State.
Yep.
Prior to that.
And we work with each other very closely. I remember.
Well, it's a really small niche.
Yeah, it is.
Just straight
It is.
neck
It's a very small field.
How long have you been here?
6 years.
Okay, and you came from?
Pittsburgh.
Pittsburgh.
Yeah. Bob, Cancer Center Director.
What any talk you like? Our winter meeting was in San Diego. Really is. I have there's
trying to get my
How are
slides
ya?
on your laptop.
Yep,
right?
it's up there. Yeah, we have your.
Oh, you found it?
Yep.
Yeah, along with all your talks. I don't,
Yeah.
we were just doing some random
Thousands of
talk, and you
files
could
there,
talk
so-
about whatever.
Could I double check?
Yeah, yeah.
That it's the right one?
Yeah. And so, Mike, this is Cecil Borelli.
good to see you again.
Yeah, I don't know if you guys have met, but
How's your finger?
It's getting better.
What? You broke it? Really?
So I've had a dozen operations
Did
since
you
then.
copy it over onto the?
So I just finally had the second joint used.
Really? Wow. Never
It
told
should
me.
be over now.
I don't think I've ever noticed that.
Yeah, it's been a challenge. So I've broken mountain wrestling in teenagers. Just not jam.
but this is
It turns out it involves space. So
Chris. So you guys already tried to put copy over her
Oh,
doc?
wait, I don't know which one you're talking. Let's see. So,
So then I put that back together, and then it was really, really ginger, and so I didn't probably do enough therapy and keep it moving, so things froze up again. And finally, threw in the towel. Because I was developing a function contraction. So now it's fused. I said I want to be able to bounce a basketball, keyboard.
Yeah. This is recent surgery.
Yeah, yeah, like these guys. So yeah, I'm free to flex this off for another 2 months.
You've been on plates with plates just going on.
Oh, yeah, so the problem is I can't find out.
Well, that's what I was like,
So I just have to accommodate. This actually gives me a lot of back pain because I can't hear the body those things. So I work with little bits sometimes. And I wind up like back or something. Hand bones connected to the backbone ultimately.
Yeah, I know. It's interesting how you accommodate for certain aspects.
that's fine, and then I'll just.
Yeah.
I mean, I could take a disability, I guess. Have a policy, but
Maybe more. Yeah, exactly. I can't imagine.
but I've got a lot of
Well, that's incredible. Yeah, that's awesome to hear.
Do not.
Able to operate and all that you can do. When I was fellowship with David Hayes was over, you probably know this, but
So just some, yeah, you can, yeah.
Okay, so we're going to get started in just a minute for our second session of the morning. And so as people filter back in, I want to just make a couple of announcements in terms of the schedule for today. So for those of you who've signed up for the golf this afternoon, the check-in can start as early as noon at the Pro Shop, which I think is just around the corner here. But the plan will be to meet with Dr. Chang at 12:45 at the Pro Shop, and then the tea time is at 1 o'clock. And so for the hike, which is still open for anyone who wants to go, be led by Sonia. And so she's going to meet everyone at 1:45 in front of the hotel. And the hike is just here. It's the Lowe's Montana Canyon Trail. It's a really nice trail, but it just goes right behind the hotel. There's a mild incline, not too bad. And the plan is not to do the whole trail, but to do about a mile and a half in and a mile and a half out, so a total of 3 miles, and she thinks it'll be about 2 hours. Nothing too intense or competitive, but it'll be, I think a really nice time to take a hike. And so anyone who wants to, you can let Sonia know or just meet her at 1:45 in front of the hotel. So with that, let's go ahead and get started on our head and neck session, and we have a really distinguished list of speakers and a pretty ambitious agenda, so we'll try to get going and get through all of that. I'm really pleased to introduce our first speaker, who's Dr. Julie Bauman, who is the director of the Hematology Oncology Division here, deputy director of the UA Cancer Center, and really been just a tremendous colleague to me since coming here. So she is going to be speaking to us about immunotherapy and head and neck cancer. Julie, thank you so much for sharing your talk with us today.
Good morning. Welcome to Arizona. I'm going to speak to you today about a really exciting topic in the world of systemic therapy and medical oncology, immunotherapy and head and neck cancer. Here is the outline, and I don't want to spend precious minutes telling you what I'm going to talk about, so let me move through this quickly to the substance of the talk. So here is the perspective of medical oncology circa 2015. Drug development in head and neck cancer was desperately slow. There was a long, dry area since the FDA approval of cisplatin in 1978 to 2006, when we had the approval of cetuximab and docetaxel. Cetuximab would go on to get a second indication in 2011. And there was a sense that we were just not keeping up with the era of molecular targeting and precision medicine, although we were slowly but surely gaining insight into the aberrant cellular signaling processes in head and neck cancer cells, specifically epidermal growth factor receptor, or EGFR, the target of cetuximab. And we came to understand that it wasn't just single nodes in a highway, but rather an intense network with which we were trying to perturb successfully to overcome head and neck cancer's wily ability to evade our therapeutics. And ultimately, the dream was that we would be able to dissect, much like as they have in lung cancer, and identify key driver oncologic mutations that would have a single key for a single lock. But head and neck cancer does not have that component in therapeutics, where personalized medicine has been incredibly evasive for us. Precision medicine was really taking off in the 2000s in the sense that we became experts in being able to identify the full genome. We defined the whole human genome and ultimately got to that place where it only cost about $1,000, only about $600 today, to get the whole genome of a cancer cell or a human cell. And we found ourselves in oncology at this very unique crossroads in that we had all of this enormous amount of genetic data, but we really didn't know what to do with it. And I love this quote: we're close to having a $1,000 genome sequence, but this may be accompanied by $1 million interpretation. And that's where I sit in the medical oncologist's office, where I have an extraordinary amount of data on my patient's tumor and still a very limited pool of therapeutics with which to work. In around 2010, a revolution started occurring in the field of medical oncology, and this is the dawn of so-called immune checkpoint inhibitors, or immunotherapy as is known. And this was pioneered in melanoma back in 2010. I never thought I would be jealous of a medical oncologist who specialized in melanoma, but I'm telling you that the revolution in melanoma has been absolutely remarkable in the ability to activate the immune system in certain ways in order to awaken T cells to battle the cancer that they've been ignoring. And this truly has been an outstanding development in head and neck cancer, which resulted in so-called immune checkpoint inhibitors making, person of the year in such esteemed journals as Science, Nature, and Time. And also has changed the face of head and neck cancer and the speed of drug development in head and neck cancer. And starting in 2016, we began to see the effectiveness of immune checkpoint inhibitors, which I'll get into more substantially with regard to mechanism. And just to give you a flavor for the number of studies that are now open in head and neck cancer looking at PD-1, the target of immune checkpoint inhibition, and the number that are accruing in head and neck cancer specifically. And this has been, I remember when I was doing my very first review article, I could go on clinicaltrials.gov and I could literally look up every single trial that was open in head and neck cancer and read it and understand it. And now head and neck cancer has become a darling of industry for the first time in its long history with regard to the development of systemic therapy. So briefly, to give you a sense of what we're doing and what we're thinking about in head and neck cancer, how do we drive this even further and in a more specific and precise way? Let me give you a brief immunology primer. Many of us went to medical school when we could barely spell T cell. A lot has been learned in that time. And here is the cast of characters that are important to the effectiveness of immune checkpoint inhibition and helps us to think, to look under the hood to understand how we might be able to make it even more striking in the benefit of our patients. So there's the head and neck tumor cell on the left, the CD8 positive T cell, that's the cell that can cytolyse, can kill a cancer cell if it has the right signals, and the antigen presenting cell, the key primer of the adaptive immune response. So head and neck cancer suppresses adaptive immunity through a number of specific signals. And let me just give you the signal 1, 2, 3 that results in the ability for a specific T cell to kill a specific cancer cell. So first of all, signal 1. That is when the MHC peptide binds the T cell receptor. And head and neck cancer has learned to get rid of that. I call it the fateful handshake, where the tumor reduces its expression of antigen and HLA so that it can't be seen and the T cell receptor cannot bind to it. So that's one of the ways that head and neck cancer hides, is avoiding signal 1. Signal 2 is the secondary T cell receptor signals. There are both co-stimulatory signals and co-inhibitory signals that modulate that initial firing of the T cell receptor. And signal 2 is where the current class of immune checkpoint inhibitors acts. It is at PD-L1 and PD-1. This is what's called a co-inhibitory receptor. It decreases the T cell's activity. And so you can imagine this is like blocking the block. It's actually the drugs enhance T cell receptor signaling by overcoming a negative signal. And then finally, there's the cytokine milieu. This is that juice that bathes the tumor in the microenvironment, made up of characters like IL-2, PGE2, TGF-beta. And I won't be focusing much on the cytokine milieu today, but that's also important to successful immunotherapy. So the history of immunotherapy in head and neck cancer is interesting. It turns out that cetuximab, the molecular targeted therapy that I cut my teeth on during fellowship in 2016, has a double mechanism of action. Now, this is a molecularly targeted therapy. It monkeys with the epidermal growth factor receptor and how it triggers aberrant growth and proliferation and metastasis. But it is also a monoclonal antibody, and for that reason, it also has a weak immune mechanism of action. And that is something that we are slowly but surely learning to exploit. But that was really all we had to play with until 2016. And in 2016, 2 PD-1 inhibitors, pembrolizumab and nivolumab, shot 2 FDA indications by demonstrating an increase in survival in patients with platinum refractory recurrent metastatic head and neck cancer. And this is a monoclonal antibody that blocks the signal, the co-inhibitory signal between PD-L1 on the tumor cell and PD-1 on the T cell. And I describe this to my patients as like the tumor is sticking out this PD-L1 saying, you do not see me, you are very sleepy. It is hypnotizing the T cell into not seeing it and doing nothing about its presence, despite the fact that it has genetic instructions to kill the tumor cell. So this is truly a remarkable change in how we treat patients. The drug is not killing the cancer, but rather the drug is awakening the T cells that are not doing their job, and they kill the cancer. So it's a fascinating class of therapeutics. Just as we have with cisplatin and cetuximab and docetaxel, we continue to struggle with biomarkers or specificity, how to tell which patient will benefit from this versus which patient will not. I now have long-term survivors in my clinic that had, fungating head and neck cancer that was refractory to every method, including surgery, radiation, and cytotoxic chemotherapy, that are in what appear to be long-term remissions in the context of this. I would like to have more of those patients, but it is a small minority, and only on the whole, if you look at the curves, about 15 to 20% of people truly benefit from immune checkpoint inhibition. So one of the things that we measure in tumors to try to get at who's going to benefit is PD-L1. How many tumor cells have PD-L1 hanging out, hypnotizing the T cells in the environment? And it turns out that that's minorly related, but it is no home run, just like measuring EGFR in head and neck cancer tumors was not predictive of who would benefit from cetuximab. So we still have a lot of work to do, and immunotherapy still in head and neck cancer is what I would describe as non-specific. So moving then to returning to what signal one, or what I call the fateful handshake. There is a lot that has to happen in the so-called cancer immunity cycle to get to that moment where the T cell and the tumor cell are in the same location. And a lot of magic can happen along the way if we could learn how to exploit the full cancer immunity cycle to get more T cells and tumor cells that match together in the microenvironment. How do we harness this incredible army in the human body of soldiers? Let's just imagine there are billions of T cells in each of our body that recognize a different foreign antigen. And the cancer is loaded with these things. How do we get the right T cells in the right place at the right time? So one of the things that's fascinating is that we have learned that the response to immunotherapy correlates with the mutation burden of a cell. So let's talk really briefly about why this matters. A non-synonymous mutation is when there is an error in the DNA code that results in a protein, an amino acid sequence that's wrong. And it's amino acid sequences that are epitopes that T cells recognize. So you can imagine a DNA with a mutation goes to mRNA and encodes a so-called neoantigen. And that's the thing that's presented to the T cell. That's the vulnerability, the Achilles heel of every cancer cell. And it turns out that head and neck cancer is one of the higher mutated tumors in the tumor genome atlas. And that is the case whether we look at HPV negative or HPV positive disease. Although the mutations may be in different genes, there is still a very large mutation burden in HPV positive and HPV negative. And this could be the key to unlocking specific immunotherapy, if you're following my drift. So this is where we are trying to drive the field. It turns out that the more mutations that exist in a tumor, the greater the likelihood that that cancer will respond to immune checkpoint inhibition. That is true across all histologies, across all anatomic sites. The threshold for the mutation burden may be different for one cancer versus another, but it is very clear that the survival relationship, the response relationship, depends upon how abnormal, how foreign the cancer is and how many mutations it has accumulated. So we sit in a field where either by viral carcinogenesis or environmental or tobacco-related carcinogenesis, we have a high mutation burden in many of our patients. It's not enough. So where we're going now is a really phenomenal place, which is called personalized cancer vaccines. This is something that I am leading at the University of Arizona. We have a trial of a personalized mRNA vaccine that is fascinating because our work in mRNA vaccines for cancer was the herald of the COVID vaccine. So this is a Moderna vaccine that I work with, but there are a number of companies, including Pfizer and Moderna, that are working at so-called personalized cancer vaccines. And let me tell you a little bit how this works. So you have a patient, you have a representative piece of their tumor. You identify their mutations by next-generation sequencing, and you use their normal cells to compare and predict which ones of these mutations, first of all, will code for an abnormal protein, and how do you predict which ones are going to be more immunogenic, which ones are going to have that cognate T cell that's going to be able to recognize it and kill the cancer. And then you somehow encode these mutations in mRNA and load it into, a capsule that's lipid-based, that's immunogenic, add some adjuvants, and then you give it to the patient. And imagine the process by which you need to do this and a real live patient sitting in front of you, and over what period of time can you do this supply chain, if you will, this development of it. And right now it's possible to do this process in 6 weeks. So let me show you a case study. This is a patient of mine. It's a patient of mine who has gone public with her story. She was recently featured in National Geographic in an article on mRNA vaccines in cancer. This is a 36-year-old non-smoking female I share with Dr. Wong. And she had T2 N2B squamous cell carcinoma of the oral tongue. And she completed adjuvant cisplatin radiation. We threw the book at her because of the pathologic features. And within 1 month, and this is literally the fastest I've seen, she had multicentric rapid recurrence in the neck, in the thyroid, in the mediastinum, and she was sick. Her radiation mucositis and dermatitis had healed, but I found evidence of recurrence everywhere in her neck. Steve took her to the operating room, did an excisional biopsy, and unfortunately confirmed that this was the case. So what would you do next? So I ask this often to an audience of medical oncologists, and these are some of the selections that we have. For example, do I test for PD-L1? Do I start pembrolizumab without doing any testing? Do I put her on cetuximab? Do I put her on some combination of systemic therapy? I had an incredible option for her at the time, which is a clinical trial that combined pembrolizumab, a PD-1 immune checkpoint inhibitor, with a personalized cancer vaccine. And this is the process: informed consent, get the archived tumor Steve had just removed for me. We were able to sequence her DNA and assure that we were able to accomplish NGS on her tumor. Then I started pembrolizumab in the clinic. So this took about 2 weeks, and her cancer was not holding still. Then she went through the pipeline of neoepitope prediction, and her vaccine was delivered 6 weeks later, and I started it with her third cycle of pembrolizumab. And this is her at baseline, at least 2 of the cross-cutting tumors that you can see where the red arrow is pointing in both her anterior neck as well as within the thyroid, recalling that these are just 2 slices of a rapid multicentric recurrence. And here is after 11 doses of pembrolizumab and 9 doses of vaccine, a total of 33 weeks, she is in a complete response. And she now maintains that response approximately 2 years later. It is truly an honor to see this kind of response. So the first cohort of 10 HPV negative patients were treated at the University of Arizona and presented at the Society for Immunotherapy Treatment of Cancer last fall. And we had, unlike a cohort of colon cancer patients where we absolutely saw no activity, we did see a 50% response rate in the first 10. Now, recognizing that is still a very small sample size, and we cannot declare victory. We are learning a lot from these patients. We are going on to accrue a total of 40 patients and moving this along the pipeline towards phase 2 and 3 development. So, my conclusions. Drug development now and clinical trial design as a whole have truly transformed in the context of omics. And omics from a genomic standpoint or from an immunomic standpoint. We have an incredible opportunity, and we are just at the dawn of beginning to harness the specificity and memory of the adaptive immune system. This has enchanted scientists for generations, and I truly stand on the shoulders of some giants. Immune checkpoint inhibitors have accelerated the development of modern immunotherapies. The toxicities, which I did not get into in this short talk, are challenging because they're related to the non-specificity, much like cytotoxic chemotherapy was, and I have a host of autoimmune toxicities that I now deal with in the clinic, and they can be very wily and very difficult to treat. So the promise of personalized cancer vaccines is the idea that this could be a universally applicable but individualized therapy across all cancers, or what I would call precision immunotherapy. And this is the direction that the field of medical oncology is now going, and head and neck cancer is part of blazing that trail. I thank you for your attention.
Thank you, Julie. Really exciting and amazing work that's been done, and many of it led by Dr. Baumann, and really an incredible story about that patient that we shared. Really amazing. So now I have the pleasure of introducing, you saw him briefly yesterday afternoon, but Dr. Cecil Borelli, one of our head and neck cancer surgeons, and he's going to be sharing with us some updates in the management of oral cavity cancers.
All right, thank you. All right, well, thank you all for being here. I will be talking about the contemporary management of oral cavity cancer. I have no disclosures. This is the outline of what I'll be talking about. I'll discuss the NCCN recommendations for oral cavity squamous cell carcinoma and discussing both the role of surgery and definitive chemoradiation therapy. We'll talk about margins, defining what are the optimal margins, what are close margins. We'll talk about the management of the neck, including elective neck dissections, watchful waiting, and sentinel node biopsies. We'll discuss the recent TNM staging changes, including depth of invasion and extranodal extension, and then we'll end on indications of adjuvant therapy. So I think we all sort of know what the oral cavity really entails. This is different from the oropharynx, obviously. Oropharynx includes the tongue base and the tonsils, and that's important because oftentimes those cancers are HPV mediated, whereas the oral cavity, which is just anterior to the oropharynx, tends to not be HPV mediated. And that's our typical tobacco-related cancers. And that includes tongue, floor of mouth, retromolar trigon, the alveolus, the hard palate, and the buccal mucosa. This is the NCCN guideline diagram for how we approach oral cavity cancers. And I think we all kind of know this as well, but for early stage oral cavity cancers, T1, T2, the preferred management strategy is surgery. And for advanced stage T3, T4, again, the preferred strategy is surgery. And really, definitive chemoradiation therapy is reserved for patients who decline surgery, or if it's unresectable, or if it's T4B or higher. But this is an interesting topic that came up again during the pandemic, in that When it first started, people were having a hard time finding operating room space, and they were unsure of the safety of performing some of these large oral cavity resections. And so this study looked at what the available data was at the time in terms of comparing primary surgery versus primary chemoradiation therapy for oral cavity cancers. And this is a systematic review, and as you can see, there are very few studies that have directly compared these two. But from these retrospective studies and this systematic review of them, you can kind of see that there is a benefit in survival for surgery up front for these oral cavity cases. So what about margins? We typically aim for about a 1 centimeter clinical margin around the tumor. And when we take out the tumor and place it in formalin, there's some level of tissue shrinkage that occurs right away. And then once the pathologist takes a look at the sample, that also increases the amount of shrinkage of your margin. So then what really is a clear margin? And this is a study that was done by Barbaris at Mass Eye and Ear, and they surveyed about 185 surgeons, and they asked them various questions about margins. And about 55% of surgeons considered a clear margin as anything over 5 millimeters. But again, 45% thought that a clear margin could be, a pathologist definition of a clear margin, no ink on tumor, if it was 1 high power field away from the edge, or even a 1 centimeter gross margin. So I think this kind of reflects there's a lot of heterogeneity in terms of what we all define as a clear margin for these cancer resections. Also, interestingly, 81% of respondents believed that a margin was clear after the initial, if the initial frozen section was positive and they re-resected it, 81% believed that the final margin was considered clear. So why are margins important? I think we all sort of know this as well. Positive margins is one of the biggest predictors of overall survival. This study here on the left is an NCDB study, a National Cancer Database study, looking at oral cavity cancers, and you can see that for patients who had a positive margin, they had a statistically significant worse overall survival. And what's interesting is that oral cavity cancers, we have a high rate of positive margins overall for oral cavity cancers. This other study on the right-hand side is another NCDB study looking at all, or the 10 most common solid organ tumors, and looked at the rates of positive margins. And ovarian and prostate cancers had the highest rates of positive margins, but oral cavity had the 3rd highest rate of positive margins. And I think that kind of makes sense. The oral cavity is a highly confined space. There are a lot of grooves and ridges, and it's difficult to 3D, to visually think about the tumor in terms of its depth and being able to get a deep margin on these tumors. I think it's a very difficult area to get a wide margin. I think tongue cancer resections still are one of the hardest things that I do, and being able to get the peripheral mucosal margins are pretty easy, but thinking about that deep aspect of the tumor is very difficult, and I think that kind of goes along with most of the oral cavity cancers. So we know that positive margins are bad and clear margins are good, but what about close margins? And so we looked at this recently as well. We did a systematic review looking at 8,400 patients. We defined clear margins as over 5 millimeters and close as 1 to 5 millimeters. What we found was that clear margins had a clearly higher overall survival compared to close margins. And involved margins had a higher rate of local and local regional recurrence, but interestingly, there was no difference in overall survival when you compared involved margins and close margins. So it kind of allowed us to frame this in a way that there was likely a continuum between outcomes being favorable for those who have clear margins and unfavorable outcomes for those who have involved margins, and close being somewhere in between. So what about frozen section margins? We all resect the cancer, and then we oftentimes will take frozen sections from either the specimen or the tumor bed, and that'll help us determine the adequacy of the resection. If the frozen comes back positive, then we can go back and take some more tissue to clear that margin. But does it make a difference? And so this study looked at that. This was also by Barbaris at Mass Eye and Ear. They did a systematic review looking at 8 studies, and what they found was that if a tumor was initially R1, so it was positive on the frozen or positive on final margin, and they went back and resected it to an R0, they still had a worse local regional free survival rate compared to those who were initially R0. And if you looked at the patients who were R1 and they cleared to R0, they also had a trend towards a better local regional free survival rate compared to a final R1, but it wasn't significant. So you can kind of see that perhaps there is still, again, that continuum, and these patients who we are clearing on the frozen section may not necessarily have the same outcomes as those who would be clear on your initial resection. So switching gears here to managing the neck, nodal disease is the most significant indicator of prognosis. Positive nodes decreases a patient's survival by about 50%. We know that in about 30% of clinically negative necks, they will still harbor occult metastasis. The NCCN recommends an elective neck dissection in patients who have a depth of invasion over 4 millimeters, and actually this might be even lower for certain subsites. And that recommendation is based a lot on this paper here. I think some of us have seen this. This was back in 2016. This was the randomized control trial that was published in the New England Journal of Medicine. They asked the question of whether or not elective neck dissections were different from a watchful waiting strategy, and that once you resected your tumor and they were clinically N0, could you observe their neck, and if they did recur, then do a salvage neck dissection at that time. And so they had 500 patients, they randomly assigned them to elective neck or watchful waiting, and they found that elective necks had a higher rate of overall survival, 80% versus 67%, compared to just the watchful waiting group. And on the subgroup analysis, they found that the depth of invasion over 3 millimeters was the significant predictor of that survival benefit. And so that is a lot of the basis of why elective neck dissections are indicated for patients who have depth of invasion over 3 millimeters or 4 millimeters. And on this same study, they found that the lymph node positivity was about 5.6% if the tumor had a depth of 3 millimeters and 17% if the depth was 4 millimeters. So, sorry, this slide did not come through very well, but so sentinel node biopsies is another important concept that we're learning more about. We know that watchful waiting is not a good strategy. And we know that 30% of clinically N0 necks will have metastasis, so that means 70 to 80% of our neck dissections will be completely negative, and we may be doing too much surgery for those patients. So is sentinel lymph node biopsy a viable alternative to elective neck dissection? And that's currently being studied. This was a systematic review looking at all the available literature that have studied this, and they're mostly retrospective studies and a few small-scale prospective or randomized control trials showing that there really was no difference between the two approaches in terms of overall survival and disease-free survival. So this is the current study that's being done right now, HN006. It's a large-scale randomized control trial looking at T1, T2, N0 oral cavities, squamous cell carcinomas. Our study, our local PI is Dr. Wong, and these are we're recruiting patients who have a negative PET-CT, and we're randomizing them either to a sentinel node biopsy or elective neck dissection, with endpoints being shoulder-related morbidity and disease-free survival. And with these results, we can hopefully determine whether or not we can safely substitute sentinel node biopsies for elective neck dissections for these types of patients. All right, so moving on to TNM staging changes. The recent updates have included depth of invasion into the T staging, and then we also eliminated T0, and part of the reason for that was the unknown primary cancers that were staged as T0. We've figured out that most of those are oropharynx primaries, and so the chances of a unknown primary being oral cavity is extremely low, so T0 has been removed. There's some minor changes to T4A. Extranodal extension has also been included into end staging, and there are a few additions to the N3 subclassifications. So depth of invasion is really important, as we've been talking about. It's really important that we discuss this with our pathologists, and we are measuring the depth of invasion correctly. And the reason for that is because if you have a small endophytic tumor that is really deep, it's very different than a large exophytic tumor. Even though the thickness might seem very similar, the depth is very different. And the way that you measure a depth of invasion is you take a horizontal line and you run it along the basement membrane from the basement membrane to the nearest normal mucosa, and then you drop a perpendicular line from that horizontal, and that's your depth of invasion. So it's important that you're not measuring the thickness of the tumor, and that instead you're really measuring the depth. So if you have a tumor that's very exophytic but has a thin stalk and a small little base, it can look very large but have very small depth of invasion. And I think that's what you have to talk with your pathologist about to make sure that you're measuring the depth of invasion correctly. And it's important because the T staging changes dramatically have incorporated the depth. So a T1 that is small and thin, or small and superficial, is less than 5 millimeters. A intermediate depth is 5 to 10 millimeters, and that upstages a tumor to T2 at least. If the depth is over 10 millimeters, it upstages it to T3 at least. So what that means is for a 1.5 centimeter tumor, if the depth is 4 millimeters, it's T1. If that depth is 6 millimeters, it's T2. And if that depth is 11 millimeters, it's T3. So you're taking a previously T1 tumor and upstaging it to a T3 if the depth is 11 millimeters. So extranodal extension is the other important change to T&M staging. And this is a nice little cartoon that depicts the types of extranodal extension. The tumor, when you have extranodal extension, you have tumor within the lymph node itself, and as it approaches the capsule, you can have varying degrees of extension. And this is an interesting study that looked at the differences between minor extranodal extension and major extranodal extension, minor being less than 2 millimeters and major being over 2 millimeters. And what they found is that for oral cavity cancers, tumors that had minor E&E had very similar outcomes to patients who had no E&E at all. And major E&E was the major differentiator in terms of survival. We don't necessarily use this currently in our staging system, in that we don't differentiate between minor and major for these patients, but it is an interesting thought in that not all E&E is the same. And so again, it kind of goes back to talking to the pathologist and understanding the tumor biology and determining what level of E&E that we're talking about. So the staging system that has now incorporated E&E is right here. It basically, for a single node that's less than 3 centimeters with E&E, it upstages a tumor from N1 to N2A. If you have multiple nodes with E&E, it upstages the tumor from N2 to N3B. All right, and so this is my last slide. These are the indications for adjuvant therapy. This largely has been unchanged over the years. So this is the diagram from the NCCN. If you have no positive nodes and you have no adverse features, you can observe these patients. Adverse features being close margins, T3, T4, N2, N3, nodal disease in levels 4 or 5, perineural invasion or lymphovascular invasion, or if you have extranodal extension or positive margins. And so if you have one positive node without any of those adverse features, you can either consider observation or radiation therapy depending on the situation. But if you do have adverse features, you're automatically recommending radiation therapy. And then if you have extranodal extension or positive margins, then you're doing chemotherapy plus radiation therapy. All right, that's it. Thank you. Appreciate it.
Well, thanks so much, Dr. Borelli, and hopefully we may be able to talk about those, some of those issues in the panel that we'll have later. But next, I'd like to introduce our next speaker, who is another key member of our multidisciplinary head and neck cancer team here at the University of Arizona. Dr. Jared Robbins is an associate professor in the Department of Radiation Oncology and also the residency program director for their department. So there's a bit of a theme in the next three talks, and you may even get some different perspectives. But we're going to go through in the next few talks some updates on some of the more recent clinical trials. And the theme here is that, I think that a lot of the trials are looking at not just oncologic outcomes, but functional outcomes as well. And I think that really represents a growing realization of how important functional outcomes are to our patients. And so a lot of the trials are focused on that. And so we're looking forward to Dr. Robinson giving us a review of, in particular, some of the radiation-focused clinical trials in head and neck.
Thank you, Dr. Wang. I'm excited to be here and talk to a bunch of surgeons. So I'm grateful over the course of my career to have worked with some great surgeons, people who we've been able to work really well together, people who I've learned a great deal from. So as Dr. Wang had mentioned, I've been tasked to talk a little bit about some of the head and neck clinical trials and what we're doing there. So here's just kind of a list of some of what I would quote historic trials, things that have laid the bedrock for modern radiation oncology and for radiation management of head and neck patients. So you can see up in the top that some of the historic ones that really have defined the role for radiation in the definitive and in the post-op setting. RTOG 7303 was one of the first randomized trials to look at definitive radiation compared to surgery, which found equal outcomes. The Parson analysis also under there was another big one that looked at outcomes for radiation versus definitive surgery and found equal outcomes but less severe toxicity in the radiation arm, which helped establish radiation as one of the definitive options for managing head and neck cases. There's been a lot of trials over time looking at some of the doses of radiation and different ways of delivering radiation with different fractions and multiple times per day and such. And these have really laid the foundation for what we have here. There have also been technique-driven clinical trials that show us that IMRT is better than 3D, for example. And these have been really key in establishing IMRT as the standard of care for managing head and neck patients. There was also a whole host of trials focusing on chemotherapy, when we should give chemotherapy, does chemotherapy benefit, which is over on the right side of the screen there. As well in the postoperative setting, when do we give radiation, when do we add radiation and chemotherapy? And then at the bottom, some of the organ preservation studies. These are sentinel. Most of them are old these days. We haven't done a whole lot with that recently, but they have certainly set a precedence for organ preservation with radiation. And it is upon these that I want to start talking. So this is kind of a foundation and then where we're going right now. So when I think of modern radiation oncology, I kind of think of this trial, RTOG 0129. So this is a phase 3 trial. This was accelerated radiation versus with chemotherapy versus a standard fraction radiation with chemotherapy. They did 2 different radiation doses and kind of ways of delivering it as far as the dose you're receiving per day. They gave cisplatin 100 milligrams per meter squared, which is a standard. And what they found was that there was no benefit to the accelerated radiation with cisplatin. But what was interesting with this trial is they went back and they looked at the pathology specimens of the oral pharynx, and they looked and they identified P16 positivity or HPV relation in about 300 cases, and they looked at these a little bit closer. When they looked at this by HPV status, they saw a significant difference in outcomes based on the HPV positivity. We have almost, at 5 years, the survival is almost doubled in the HPV positives, as is the progression-free survival. They looked at this a little bit and they made a nomogram, and they identified the key features which were important for these patients' outcomes. First, it was being HPV positive or having that HPV relation. Second was pack years of smoking, and statistically they found that to be about 10. And then they looked at some of the other things like nodal status or T4 tumors. And they identified this low-risk group here that had less than 10 pack year smoking history, had relatively low volume nodal disease, and they classified them low risk. And when you look at this group, you can see at 5 years now that low risk group does almost 95% overall survival, which is a real game changer. So it's not often in the course of your career you have a new disease that defines and shapes the way that you treat cancer, and this is really one of those. Because of that improved outcomes, all of a sudden it becomes important to think about some of the long-term consequences of our treatment, which we may not have thought about before. And just to show some of the responsiveness of these HPV tumors, so this is a slice of a CT scan through the primary tumor in the tonsil of a patient that I treated. This was the day of simulation, so when we worked up his radiation, and then every week he had a CT scan as part of the treatment to show his tumor. So you see the tumor is the yellow right here. You can see after 5 days, you already see that tumor shrinking in. You see more airspace back here. That keeps going, and by the time you get to 3 weeks, at day 15, you can hardly see a tumor at all, and you're just treating the area where the tumor was. Again, just showing some of the great sensitivity these tumors have to chemo and radiation. So with these great outcomes, we start thinking about, okay, if we're doing so great taking care of these tumors, what can we do to reduce some of the toxicity? And there's a lot of different strategies that have been implemented as of late. I want to touch on a few of those with this. The one that I'll touch the most on is related to the radiation. So can we reduce the radiation dose? And we'll talk about a couple studies that are doing that. Can we reduce the radiation volume? Can we change and treat a different area? Or can we better define the areas that are at risk? Third, can we reduce the margin? Can we use daily imaging to reduce the need for extra margin for setup? Can we do a couple other things to improve? What about if we change the chemotherapy? Can we try something less toxic like cetuximab or a lower dose of cisplatin or immunotherapy? And I'll talk about that. Can we use chemotherapy to induce response in the tumor so we can treat a smaller area? So there's a couple of trials dealing with that. I think one of the really interesting and upcoming areas is the last one, using surgery to reduce adjuvant therapies. And so there's two big trials, ECOG 3311, and I also think the Mayo trial is very innovative, the DART trial. I didn't talk a lot about those because I have two esteemed surgical colleagues who can give a lot more insight on those, Dr. Wang and Dr. Henney. But those are both great trials. I think we learn a lot about radiation from those trials, being able to potentially reduce some of the adjuvant radiation dose. And with Mayo, their trial is really innovative because they did an innovative radiation technique by giving it a lower dose and twice a day. So when we talk about dropping the chemotherapy, so one of the studies that really set the precedence for this was the Princess Margaret study. So they looked at about 277 HPV positive tumors. Most of these were treated with accelerated radiation, and some of them were treated with chemoradiation. And they looked at it, and they kind of looked again at that low-risk group. So they looked at the low-risk stage 4A patients who were limited smokers. And what they found between the accelerated radiation and chemoradiation, there was no real difference in their outcomes. So the overall survival was the same, the local control was the same, and the distant control was also the same. So they kind of postulated that maybe this moderate accelerated radiation alone would be something to consider for HPV positive low-risk patients, excluding the T4s and the N3s. The UNC Florida group kind of thought about not just dropping the chemotherapy, but maybe changing the radiation. So they piloted a phase 2 trial where they did 60 gray, so they dropped 10 gray, and they gave IMRT, so about a 15% reduction in the radiation dose. And they also changed the chemo, the cisplatin, from 100 milligrams per meter squared every 3 weeks to 30 milligrams weekly, which is about a 40% reduction in chemotherapy. So patients that were eligible were fairly low risk, so they were T1 and T2s, N0 to N3, P16 positives, and they had a limited smoking history. So the first phase of this trial, they were a little concerned that if they didn't fully treat these patients, so all the patients had post-treatment biopsies and resection of positive nodes 4 to 6 weeks after radiation. On those specimens, they found a pathologic CR rate of 86%, 98% at the primary, and 84% at the nodes. So with that good of a PR, they went ahead and did that extra on the remaining patients. So most of the patients were actually not treated with those extra biopsies or resections. At 2 years, their overall outcomes were very good. So their local regional control was 95%, distant metastatic free survival was 91%, progression-free survival was 86%, and overall survival was 95%. If you drop the dose and you drop the chemo and you do a great job with the tumor, how did you do with the side effects? And this is just some of their patient-reported quality of lives and the EORTC OLQ scores showing that patients did favorably well as far as toxicity, and they did have recovery after their radiation. So based on these two trials, the NRG did a national trial looking at these two arms. So it's a 300 patient trial where one arm was the UNC Florida style, where they decreased the radiation and the chemotherapy. The other arm was Princess Margaret Hospital, where they just dropped the chemotherapy and gave the radiation a little bit faster. And their goal was to try to achieve a progression-free survival of more than 90% and a one-year MDADI score of greater than 60%, or greater than 60. So these are first their toxicities, and as you can imagine, the patients that got cisplatin did have a worsening, several worsening things with their lymphocyte count, with their dysphagia, white blood cell count decrease, neutropenia, vomiting, as expected. These are their results. So their PFS was 90% for the reduced radiation and chemo arm, 87% for the IMRT alone arm. And both groups achieved the MDADI score of much higher than 60. They were both in the low 80s. So this showed that the radiation plus cisplatin arm was sufficient to consider for further clinical trials, whereas the radiation alone arm wasn't. And that kind of, again, is a building block for the next clinical trial. So this is a clinical trial that's currently open nationwide. We have it here at University of Arizona. And it is a 3-arm trial. So one arm is a standard of care. So we had to make sure that we weren't sacrificing oncological outcomes for these patients. So the first arm is the full dose radiation with cisplatin. The second arm is very similar to the arm that was studied with the reduced radiation and chemotherapy. And the third arm is a new arm. So we just heard Dr. Baumann talk a lot about immunotherapy and how promising it was. The third arm is IMRT with immunotherapy. This is a great trial. It's a great option for people with low-risk disease. And we've had multiple people on it, and they've all done very well. So the other question, can we alter the chemotherapy? So cisplatin can be very toxic. One of the options, it's kind of the fallback, is cetuximab, which is a monoclonal antibody that inhibits EGFR expression. And it has different side effects. Most of these are skin reactions that people have. This is actually one of the first drugs that are targeted agents that was used with radiation that had a positive outcome. And that's the graph there showing an improved outcome versus radiation alone for head and neck cases. So there have been several trials looking at, can we take out cisplatin and use cetuximab? The largest is RTOG 1016. There's also a De-Escalate, a UK trial, the ART-SCAN, which is a European trial, and the TROG, which is from Australia. So all 3 trials asking the same thing. They did their chemotherapy a little bit differently, but fairly similarly. All of them found that there was no difference in acute or late toxicity, which was surprising. Again, not what people expected. The thing that they found that was a little disheartening was that the outcomes were worse with cetuximab, so you can't, in fact, switch out the chemotherapy. To kind of hone in a little bit on that, can you change the cisplatin intensity? So there was a big trial done at Tata Memorial Hospital in India asking if you can do 30 milligrams per meter squared weekly versus the standard of care, 100 milligrams per meter squared. And what they found is that you can't. So your local regional control was again lower by having that lower dose of cisplatin. And this was in all head and neck patients, not specifically HPV positive patients, but it does at least raise some alarms that when we try to de-escalate too much, we sometimes do a disservice to our patients, so we must do that prudently. There are a couple of trials that are continuing to try to switch out some immunotherapy. So the Key Chain is an innovative trial that we're part of. It's a phase 2 trial, and it's for cisplatin eligible patients, so they have to be good performance and good kidney function, but it's switching out the cisplatin for pembrolizumab, and this is in HPV positive tumors. The primary objective for this is progression-free survival. And I'm actually really excited about this. The people that we treated so far have gotten through the treatment very well and had great responses with minimal toxicity related to their immunotherapy. So I think it's a great option for people. And for those people who aren't eligible for immunotherapy, trying to build upon the cetuximab This second trial, HN004, is replacing the cetuximab with durvalumab. That's currently been going for several years and currently under interim analysis. You know, the technology that we use for radiation has really improved our outcomes and what we can do. Historically, we had large fields. We didn't have to think too much about what we were treating because we treated everything, and that led to a lot of toxicity. But IMRT has really changed that. We have better distribution of dose to the tumor. We also can spare more normal structures, which leads to better quality of life. So the panel on the bottom just shows the 2D, the old school radiation, to a little bit more modern 3D conformal radiation, and then IMRT. And you can see how much more conformal the radiation dose is and that we're really hitting only the spots that need to. Again, this just shows a couple of plans where we're really able to put the high dose where the tumor is and reduce a lot of the toxicity. This is an unusual patient that I treated who had melanoma all over her scalp and down her neck, and you can see how conformal and nice those radiation plans can be. This lady is a long-term survivor of that. And you know, as we know more, we have to gain a lot of insight into what we treat, and not just how tumors respond, but also what can safely be treated. And we lean on our surgical colleagues a little bit for this. So down at the bottom, we see a trial from Hopkins, where they went in and they dissected out a bunch of lymph nodes in different areas to see where there was occult disease. And in these places, 1B and level 5, there was pretty low risk of having nodal disease. So those are areas that we can potentially now spare when we treat, which will help with some of the toxicity. Again, along that same vein, this is a small study that was done at University of Washington University. In A, you see how they were treating initially. Then they started relaxing on some of the areas like the high retropharyngeal lymph nodes, and then they gave up on the retropharyngeal lymph nodes and the retrostyloid lymph nodes. And what they found that there was no recurrences in those areas, again showing that we were over-treating before, and now that we can hone in on those areas that really need radiation in the future. Similar work was done in Denmark, again showing that we can spare some of those areas with low risk of recurrence. This is actually something that was published last week. So this is from Memorial Sloan Kettering, a retrospective study of about 300 patients. All of these were low-risk patients, and what they did, just as an institution, they reduced the elective nodal dose. So when I treat, I typically treat bilateral necks to a risk-adapted dose, and here they said we're going to treat everything to 30 gray and 15 fractions, which is quite a bit less than what we normally would, and then they coned it down and give 70 gray to the gross disease, which would be standard. They also avoided those areas that I talked about, the high retropharyngeal lymph node basins and the 1B and level 5s. What they showed is excellent control and outcomes, and very good toxicity. They had only 8 failures. 7 of them were primary site, 1 in the persistent node. And then as far as feeding tubes, they had a 6% feed tube rate at 1 year, which was pretty fabulous. So also their quality of life composite scores were great, again showing that. This is another study that tries a different method. So they use induction chemotherapy to change the radiation volume and the radiation dose. So people would get induction chemotherapy, and based on that response, they would change their dose. So if they had a great response to good responders, really just got dosed to the primary disease with some margin. If they were non-responders, then they also treated some elective nodes. And they had very good outcomes as far as cancer, and then also as far as toxicity. So, it is a surgical meeting, and I think there's a lot of interesting things happening right now in comparing radiation, upfront radiation versus TORS. One of the big trials, or it's not really large, but one of the prominent trials was the Orator trial, which was done mainly in Canada. And this trial was actually set out to show that surgery was superior as far as their swallowing outcomes, and it was designed as such. But it was about 70 patients, 34 on each arm. And they got radiation or TORS, and then TORS was followed by adjuvant therapies. Both arms had very good cancer outcomes. What was shown is that the radiation had slightly better outcomes, although they were statistically significant but not clinically meaningful, showing that something that we thought was true when we actually did the study, it came out a little bit different. And I think there's a lot of reasons for why some of the long-term, the toxicity issues were a little bit different, and this can be everything from changes in surgery or having to do adjuvant therapy afterwards. But I think it still goes to show that sometimes when we lead into a clinical trial, we may not fully anticipate some of the results. They just released their long-term update within the last month, And when you look at the groups in a whole, certainly there's no statistically significant difference, or clinically significant difference, but when you look at some patients, like the base of tongue tumors, there is a statistically significant and potentially clinically meaningful difference. This was an ad hoc analysis, so you can't put a lot of weight into it, but I think it does show a little bit about something about a selection of our patients, who would benefit from radiation versus surgery. There were some indications that adding additional therapies on had worsening outcomes for their MDADI over time, which I think is important, and again, just emphasizes that we should try to avoid trimodality therapy when possible. The last thing I just want to touch on very briefly is the Orator 2. So this is a second analysis building on, this is the second study building on Orator 1, where they use for HPV positive tumors, they use reduced radiation doses, both in the adjuvant and in the definitive setting. So the radiation was very similar to what was done from the UNC Florida group with reduced radiation and reduced chemo. The TORS, they gave radiation similar to 3311 on the intermediate arm, the low-risk intermediate arm. This was intention to treat analysis. This was reported in November at ASTRO. And as far as the results, you can kind of see the surgery results. So about half the people got a bilateral neck dissection. Positive margin rate was 8%. Adjuvant radiation in about 3/4 of the patients. The radiation dose is really 60, so 3/4 of people got chemo. From an overall survival and a progression-free survival, radiation did wonderfully at 100% for both. There were some events in the surgery arm, both deaths and progressions, that ultimately stopped the trial. From a toxicity perspective, both were good. The one thing that was unexpected was there were a couple of deaths on the TORS arm, one from bleeding and one from cervical spine osteomyelitis, which impacted the progression-free survival and the overall survival, and eventually halted the trial because it met the grade 5 toxicity ruling. So they won't finish this trial. This is the end of it. They didn't finish their accrual, so they got about half the patients that they wanted. And I think this is another, again, where we didn't quite get the result that we expected from our trial. And I think it means when that happens, we go back to the drawing board and figure out how we can make things better. But again, we've made a lot of progress in recent years with head and neck cancer. Clinical trials are the building blocks for advancement. When we put people on clinical trials, we not only treat the patient, but we prepare for the future and prepare for improving outcomes in the future. So I encourage all of you, when you have a possibility, to get these patients on clinical trials so that we can keep getting better. And again, thank you for the opportunity to talk.
Thanks, Jared. That was a wonderful, really whirlwind tour, but really hit some of the key highlights of those clinical trials. I have a little bit more to say about those last two trials in my talk. But first, I want to introduce, really it's my honor to introduce, let me get this other way so you can start setting up. Oh, no, that's fine. You don't need to. Oh, okay, there we go. But, yeah. It's my pleasure to introduce one of our really distinguished invited speakers to our meeting, Dr. Mike Hinney, who's the chair of the Department of Otolaryngology at Mayo, Arizona. He's going to share, as was mentioned, some of the really exciting work in clinical trials that has been done across the Mayo system. And in addition, I'm really just pleased to invite him to Tucson. I had the pleasure of joining the Mayo group at their meeting, which was one of the last in-person meetings that I attended. It was March of 2020, but that was a wonderful time that I had, and really am looking forward to Dr. Hinney spending some time with us down in Tucson.
Stephen, thank you so much for the kind invitation. It's a great talks, kind of hard to follow. For those of you that are from out of state, as a fellow Arizonan, apologize for the weather. This is literally freezing for us. If it helps, I have this on a USB and could use his computer with that. I was thinking about this before. I apologize.
Do you have videos? Okay, then it should be fine. Yeah, it should be fine. Okay. Oh, yeah, is this? Here. How do I make the?
Oh, yeah, you can see it.
Not used to that. Advanced.
There you go. And then, square back.
Never good to have such an inauspicious beginning. So Stephen asked me to talk about de-escalation therapy. And I'm going to share with you primarily the work. It's a brainchild of one of our radiation oncologists. His name is Daniel Ma. He trained at Washington University in St. Louis and then joined the Mayo Clinic in Rochester. And I have been partnering with him. I do have disclosures. My employer licensed my laryngoscope design to Carl Storrs, and then some textbooks. So this is how I was taught to do surgery when I was a resident, and for pretty much all oropharynx cancers, this is what we did. And amazingly, the patients were agreeable to do this. Today, folks are really uncomfortable. Your patients, they don't want to have this. I don't really blame them. This is pretty morbid. So is this, by the way, because the pendulum swang away from surgery toward non-surgical chemoradiotherapy. And this is an awful outcome, and fortunately relatively uncommon, but it happens. This is 70 gray with cisplatin. So this has given way to endoscopic or transoral operations, which Americans have been gradually adopting over the last couple of decades or more. Creating a wound like this, transorally, no tracheostomy, hospital stay of 3 days instead of 10. And you get a wound like this, and as the scar naturally contracts, it knits the pharyngeal muscular back together. There's sensation rather than a non-sensate skin paddle from a flap. And functionally, these folks do really, really well. So I've been hearing this, for years when I talk about transoral surgery or endoscopic surgery, which by itself is de-escalated, right? And, what's the big deal? Everybody gets radiated anyway. True or false? Is this true? I would argue no, because nearly a quarter of the patients in our practice have surgery, margins clear. If they've got low volume neck disease, they get observation. Those are the luckiest folks. They're functionally as close to normal as you can get. Often the primary site can avoid a boost. I'll share a paper about that. Local control is excellent. I'll share a study suggesting that chemotherapy is not guaranteed in this case, and that the morbidity is lower, certainly than traditional surgical treatments, as well as concurrent chemoradiation is 70 gray. This is probably the most important slide I'll show. Every radiation oncology textbook will have this in there someplace. And what we've discovered is that, and not just we, I think head and neck multidisciplinary groups everywhere, most of these patients are going to get radiated, 3/4 of them. And whatever you can do to reduce that dose is going to improve functional outcomes later. So after 10 gray, if this is the long-term HER2 curve, turn your tissues to scar curve here on the y-axis, 10 gray, 20 gray, 30 gray, 40 gray, very little long-term consequences to your pharyngeal musculature, salivary glands, teeth, bone, etc. 60 gray is about right here. The difference between 60 and 70 is just a week. Doesn't seem like much, but you're on the logarithmic part of the HER2 curve at that point. So everything we can do using surgery in this case to get this dose to this dose is going to improve outcomes. First speaker talked about standing on the shoulders of giants, and certainly the famous paper by Giza Jakob and Stuart Strong, 1972, brought endoscopic surgery essentially to the world. They were the first to do this. I had the privilege of meeting the two of them in Boston when our academy met there some years back and got a picture. They have since passed on. But this type of surgery requires new and different understandings of your anatomy. You have to learn it from the inside out rather than the outside in, as we learned in books
and in cadavers and when we did our surgery training. And it's different. De-escalation. This is an old study now from 2009. These were my cases. There were now 69 patients that had oropharyngeal cancer treated with surgery only. A third of them had indications for radiation but refused. We see that a fair bit. And even that, there were just 3 local recurrences in this group. And this represents, I think, not that we're such wonderful surgeons, but we have a more wonderful disease with HPV, makes everybody's data look better. I'm blessed, as I think the relationship here looks really solid, to have radiation oncologists that are cooperative. In many medical centers, it's cats and dogs with surgeons and radiation doctors. But perhaps in part because of our salary, flat salary, we were able to get our radiation doctors interested in transoral surgery instead of competing. They get paid the same, whether you do 6 weeks or 7. And one of our radiation doctors, in a single institution study, usually at academic centers, single institution, you'll find your best outcomes, but there were no local failures in this group of 80 patients that had margin clearing surgery and IMRT and follow-up. Throw this in here just for interest. This is from our center, and there's a lot of lines here, but the point I want to make here is that surgery alone is the cheapest treatment as a cost to society. And in our center, if you had transoral surgery, focus on the private payers, cost to society, $25,000. If we added radiation to the surgery, then it was up to $75,000. And if we added chemo and radiation, then it's $145,000, and surprisingly, no surgery was the most expensive treatment. And a lot of this came down to hospital admissions midway through from dehydration, needing a PEG at 3 weeks. Those things actually become super expensive. So how else can we de-intensify? One of our radiation oncologists published this paper, mucosal sparing radiotherapy. So the challenge was standard of care in radiation circles. If you need to radiate because of neck disease, the primary is always boosted, whether the margins are clear or not. And so the challenge is, well, just because Dad did it that way, why do you need level 1 evidence to stop? So anyway, we began to not boost the pharynx if the margins were clear, and outcomes were quite good. And so this is additional de-escalation therapy, and we offer this together with the DART trial I'll get to as standard care now in our center. And this is what the radiation treatment fields look like. You can see that for a tongue-based tumor or a tonsil tumor, a lot of the pharynx and musculature is getting no radiation or a lower dose down here around 40, 45 gray. So here's a question for HPV positive patients, because we all think we're probably over-treating them. Do you have to give them 60 to 66 gray? This was a famous paper on chemoradiation from Cooper. This has been quoted a lot. Adding chemotherapy improves control and survival. No question about it. There are some long-term consequences to this, though, in terms of all-cause mortality when you get out to 10 years. But I just remind you that this difference, while measurable, is not enormous. My buddy Bruce Hoey, when he was back at Washington University, did this study. These are patients that had single modality therapy. Recurrence rates are higher, but the overall survival is not, because they can be salvaged. And this work also revealed that when chemotherapy was used, they could not measure any benefit in HPV-positive disease in folks that had upfront surgery. Additional de-escalation. So this data was mentioned by the prior speaker. It was just presented this past fall at Astro. And we've been working on this going back to like 2007 now. And this is the MC 1675 phase 3 evaluation of de-escalated adjuvant radiotherapy, or DART, versus standard of care. And I'll share this study with you before closing. The first study, this was a phase 2 trial that inspired this, used patients that were then randomized to either 30 gray in one arm or 36 gray with docetaxel, and then they were observed. And they had before and after quality of life and swallowing scores done. And they also had, of course, upfront margin clearing surgery and neck dissection. So why 30 gray and why twice a day? Well, it turns out that if you give it twice a day, rapidly dividing cells are more susceptible to the radiation. So you get a little extra bang for your buck with no additional harm to slow dividing normal tissue. And the folks tolerate this really well. So the radiation after the surgery, the post-op radiation, is done in 10 days. You're done in 2 weeks. And why give docetaxel? Well, it's been shown to be effective in the laboratory. These are cancer cell lines grown and radiated. And if you give docetaxel, it freezes the dividing cancer cell in metaphase. It's a microtubule inhibitor, which is the most vulnerable part of the cell cycle for radiation to kill it. And it's been used in numerous head and neck studies, including RTOG 0234, where docetaxel was used, as well as JCO 2009. It has relatively low toxicity. The dose is, it's only 2 doses, and it's a low dose. Tolerated very well. So these were the initial outcomes. Operating, clear margin, neck dissection, and 2 weeks of radiation twice a day with docetaxel. The overall survival is 98.7%. Say, maybe it's time, for a phase 3 trial here. So what I'll report next is the 2-year results from that phase 3 trial with 2 weeks of radiation compared to and randomized against standard of care being upfront surgery with traditional 6 weeks or 60 gray. And here's the schematic for that trial. And many of you, I'm sure, have seen this. There's a baseline quality of life score. Oops, sorry. Oh, I got lost here. Baseline quality of life score, and then baseline swallowing tests. And the folks were randomized to cohort A or B to receive either 30 gray or 36 gray. This is T3 tumors and smaller, and N2 neck disease and less. The T4 cancers and more than N2A were not included. So the primary endpoint was having grade 3 toxicity, or greater than grade 3, equal or greater than grade 3 at 3 months. The study was appropriately powered. Additional endpoints were overall survival, local regional control, and progression-free survival. We also evaluated swallowing as well as quality of life using all of these quality of life metrics. The percentage of T1s, 2s, and 3s comparing standard of care to DART are quite similar. And the nodal stages comparing the standard of care to the DART trial also really quite similar. So the groups were, I think, appropriately matched. Adverse events, grade 3 toxicity at 3 months, 1.6% for the DART trial versus 7% for standard of care. That approached significance. And of note, 1.6% of the patients in the DART trial had a feeding tube versus 27%. And that was highly significant. So it seems like adverse events favor or support using this DART trial. This was the quality of life data, and essentially, no surprise, swallowing was superior in the DART trial than standard of care, and quality of life was measured in terms of less pain, less xerostomia, and favored the DART trial versus standard of care. Overall survival, identical. We had a slight reduction when there was extra nodal extension in overall survival. Again, not significant. Probably underpowered to prove that. Local regional control, it's the same. Progression-free survival fell off a little bit for the DART trial. And bottom line on why that happened is for N2 disease with extranodal extension, I think we have to have a little bit of caution using this particular de-escalated therapy trial, because we did see with large volume neck disease, that's PN2 and DART, there was more recurrence. Overall survival wasn't different, meaning these patients were salvaged, but you have to be a little careful with N2 disease. So are these results durable? So far, so good. And we have 2-year data was just presented. 5-year data is now out on the phase 2 trial, and we're combining these folks, and we're planning a second DART trial that's currently in development. And there's a big private group that has also so far been able to duplicate the data. It doesn't seem to be a single institutional outcome. So in conclusion, the DART demonstrated less toxicity, improved swallowing function and quality of life when compared to standard of care. It had excellent overall survival rates, local regional control, and progression-free survival, particularly in the ENE negative cohort. You have to be a little cautious, as I mentioned, for N2 disease, and future work will define the risk groups which may not require adjuvant care, and the role of systemic intensification for groups that are higher risk or with distant disease. So I just want to point out the primary folks that are participating in this. The most important guy, where is Dan? He didn't put his own picture on his own slide. I borrowed this from him. Anyway, Daniel Ma is, this is his work, and I'm just sharing it because Stephen asked me to, so thank you for your time. I hate to just pull this out.
Yeah, just pull that out. Okay. Thanks so much, Dr. Hinney, and we'll have him back a little bit later for our panel. But at this time, I'm going to move on. And really go on to what I think is sort of the next talk that's complementary to the previous two. But I really want to just emphasize what Dr. Robbins said earlier in terms of really the importance of high-quality clinical trials. It's the only way that we can, move our field forward for the benefit of our patients. And also just to highlight that, we can believe something to be true, but the proof is in, high-quality clinical trials. So really want to put a really strong emphasis on that. Seems to be moving on its own. Okay. So as I said, I'm going to, on this talk, I'm going to talk specifically about transoral surgery, primary transoral surgery and its role in de-escalating adjuvant therapy for HPV-related oropharyngeal squamous cell carcinoma. And the reason that I think that this is really, there's several reasons why I think this should be a good focus. One of which is the fact that HPV as the causal agent for a subset of head and neck cancers is really, you can't even underestimate how this has completely transformed, our field and for many of us, our careers. And it's still a growing group of patients. And so, in many centers, HPV is responsible for, somewhere around 80% or more of new oropharyngeal cancers. And this is important because there are, probably everyone knows by now, really remarkable, striking differences in both the typical demographic profile as well as the prognosis of HPV positive versus HPV negative oropharyngeal cancers. And so just to sort of review, compared to HPV negative oropharyngeal cancers, these patients often have little or no tobacco exposure. They tend to be of younger age. There is a male predominance. And particularly in areas like North America and Northern Europe, this has really become the main driver of disease for this population. So as I mentioned, why this is so important is because we know that these patients, stage for stage, have a better prognosis, improved survival, and better response to really any kind of treatment that we use. And so that leads to, but first off, though, that's not true for all of them. And so it's important to keep that in mind. And there have been a number of studies that sort of looked at, the factors that may portend a poor prognosis in HPV-positive cancers. And the main one here is if there's a concurrent history of smoking, and particularly more than 10 pack years, they still do better than HPV-negative oropharyngeal cancers, but not as good as the never smokers. And then those that have more advanced disease, such as T4 primary tumors, which are fairly unusual, but also bulky nodal disease also seems to be perhaps a marker for poor prognosis, particularly because these patients, clearly the ones that don't do well are those subset that develop distant disease, and bulky nodal disease may be portend that outcome. But the question that this leads to, obviously, in terms of, in general, the better prognosis that these patients have, is can you then, extrapolate and say, de-escalate their treatment? And there's a variety of ways, which we talked about already, of how you might do that. We may believe that's true, but really it's important to emphasize that for the most part, standard of care treatment is still indicated. And if you want to look at de-escalation, really, as I mentioned, there are actually now a number of clinical trials that are out there, and that's best done in that setting of clinical trials. So we mentioned already that there's a variety of ways that one could de-escalate treatment for oropharyngeal cancer specifically. I'm going to talk specifically about the use of minimally invasive surgery, transoral surgery, whether it's through robot or, as Dr. Hinney has shown so well, through transoral laser. That in itself is a de-escalation treatment, as Dr. Hinney showed in his initial slides, because compared to the conventional, more invasive approaches that require mandibulotomy and pharyngotomies, that transoral surgery, just in and of itself, represents a de-escalation in surgery. The other important point that was also mentioned by Dr. Hinney is this is a de-escalation because there are a subset of patients where surgery alone is curative. And so using a minimally invasive transoral approach as a sole treatment clearly is very good for those particular patients because, and I think this is borne out pretty well, surgery alone through a transoral approach for tonsil-based tongue cancers has minimal to long-term, no long-term morbidity. So the technique that I primarily use is with transoral robotic surgery, and I just wanted to show off our latest technology. The Da Vinci SP robot is the latest FDA-approved robot for TORS. TORS was first approved by the FDA about, I think, like 2009, 2010. But in 2019, the development of this new robot, which, in the past we'd always say, well, these robots were designed more for, transabdominal surgery and really weren't designed for the head and neck. But this one was actually designed with the cooperation of a lot of transoral robotic surgeons. And so SP stands for single port. And so as you can see, I'll just point out here, that it comes out as a single port. This part then goes in the mouth, and then it can then send out its arms to do your transoral robotic surgery. And so we got delivery of this in the end of 2020, right in the middle of the pandemic. And there's only a few. I know Mayo, you have one up there, and I think there's two within our banner system, one in Tucson. But this has been really a tremendous game changer in terms of our robotics program, particularly because, and this is not so much even necessarily for oropharyngeal surgery, but the new robot, we can really reach further down, and so we're able to do more laryngeal and even hypopharyngeal work with the SP robot. Oh yeah, okay. And so that's just kind of demonstrating here in this video that I got off of YouTube of showing how it works. And then an example on an actual patient. But the That's the camera arm you see up in the top left that now has a wristed control, and then up to 3 additional arms that can be used. And each of those now can actually be connected with cautery, so even the Maryland forceps is actually a bipolar. I don't necessarily always use all 3 of those additional arms when doing a surgery, but on the lower right there is an example of a right base of tongue cancer that I just highlighted just for illustration purposes. That's not actually what you get to see on the screen, but just showing the ability to, with a transoral approach, precisely excise a base of tongue tumor without having to do any pharyngotomy or lip split or mandibulotomy. The patients, for the most part, don't require tracheotomies, which we'll mention in a bit as I talk about some of the clinical trials, specifically the 2 orator trials. I usually do routinely put feeding tubes in them, but I let them eat right away, and just depending on the person, sometimes they can, sometimes do fine and go home on post-op day 1, and sometimes people take a little bit longer. But as is mentioned, the long-term feeding tube rate with regard to surgery alone is, in my hands it's 0, and I think that's pretty much what's been reported in the literature as well. So as I said, the numerous studies show that if you just look at surgery alone, transoral surgery, it has really negligible long-term toxicity. I just quoted one study, 96% of patients who were treated with transoral surgery alone said their swallowing is back to normal at 1 year. And the long-term toxicity of radiation and chemoradiation, I think is well recognized in terms of, really, everyone gets xerostomia, and close to everyone gets some degree of dysphagia. Obviously, some people do very well, but I think the idea here is that transoral surgery in itself has fairly minimal long-term toxicity. And so then the question really, which we'll talk about next, is then if you do that combined with those patients who go on to get adjuvant radiation therapy, how does that functional outcomes look like for those folks? Because of the reality is that, again, that's great for, Dr. Henry mentioned about 25% in general get treated with surgery alone, but that still means that it is true that the majority of patients under current treatment guidelines who get primary transoral surgery will still get adjuvant therapy, and some patients will get radiation and chemo, and that's, I think ideally something that we'd rather avoid. So this trial was mentioned, and again, this was not a large trial, but there was a lot of excitement about this study, and part of it is because historically it is very difficult to do randomized trials that involve surgery and a non-surgery treatment. It's for obvious reasons, it's challenging to get patients to sign up for a trial where they don't even know whether they're going to get surgery or not. It's a flip of a coin kind of thing. Most people are probably familiar with the VA larynx trial, which is one of the most well-known such studies in head and neck. That was 30 years ago. There was an RTOG-sponsored randomized clinical trial of TORS versus non-surgical treatment for HPV-negative oropharyngeal cancer, and that trial unfortunately did not accrue a single patient in 18 months and had to be closed. In Canada, they had an interesting situation because their equivalent of their FDA did not, at that time, had not approved TORS with the Da Vinci robot. And so a group who I actually know really well, the chair at the University of Western Ontario was a co-fellow of mine, but they designed a trial where they were going to, in a sense, funnel any Canadians that were interested in doing a study that might involve TORS into their center, and then they would randomize them into either TORS or conventional chemoradiation. And so that's why I said I think they drew from a few centers, but I think most of the surgeries were all done in the one center in Canada. So people were looking at this as really something that might, for once, have a randomized clinical trial comparing a surgical approach from a non-surgical approach. And Dr. Robbins already mentioned kind of the headline results, which were just published long-term results just last month. So to keep in mind that this is, I think this is the correct terminology, this is an intention to treat a trial. So patients with early T status, N0 to N2, HPV positive oropharyngeal cancers would be randomized either into the surgery or the non-surgery arm, and then they would undergo surgery, and then adjuvant treatment would be determined really based on standard criteria. And so in the surgery treatment arm, which included some that got surgery alone, some that got surgery plus radiation, and some that got surgery plus chemoradiation, while the overall survival was similar, which is what was expected and hypothesized, the swallowing outcomes as measured by the MD Anderson dysphagia index were actually higher or better in the radiation treatment arm compared to the TORS arm. But it did not meet clinically meaningful significance in that prior to the trial, they determined that a clinically meaningful significance would have to be at least 10-point difference, and that was not achieved. So the main conclusion was that there was no clinically meaningful quality of life difference between the radiation arm and the surgical arm. But I wanted to just sort of take a look and see how that result might have been surprising. And the first of which is that it was a small study, and 68 patients, 34 in each arm, which, like I said, is better than the one attempt previous to this to do a surgical arm where they got 0 accruals. So I mean, they got close to 70 patients, but it was really underpowered to be able to detect that clinically meaningful difference in quality of life. But I also wanted to mention that there were a couple things that were different about their surgical arm than most other studies have shown in this area. And one was mentioned is that they did have a postoperative hemorrhage that resulted in death. And so after that, they mandated tracheotomies for all their patients. And that's not typically done in most centers for TORS. Now, the question of how that might have affected their overall eventual swallowing outcomes, hard to say, but it's just to point out that there were some differences in the surgical arm. And then the postoperative hemorrhage rate that they reported was higher, about twice as high as what was reported in most other large series. I saw that there was one of the largest studies showed that the reported postoperative fatal hemorrhage rate for after oropharyngeal surgery by TORS is only 0.17%. So unfortunate, unlucky, but I think some of us have concerns about drawing too much from the reports of this surgical arms just because it differed from what others have experienced. And the other important point is that, and this makes sense in terms of when the trial was designed, but the idea here is, so they still use, in a sense, this was standard of care, in the sense that patients underwent a conventional oncologic surgical resection, and then based on standard of care criteria, they got adjuvant treatment that followed. And so this is a standard post-op dose of radiation therapy for 60 grade for those that met certain risk factors, and then cisplatin and a higher dose of radiation was added for those that had higher risk factors. So we're not really de-escalating the adjuvant therapy. We're just looking at, with TORS plus standard adjuvant therapy, do we get a clinically meaningful difference in quality of life? And so, some of the studies that have come since then, are moving a little bit more forward in that. And so, as strategy to de-escalate, surgery alone, I think clearly works well. But surgery, what about just using, in this case, a standard lower dose of adjuvant therapy versus concurrent chemoradiation is one approach. That was what was used in Orator 1. But can you go lower? And we already heard that in terms of the DART trial, in terms of actually de-escalating standard adjuvant therapy, reducing the dose of radiation, either eliminating chemotherapy or reducing the dose of chemotherapy. And so I think that's really where we're at. So in some sense, we've kind of moved beyond what was studied in Orator 1. And when we look at that, I think these are the two key questions to keep in mind as we evaluate trials. First off, obviously, you have to maintain the same ability to control the cancer as you did with conventional standard of care. So the hypothesis of all these is that is a non-inferiority of the experimental arm. But then, just as important is it meaningful in terms of functional outcome? And that's where, I think that's where we want to know the answer to that question, is that does lowering the adjuvant therapy, even lower than what was done with Orator 1, can that result in better functional outcomes? And just to mention that this is only one de-escalating strategy using surgery, and Dr. Robbins already mentioned the other ways that don't involve surgery. Same key questions would apply to those. And so these are some of the studies that have been done that uses transoral surgery and then does a lower than standard post-op adjuvant therapy based on certain criteria. So I'm not going to go in detail in all these trials, but I'm happy to provide my slides. As Dr. Chang was saying when he was going through his talk yesterday, I went through these so you don't have to, and I'm just going to hit the highlights of this. But this is a single institute, single arm trial, and the idea here is just looking at whether for these patients, you can take patients who you've determined that you think might need less than standard adjuvant therapy, giving 50 instead of 60 gray, but still doing the higher, sort of more standard adjuvant therapy for those that are low risk, and then showing, as they did at Mount Sinai, had similar progression, statistically similar progression-free survival across those three groups when you de-escalated. This is probably the most important one, so I'll spend a little bit more time on this one. This was a large 353 patients, multi-institutional trial, ECOG 3311. This one, where all patients were transorally treated, and then they then separated them into up to 4 arms. So those that had low risk, they didn't get any adjuvant therapy at all, just surgery. 2 and 3 are the most important because this is the group where they're really trying to show that they can safely reduce the amount of adjuvant therapy. So these patients clearly met criteria for adjuvant therapy, but then they randomized these into, this would be the standard 60 gray of adjuvant therapy, and then the experimental arm 2, got 50 gray. And the obvious question you might want to say when you do that, well, that's only 10 gray. Is that really enough to make a difference? And that's a good question. And we'll look at that, and certainly in the context of what Dr. Hinney just presented. But this is lower on that, I forget what you called it, but that curve that he showed that looked like that. And so that was the idea. And again, in a multi-center trial, sometimes you go for sort of more incremental goals. But this all comes down to how did this group did when you lowered the adjuvant radiation dose for TORS patients from 60 to 50 gray. Those that had higher risk factors after surgery, they got chemoradiation. And so across the 4 arms again, and this was also just presented just a few months ago, they got similar progression-free survivals across all of these arms. And so that's great. And so I think in a study like this, this is a practice-changing type of trial because clearly they showed that for this group of intermediate risk patients, which includes those with small ECE, so that's important in terms of they were included in this group, that you could safely lower what would have previously been the standard dose of adjuvant therapy to 50 gray. Now, when you look at it, this number, though, is a concern because I can tell you that when all patients were enrolled, the idea, the hope was that they would be able to go into one of these arms. But 113 is quite a large number, which ended up getting triple therapy. And so, that's a concern. The implication of that is, one, maybe we needed to do better risk assessment ahead of time. The other thing is there something that we can work with this? And so maybe in looking at this group, because there's always going to be these patients, can we do some future trials where we look at de-escalating treatment in this group too? So I think those are the kind of the key points from this trial. I'm not going to mention this because Dr. Hinney already went over it. I'm just going to mention one more, and this is a similar concept to what the folks did at Mayo, and that is the other way to de-escalate adjuvant therapy is the avoidance of radiation therapy to the resected primary tumor site, which Dr. Hinney so nicely explained. One difference, though, is that they still, in this group, gave the standard 60 gray to the nodal sites. And so, interesting to think about that is because the nodal sites are pretty close in general to the primary tumor site, that they still said even by avoiding it, they got about 36 gray that was, on average, a maximum dose to the primary tumor site. This was really just sort of a pilot study to try to use for future studies, but they certainly showed that this was safe to do that. And then in the last minute, I'm just going to mention some of the trials that are still in progress that have tried to take, in a sense, a step further from the ECOG 3311 study. This is by WashU. I think this was mentioned earlier. But again, you can see how they're now taking, instead of just the 50 gray, they're going down to 42 gray. And then even, and I looked this over, so they've kind of changed the definition of here. So don't used these same definitions to look at the ECOG 3311. But really, in a sense, this was the high-risk group in 3311. And in some of those folks, they're going to now still take down a lower dose of adjuvant therapy and a single dose of cisplatin. And then we'll see how they do in terms of oncologic and functional outcomes. This is a European study, and this is an example where, so similar to 3311, they're going to look at intermediate risk and lower it to 50. But that high-risk group, they're going to go and look at whether they can safely omit chemotherapy in that group. So again, I think that'll be an important study that we'll look forward to. And then in the last minute, I wanted to mention the ORATOR 2 trial, which was mentioned by Dr. Robbins. And so here, in the next phase of their initial trial, they're looking at both de-escalation of primary radiotherapy. So instead of the standard definitive doses, they're doing it at 60 gray. And then they're in the surgical arm, they are similarly kind of following the model of the ECOG 3311. But what was different from what they did in the first ORATOR 1, they're going to take it down to 50 gray in a randomized subset of those patients. But as was already mentioned, the study was actually halted due to excess mortality. It's a little bit hard to explain, but this is really kind of an unfortunate outcome in terms of not being able to complete the study. But I think it does somewhat call into question their preliminary conclusions, which was that the radiation arm was superior in terms of control. But they did have two deaths out of their 30 patients. One was, in fact, their second postoperative hemorrhage fatality in a TORS patient. And then they had this unusual patient who, during their radiation therapy, developed a fatal case of cervical osteomyelitis, which they thought might have been related to the surgical defect from the TORS. So, just hard to say how that might have impacted their preliminary conclusions, but just to point out that there were some differences in their surgical arm from what we typically see. So in conclusion, the role of TORS in de-escalating adjuvant therapy, it does appear to be safe by a number of both single and multi-institutional recent trials. And we're still looking forward to what will be the optimal strategy. Really, really exciting results that Dr. Hinney showed about what they're doing at Mayo, but trying to figure out what that strategy for de-escalating adjuvant therapy will be determined through pending and future clinical trials. So thank you so much. And so now for our last speaker for the morning, I'm pleased to introduce again my colleague, Dr. Audrey Baker, who will be speaking to us about updates in surgical management of melanoma. Thank you, Audrey.
Hi, thanks for having me. One last quick talk before our panel and lunch. So if you're hungry, don't worry. These gross pictures will curb your appetite. We've heard a lot about immunotherapy and radiation and some very fancy lasers and robots to address head and neck cancer. But today I'm going to talk about old-fashioned surgery. The tools we use in what I do are the same: a knife, a rag, a suction, some sutures, but the indications for doing surgery have really drastically changed. And part of that is because new techniques in immunotherapy has come to the forefront, and part of that is because we understand the disease process a bit better. So without further ado, we want to talk about melanoma and its incidence. This is the fastest rising incidence in nations who have predominantly Caucasian populations. So there are a lot of white folks out there enjoying the sunshine. And good for them, I guess, good for me, because I have a lot of business here in Arizona. It can also, there are some that postulate that with climate change and huge holes under the ozone layer, we will continue to see an increase in melanoma. But it's not all biologically driven. As you can see, the incidence has been steadily increasing since the early 90s, but you can see the death rate is almost starting to decrease, or at least flat. And this is the 5-year survival rate for patients with melanoma, disease-specific survival. And as you can see, survival is slowly increasing, death is slowly decreasing, even though the incidence of melanoma is increasing. So there are some different theories about why this is happening. One is that there has been a diagnostic drift. We are catching earlier melanomas and lumping them into the whole melanoma group as documented by the SEER database. So we are including patients that are going to do better because we're catching them earlier. But there's also been such wonderful advances on the other side of the spectrum with patients with highly advanced tumors that are getting immunotherapy agents and turning these once fatal prognoses into just chronic disease like diabetes or hypertension. So it's pretty amazing. As head and neck surgeons, there is a lot of skin cancer that goes on in the head and neck. So somebody might be coming to see you for cerumen impaction or for tinnitus. I mean, not me. I don't see tinnitus. By choice. I see a lot of other painful things, but tinnitus I have given up. But you know, during your thorough head and neck examination, you might find a skin cancer because a lot of them are up there. 65% of squamous cell carcinomas in men are in the head and neck, and nearly 30% of all melanomas arise within the head and neck. So we are relevant as head and neck surgeon in not only the treatment of cutaneous malignancies of the head and neck, but also the initial diagnosis. The surgical goals for melanoma are threefold. One, in diagnosis. So, you know, to really get a good look at the melanoma, you have to do a full depth punch biopsy. Shave biopsies for pigmented lesions are not adequate because we are staging the primary tumor based on Breslow depth. So that is the first step, and that can be done by a surgeon, that can be done by a dermatologist. Some primary care physicians in the community will also get very good at punch biopsies living in Arizona. The second goal of surgery for melanoma is treatment and reconstruction. So this is a patient who came to me, we'll talk about him a little bit later, with a very advanced melanoma that we had to both surgically resect and reconstruct. You know, some would argue even if he had distant metastatic disease, it's probably not like super cool to just leave him with that thing on his face. So, you know, palliative surgery is a big deal for melanoma because you can really improve a patient's quality of life even if they only have 6 to 9 months left to live. And then finally, pathologic staging is important. And, you know, we'll talk in a little bit about the sentinel lymph node and the status of the regional lymph nodes being the single most important prognostic indicator in melanoma and its disease progress. So here you see a sentinel lymph node. There's some blue dye here, which I don't use anymore. But that is the third part of why old-fashioned surgery is still very important. This is a glimpse into my clinic. I see a lot of bald heads with a lot of weird things. I can't tell what's good and what's bad. I can't tell what's squamous cell carcinoma and what's melanoma, what's a nothing biopsy and what's a something biopsy. I rely very heavily on the pathologists in our community to tell me what I have to do. Is this a bad melanoma where I have to like take their whole head off and give them immunotherapy? Or is this like an okay melanoma that maybe I can just zip out in clinic and put a little cream on and cross my fingers? So the biopsy is your friend. Surgery for primary melanoma has not changed over the last 20 to 25 years. So small melanomas, meaning thin melanomas, melanoma in situ, the recommended excision margin is 0.5 to 1 centimeter. This can be difficult in the head and neck, not because you don't have enough room, but because melanoma in situ in the head and neck often is the result of field cancerization. They didn't just get UV damage right in this spot. It's on the whole left side of the face. I say left side of the face because it's often on the left side because patients are driving throughout their entire lifetime and getting all of that UV through the windshield. For T1 melanomas, we recommend 1 centimeter excision margins. T2 melanomas, which is 1 to 2 millimeter of Breslow depth. We recommend 1 to 2 centimeter margins. There are some parts of the body where it's very easy to take a 2 centimeter margin, but obviously some parts of the body it's not. And for really large melanomas, it hasn't been shown to increase overall survival to go bigger than 2 centimeters. About 25 years ago, a paper came out looking at thin versus thick excision margins, and at the time, it was common to use 4 centimeter margins, but that has fallen out of fashion as those extra 2 centimeters didn't matter so much. So I put these just as kind of an example of what kind of margins you can and can't take in the head and neck. Sometimes you can get all the way around a T1 lesion, but it leaves a huge defect. And you can either reconstruct it yourself or call one of your colleagues to help. But despite the fact that she had a very thin melanoma, even 0.5 to 1 centimeter margins in the nasal ala can cause a big problem. This guy had a huge melanoma, and you can go all the way around it because it's his chin, and we reconstructed him with a local flap. And this lady has a terrible T4 melanoma, but you can't take 2 centimeter margins. They don't make a lot of sense because, I don't know, do you take like the eyeball or the orbital rim? So, you know, you do the best you can. And that's what we say in preschool and in melanoma. You do the best you can. You follow the guidelines to the best of your ability. You're not going to take out an eyeball for a T4 melanoma, especially in a patient who you know is going to get immunotherapy afterwards. Melanoma in situ is a sneaky disease. There are a lot of people trying to treat it all at once. Surgery is still the mainstay for treatment as of now. You know, it can be very difficult to tell where the lesion starts and where the lesion ends. So I would highly recommend, if you're planning to take out a melanoma in situ that doesn't have very discrete borders, to do some mapping biopsies in clinic. And you can either do these just by punch biopsies. I always take a picture because sometimes they heal so well and I can't find my biopsy when I go to excise the lesion. And that is one way of clearing the margins. You can also do something called a square technique. You can either do this in the office yourself, or there are some dermatologists in the community. And what they're doing is taking a strip all around the area and looking at the complete circumferential pathologic margin of that tumor. So they've cleared it before you even go to the operating room. This lady had a very large defect, actually, and was reconstructed with a cervical advancement flap. On the horizon, most surgeons want to be a part of the melanoma in situ party, and I'm so glad because I think they're going to be a lot better at it. You know, previously, the stains that we were using to assess melanoma took, 24 to 48 hours. So most surgeons were doing this thing called slow Mohs, which wasn't Mohs at all, basically. They were doing standard pathologic assessment and bread loafing the tumors, but they had a friend who was a pathologist who was doing the pathology for them. And they would do the original resection, send the patient home for 2 days, and have them come back. But Mark 1 is a stain that can be done under frozen section, and it's going to be, I'm hopeful, revolutionary for melanoma in situ disease, because I think this will really help us define where the lesion is and where the lesion isn't. And I'm also hopeful that we'll look back at the previous slide and look at like the little punch biopsies and the square technique is completely archaic. Most surgeons, they're not just checking the margins as they go. They're not bread loafing the specimens, so they don't care about the main tumor. They're just looking at all of the margins. So it's really a complete evaluation. Here you can see this is a sneaky tumor. This is an adnexal structure here, and you can see the melanoma is highlighted by this MART1 staining and has complete adnexal extension. And that's very important to see because in patients with non-surgical management or unresectable disease, meaning This woman came to me, and actually, I don't know if you can see it, but she has a scar going from here to here. She has a little standing cutaneous deformity. She came to me about 4 years ago with melanoma in situ. I did mapping biopsies and cleared it in the clinic, and then I took her to the operating room 4 years ago. She recently popped back up into my clinic, because you can see this is about 3 centimeters away, a well-healed biopsy site, another well-healed biopsy site up here, and I think you can see this is all melanoma in situ. Dermoscopy showed a lesion here, a lesion here. So her entire cheek has melanoma in situ. She was not interested in a complete cheek resection, which I agreed with. I mean, those are a lot of fun to do. But in her case, for in situ disease, we tried something different. Aldera is local immune therapy. It's a cream that patients can use. It activates the local immune response by various pathways. It combines programmed cell death within the affected keratinocytes and melanocytes. It also activates antigen-presenting cells, which are the dendrocytes, dendritic cells within the basement membrane of the skin. So it attacks multiple areas of the local inflammatory response that can help in melanoma in situ lesions. Now, if you remember that previous slide with that deep adnexal extension, you can imagine that if you're applying a topical cream and you're wanting it to get into the hair follicles, it's not going to go there. So if you see a patient with unresectable disease and deep adnexal extension, you really have to think about a different option other than imiquimod. As a side note, imiquimod was originally designed in the late 90s to treat genital warts. And it worked so well that then they looked for all sorts of other diseases they could treat. It's been amazing for melanoma in situ lesions as well as atypical junctional melanocytic hypertrophy, which is a very long pathologic name for like pre-melanoma in situ. And I had a patient, she was about 45, and she came to my clinic, and she had a very large AGMH, so she didn't have melanoma in situ yet. And I mentioned, there's this treatment you can use, it's called Aldera, and her eyes lit up. She's like, oh yeah, I used that in college. And I'm thinking, ooh, that's rough. I want to remind you that the rates of occult metastatic disease are not zero. So even in a patient with a small little tumor, they may have up to a 20% rate of occult metastatic disease for melanoma. This is a patient with a very discrete but horrible T4 melanoma. This is a patient with squamous cell carcinoma. They have a smaller rate of metastatic disease, which is a different talk altogether. And even in basal cell carcinoma, most practitioners think that it's probably not the basal part of the carcinoma that metastasizes, but sometimes these pathologic transformations to basosquame can then be deeply invasive into the regional lymph nodes. So this is the patient we briefly talked about before. He had a 12 millimeter Breslow depth, and that was probably not even. I mean, his tumor was very thick. We took him to the operating room for a wide local excision and a sentinel lymph node biopsy. He had a T4B, meaning it was also ulcerated. He did not have a positive sentinel lymph node, so he had an N0, and he had a PET scan which showed no distant metastatic disease. So he was staged as a stage 2C. And I want to bring your attention to this tiny little biopsy site with no pigmentation. This is a patient who came to me who had a 1.2 millimeter melanoma, but he had microsatellites found on the wide local excision. Now, a microsatellite is defined as a small nest of melanoma that's some distance away from your primary tumor, separated by either collagen or fat. Now, there's no way we would have known that had we not excised the tumor and done complete pathologic assessment throughout the entire block. He also had a negative sentinel lymph node biopsy, but the presence of a microsatellite within the primary tumor automatically upstages you to N1C. And this patient is a stage 3B. So looking at these patients at first blush, you'd think this guy, man, he's really in trouble. But it's actually this guy who has an occult, scary tumor up there that has already figured out how to stick itself into the local lymphatic system. So of stage 3 disease in melanoma, now these are patients with regional metastatic spread. So these are either a positive sentinel lymph node, multiple positive sentinel lymph nodes, and this is where you get into microsatellitosis or greater than 4 positive sentinel lymph nodes. Now, there's lots of ways you can be a stage 3 melanoma, but I want to highlight that all of these patients, in some way or another, could have a clinically negative neck. So patients could come to you with a well-healed biopsy site and with nothing on physical examination, and they could still have a 24% 10-year disease-free survival curve. So pathologic examination of the tissue and the regional lymph nodes is really important in prognostic information for your patients. How do you treat the N0 neck? Will early treatment of those regional lymph node basins in the absence of clinical metastatic disease, will that improve overall survival? Like, if you catch it early, is it going to help your patient? So how do we best address the N0 neck? There's been a few studies to look at this. The MSLT1, this was published in the early 2000s, and what they did is they looked at the difference between observation, wide local excision alone, and wide local excision and a sentinel lymph node biopsy. And though the two arms showed no difference in overall survival, which some people say, well, see, now you don't do a sentinel lymph node biopsy because the study didn't show any difference in your two groups. Most people understand that over 80% of patients didn't need any sentinel lymph node identification anyway because they didn't have clinical disease in the neck. However, if you look at the subgroup analysis of only patients who had disease in the neck, so what we're looking at here is either patients with a positive sentinel lymph node biopsy or patients who popped up with a lymph node. So this is patients with a neck lymph node or clinically positive disease. And those two curves are vastly different. So even though looking at all comers, sentinel lymph node biopsy versus excision alone, you didn't see an overall survival benefit, you do see it in the patients who need it. So when you identify patients with microscopic disease early on, they do better than if you wait until they grow a neck lump. So how do you look for it? We use preoperative lymphoscintigraphy. This is an old-fashioned plain film, which I still use and love. Everybody gets SPECT CTs now, which I do as well, but I don't know. Maybe I'm just old-fashioned. This is the primary site, and there are the lymph nodes. And then you go to the operating room. You use your gamma probe. You only make an incision where the gamma probe tells you to make the incision. I used to use blue dye as just preoperatively, but then I tattooed a few ears, so I don't use blue dye anymore. Blue dye is really helpful in the trunk and extremity melanoma. The lymph nodes within the axilla and with the groin really take up the blue dye, but most people have not found blue dye to be as effective in the head and neck. This is the blue dye staining I had showed you before. This is really nice. You can see the afferent lymphatic channel going into the lymph node itself. But we don't usually see that anymore. The next decision tree comes. Okay, so now we have a positive sentinel lymph node. Do we do a completion neck dissection? And this used to be the default answer of yes. Anyone with positive sentinel lymph node biopsy underwent completion neck dissection. But that has changed. The MSLT2 trial, which was published in 2012, looked at only patients with positive sentinel lymph nodes, and they randomized these patients to either observation via ultrasound 3 to 4 times a year, or completion neck dissection. And as you can see, there is no separation of these curves. So completion neck dissection or completion lymphadenectomy, as this was looking at both trunk, extremity, and head and neck melanomas, did not show a difference in overall survival. And because of this, people in the community have started to shy away from completion lymphadenectomy. There was a second study out of Germany that looked at the same thing, and they re-demonstrated the same results. You see, these curves are all smacked together. So it didn't seem that completion lymphadenectomy at first blush was going to be helpful. However, this is a very controversial issue in head and neck surgery circles. And that is because, first of all, in this German study, they didn't look at any head and neck melanoma. This was only trunk and extremity. And in the previous study, in the MSLT2 trial, they only had about 20% of melanoma that was represented was head and neck. The other main problem is that a completion lymphadenectomy in the axilla or in the groin has a 30% chance of lymphedema, which is a terrible outcome. And we don't see that a lot in the head and neck. You know, it's hard to say to a group of surgeons who do a neck dissection, which is like the most fun operation there is in our field. You know, there's great anatomy, there's not a lot of morbidity, to say stop doing that because your patients have unnecessary complications. Well, you can get a lot of information out of a completion neck dissection. It gives us really great prognostic information about non-sentinel positive lymph nodes. Those patients may be eligible for further trial studies and further adjuvant therapy. And also, we don't have the complication rate that general surgeons do in the axilla or the groin. We've all seen patients after radiation, they have their little turkey gobbler. But after, you know, after just surgery in the neck, that lymphedema doesn't usually happen. So this is a very controversial issue. There was recently a survey of head and neck surgeons that was not completed because I'm not sure anybody wanted to admit what they were doing. I will say at the University of Arizona, we are not routinely doing completion lymphadenectomies, although I do have frank discussions with my patients that what that means is they're going to need a very close follow-up, both with clinical examination and radiologic examination. So in summary, addressing the neck and melanoma, for T1 lesions, ignore the neck. You might have a lot of other stuff to do. A lot of these lesions are big and they come back a lot. So just forget about the neck, it's all good. For T1B and above, do a sentinel lymph node biopsy. If the lymph node comes back positive, most people would say don't complete the neck dissection. However, that is a highly controversial statement. And finally, if you have a patient with a grossly positive disease, you can see this patient has a neck node, you should do a neck dissection. If you have a patient who has a positive lymph node seen on PET-CT, do a neck dissection. If you have a patient who has a positive FNA, do a neck dissection. Surgery is still the best curative treatment for melanoma. So if you know there is melanoma in the neck, in the regional lymph nodes, if you can, take it out. One last slide. I want to talk a little bit about Castle testing. This is becoming very popular in dermatology circles. What Castle testing is a commercially available genetic profile test that you can send on the primary tumor. However, this was developed and trained in very high-risk patients and has not yet been validated in melanoma populations at large. So what this test will say is yes, you have a really high chance of metastatic disease, or no, you don't have a high chance of metastatic disease. And there are some dermatologists who are using this in lieu of sentinel lymph node biopsy, and I would be very wary of that. Sentinel lymph node biopsy gives you good prognostic information, not only of the size of the metastatic lesion, but of the surrounding lymph nodes. And you know, some patients are having resections without evidence of in-transit disease. And as you saw before, that's also a really important pathologic feature. So I thank you for your time. This is my team. I couldn't do it without them. Melanoma is a multidisciplinary treatment approach at the University of Arizona, and I'm proud to be a part of it. Thank you so much.
So we can have our head and neck panelists come up here. So I thought it'd be a little fun to make this a bit like how we do every week in our multidisciplinary head and neck tumor board. And so we've taken a couple cases, recent cases that we had, and the first case is going to be presented by Dr. Borelli.
Okay, yeah, so this was a case, I want to say about a year ago now. So it's a 26-year-old man. He had about a 3-month history of left tongue soreness and ear pain. He presented to an outside ENT. This is up in Phoenix, and he had a 2-centimeter lateral tongue lesion. It was biopsied as squamous cell carcinoma, so he was recommended to undergo surgery. He had a preoperative PET CT, and it showed some avidity in the left tongue and some mild avidity in the left level 2 node, but no other regional or distant disease. So very appropriately recommended a left partial glossectomy, left neck dissection. During the surgery, the surgeon sent frozen sections. They all returned negative, and everything went well. Final pathology showed a 2.2 centimeter tumor with a depth of 7 millimeters. And the anterior inferior margin was positive, but all other margins were close, less than 1 millimeter. All the nodes were negative, so this was staged as a T2 and 0. But because of that margin, that focal positivity, that anterior inferior margin, the patient underwent a re-resection of the peripheral and the deep margins. And fortunately, all of those margins returned negative. But due to some of that question of the margin status, the patient came to actually I don't know if they saw one of us directly, but wanted our opinion. And so we actually had the same conversation at our tumor board in terms of what we would offer this patient for adjuvant therapy. So again, T2 and 0. Initial margins on the first resection were positive, but then did a re-resection and it was negative. So questions for the tumor board? How do you overall manage positive frozen sections? Do you re-resect it? Do you then consider it negative if your final resection margin was negative? How about we just go down the line and see what you all do? Dr. Baker.
We have a hard time trusting frozen section analysis. My mentor, Greg Wolf, said you never make a decision based on frozen section in the operating room. And I didn't know what he meant. But now I know what he means. It's really hard to cut somebody's whole face off based on a frozen section in the operating room. I think a negative frozen section makes you feel good, but I never really know what to do with a positive frozen section. I do re-resect and send some final margins, but I think it's very difficult to trust a quick and dirty look.
I have a question about the re-resection. Was there any residual tumor found in that?
No, none.
That's very typical. And we see this a lot, particularly dentist finds a tumor, sends the patient to an oral surgeon friend who excises it, and the margins are positive everywhere, and the patient shows up with a well-healed wound and nothing to see or feel, and then you don't know how big an operation to do. But, I mean, this is you have margins that are clear and nodes that are pathologically negative, and a 26-year-old guy, and the long-term consequences of radiating a guy that young are not insignificant. I'm eager to hear what the fellow to my right has to say, but I suspect that our multidisciplinary tumor conference would recommend close follow-up and no adjuvant treatment in this.
Well, we're like-minded. So I actually talked to this guy and talked to him about radiation and the consequences of radiation, what that might look like down the line. Ultimately, I actually called his surgeon even and went over the pathology and what they felt. Because I think, at least from a radiation oncologist perspective, to talk to the surgeons it helps me a lot. So, I mean, Sheethal presented some data earlier about when the frozen, or about margin, when you have to go back in and get them and what that does prognostically, if it's positive and then you get a negative. And, it's not very clear, but, ultimately we talked to him, and because of everything else had been negative, there was no residual disease, no disease in the neck, we did elect to observe.
Yeah, so I would say I have a similar experience with Dr. Hinney in these scenarios in terms of when you do go back, usually there's nothing found, but it is a very challenging and frustrating situation. I think it does. There also is a factor of in terms of I think there's two different types of frozen sections that you encounter. I know how I typically approach tumors in terms of getting as in terms of the principles that Dr. Borelli was actually talking in his talk of getting a minimum of 1 centimeter clinical margins around the tumor. And so when I've done that, I mean those frozen sections are something that I think is often a sign. It's a sign of a more aggressive type tumor. I know from our pathology colleagues, they talk about how do the borders of the tumor look, and in some cases they're very clean borders, and sometimes there's a more infiltrated pattern. I wish I was a pathologist to know that I'm blanking on the name of the different patterns that they'll see there. But oftentimes the frozen section, if it's evidence of that, then it's really a marker of having more aggressive disease, and that may be a case where you would be more inclined to give adjuvant therapy. On the other hand, if the frozen section is, if the margins are positive because the resection was simply not adequate, that's a different scenario.
Yeah, so I think that's an important distinction in that a tumor that has a positive margin doesn't necessarily indicate the technical ability to get around the tumor, and oftentimes it's just a marker of aggressive disease. And so that's why I think this is an important question, in that if you have a positive margin, is the answer just going wider on the margin? Is that really going to clear that disease? And so I think it's an important question. A frozen section being positive and clearing it on your final, you don't really necessarily meet any of the indications for adjuvant therapy. And so in this case, we did not offer adjuvant therapy, but I think it's important to understand that perhaps there's something different about tumors like this, where if you're looking at it and you're able to grossly clear it, but yet on microscopic analysis there's extension of tumor, there's something a little bit more worrisome about this type of tumor.
Could I make another comment?
Yes.
Not to beat a dead horse, but the reason perhaps that positive margins are so dangerous, whether you fix them right then at the frozen section, more ideal, or come back later, is that the severed muscle can carry microscopic disease well below the surface of the original wound. So you cut your Achilles tendon, and then you find it mid-calf. I mean, muscles shorten dramatically. And in the tongue, there are radially oriented muscle fibers that when they shorten, make the tongue extend. And there are animals that can stick their tongue out 10 times their body length. So those radially oriented muscles, if you sever it, a little bit of tumor is left that can contract well under the surface. And perhaps that's, the reason that this is such a bad prognosticator to have a positive margin, both initially and especially if you have to chase it again and again.
Yeah, so that leads to my next question. This is, hopefully not a common occurrence, but if you have a positive margin, what is your typical strategy? Is it something, like you said, if there's scar tissue there, it's hard to determine exactly where your positive margin is. How do you approach that situation where you know that the final pathology demonstrates a focal positive margin, maybe in one spot or two spots? Do you try to resect it, or at that point, do you consider adjuvant therapy?
So, I think, just to be clear, I think what we're all saying is positive margins are bad, because it is very difficult, even at the same operation with a frozen section, to know that you really resected that area. So you really, and that was I really like the description Dr. Hinney gave in terms of why that is, but and specifically in the tongue, in the deep margin, realistically thinking that you're going to get out wherever the frozen section was and re-resect it, I think a lot of times you're probably fooling yourself. So avoid it in the first place is the best strategy.
Yeah, it's very challenging, I think, to go back in and re-resect a margin that's positive unless you know exactly where it is, because oftentimes it comes back negative, and it's hopefully something you try to avoid in the first place. So a question for Dr. Robbins. You had this discussion with this 26-year-old, and you talked to him about the possibility of adjuvant therapy. What are your concerns about radiation therapy, chemoradiation therapy in this young individual?
Yeah, so I mean, he's a young guy and he's otherwise very healthy. So, without this malignancy, he may live for a very long time. So, when you have to weigh the risks and the benefits of the radiation. So with the radiation, he's going to have dry mouth, which is going to put him at risk for dental problems. Dental problems can lead to radiation necrosis because he'll get a fairly high dose to his mouth. He's going to have secondary malignancy complications potentially, if he's living 15 to 20 years down the road, which we would assume that he would. So all these things are considerations when talking to patients about radiation and chemotherapy, because you're doing something that may take care of something right now, but 15, 20 years down the road, both of those things, the chemo and the radiation, can have other complications that he'll have to deal with.
Yeah, so it's certainly not an easy decision to just say, yeah, go ahead and radiate this patient, because he's so young and has a lot of potential side effects from it. So that's what we discussed at our tumor board. The final margin was cleared. Dr. Robbins talked to the surgeon about it. We looked at the pathology slides ourselves, and we didn't really see any indication for adjuvant therapy. 6 months later, this patient began having return of tongue pain and ear pain. It was initially thought to be dental and had a tooth extracted, but the pain persisted. I saw this patient for this continued pain, and on my exam, there was a 1 to 2 millimeter superficial ulcer within the lateral tongue scar bed. There was a submucosal nodule that was just deep to that ulcer, and that was about 1 centimeter. There was a separate submucosal nodule that was, again, deep to the scar bed, but posterior to the first nodule. I did a pretty aggressive in-clinic punch biopsy. He said it was one of the most painful things he underwent, and despite that, the biopsy itself just showed some inflammation and fibrosis, but no malignancy. I took him to the OR. I was convinced that he had a cancer. Took him to the OR and did a much deeper biopsy and proved that it was invasive squamous cell carcinoma. Got a CT neck and a chest, which you can see here. Essentially, I'm not sure if you can see it well on the projector here, but there's a enhancing mass in the left tongue. It approaches about the midline. Again, he's 26. He works in Secret Service. He obviously values his quality of life and his function. He wants to be able to speak and swallow. How do you counsel a young patient like this in terms of what to expect from the treatment? What do you think he needs? What would you offer him in terms of treatment? Why don't we just go down the line again?
One thing I'd like to add is in the beginning of his recurrence, I think that underscores the importance of very close follow-up with oral cavity cancers. For the first year, I usually follow patients every 4 to 6 months. Every 4 to 6 weeks. We get real sick of each other, but I like to look and feel. I like to talk to them about their symptoms. And Dr. Borelli didn't believe his first biopsy that was negative. He took him to the OR for a second biopsy. I have a feeling if the patient came to Dr. Borelli and said I had ear pain, he wouldn't have sent him down the rabbit hole of getting a tooth extracted either. I have a feeling that, had he been seen originally for ear pain by an otolaryngologist, that would have been caught then. So I think that underscores just the importance of very close clinical follow-up, especially within the first 1 to 2 years of any oral cavity carcinoma.
So backing up, at the initial encounter with a patient, I like to explore 2 things. So number 1, why did this young guy get this in the first place? Oh, and second, well, what are we going to do to fix it? And it's easy to just go right to number 2. But Is he a smoker?
He is not a smoker, no.
Chews tobacco?
No, yeah, no risk factors at all.
Because to develop a cancer, you generally need some sort of source for chronic inflammation. A broken tooth that's sharp, that's poking something all the time. I've seen a teenage girl get a lateral tongue cancer because her braces continually picked at it for 2 years. I mean, you pick a sore long enough, you can make it malignant. Even folks that have dental fillings, if it's a metal that makes their skin break out, nickel's common, and you put that in somebody's teeth and leave it there for 25 years, the chronic inflammation from that may be a risk factor for cancer. So it's important to explore all of those things so that you don't leave a mitigating factor unattended just because you're focused on number 2. But this fellow clearly needs a big operation now, and he's going to need a neck dissection, and he's going to need adjuvant treatment. He'll need a reconstruction. And adjuvant treatment, because of the depth of invasion and it's recurrent, that's another reason to use your friendly neighborhood radiation oncologist. So yeah, this sadly is all too common, and this guy's in trouble. So we didn't ask about HPV, which is probably not particularly meaningful, but it'd be nice to know because down the road, or in the adjuvant setting, you may want to think about immunotherapeutic tools as well in this young man. He's in trouble.
Yeah, I mean, that's a good question. Do you guys test routinely for HPV in non-oropharynx subsites?
Yes.
Yeah, I'm not sure that this was ever tested for HPV. There was some report of saying that maybe it was thought to be HPV related, but I think most of the data, at least that we have currently, doesn't suggest that if you find a P16 positivity in an oral cavity subsite, that it confers a survival advantage. But I think it is an interesting focus of future research in these, obviously subset of patients who have no other risk factors, what could be driving their carcinogenesis. Any other thoughts about treatment options? I think it's fairly straightforward. I mean, this kid is in trouble. So we offered him a left hemiglossectomy, a left neck dissection. We did a forearm free flap. It was a 4-centimeter tumor. Depth of invasion was 25 millimeters. He had multifocal PNI. He had a focally positive margin. The frozens were negative. Beyond that, he had no lymph nodes that were positive. So he was T3N0. Now, what do we do in terms of adjuvant treatment?
Yeah, so the question is now quite a bit different. I mean, his pathological features are much worse. This is a recurrent tumor. The worry about something that's going to happen in 15 or 20 years is out the window. We're focusing on right now and taking care of it. So certainly this guy needs adjuvant radiation therapy. He's got a lot of risk factors with the PNI and otherwise, and he's very young. So I think you could even escalate the discussion to what are the benefits of chemotherapy in this case because of the rapid rapidity of the recurrence of multifocal PNI, the depth of invasion. We're going to have a hard time getting ahead of this one, I think.
Yeah, and I just maybe just to step back for a moment and just kind of make some key points. I mean, the question of HPV, it would certainly say, because I don't know if we tested or not, but I mean, he doesn't fit the typical profile of an HPV positive case in the sense that this is oral cavity, and he's 26, which is actually pretty young in terms of if we think about the typical thoughts on pathophysiology of infection and of the HPV, and then a latency period of, in many cases, a couple decades. Most of those patients are usually in their 40s, and 50s is kind of a typical age group. And then, like I said, this being clearly in the oral tongue, and to emphasize that, we're here with 3 surgeons in the radiation oncology, but certainly the consensus, oral cavity, and specifically oral tongue, the primary preferred initial treatment is surgery. This would be very different, HPV or not, if it was base of tongue or tonsils. So I just wanted to highlight those points.
Yeah, so T3N0, we obviously wanted to throw the book at him and give him as much therapy as possible, intensify it. Because again, the focally positive margin, PNI, depth of invasion, he was young, this was a recurrence. He got chemoradiation therapy with cisplatin. He had his post-treatment PET CT and it looked good. He's back to work. He's currently tolerating a regular diet. We just removed his PEG tube recently. I'm still really worried about him. You know, I'm following him every single month, and for every little discomfort that he has, we're going to biopsy it, and you know, I think he has an extremely high risk of recurrence going forward. Any other thoughts about this case?
You know, these are always memorable cases because they're so young, and we had a discussion about this recently in tumor board. Hopefully he doesn't fall into a category, which I know we've all had in our careers, of these young folks that have these just extremely aggressive oral cavity cancers. I think one concern is, you know, regardless of what we want to say or not say about the initial surgery and the positive margins, but you know, we went from clinically undetectable to a very large recurrence in just a matter of a few months, and so that's a concerning sign. And so you know, I think in terms of his most recent salvage surgery and adjuvant therapy, you know, I think that makes sense, and you know, he certainly warrants close follow-up.
Okay, I don't know if we have enough time for a second case. Or?
I have a feeling people are probably hungry, and I think there's some nice lunches next door. So why don't we wrap it up? If anyone has any questions, certainly feel free to come down here and ask any of the panelists. But otherwise, we'll end things for today. There's lunch next door. Otherwise, enjoy your afternoon. A reminder, if you sign up for the golf, they're meeting actually in a few minutes. And if you're signed up for the hike, I think Sonia will be meeting everyone in front of the hotel at 1:45. Otherwise, I'll see everyone tomorrow morning.
Well, it's nice meeting you, Dr. Haney.
Nice meeting you.
So Samir Patel, he was my attending back when I was in training. So.